Good morning, ladies and gentlemen. It's a really great pleasure to organize such an excellent conference in the midst of COVID-19. After a long time, we are going to meet so many psychiatrists over here with full precaution. Credit goes to definitely the organizing committee led by the organizing secretary Rajarshi Ghotakurta and the organizing chairman all of us. Fully supported by we are really proud of it. I don't want to take much time to any top priority. So my dear friends, be with us either virtually or physically, and I wish all the best for the program. Thank you very much to all of you to be with us. Thank you so much.
A very sunny and good morning to all the delegates, faculties, chairpersons, the entire organizing committee of Psycon 2020. For the first time in the history of West Bengal and the history of India, in this pandemic situation, West Bengal State Branch is conducting a both virtual and physical platform-based program of Psycon 2020, which is the joint annual amalgamated conference of WB-IIPP and WB-IPS under the aegis of Tamralitto Midnapur branch, which is a newly formed branch and was formed last year on 23rd of September, that is just 1 year ago, from in Port Blair, in CZIP's Port Blair, which was held by Dr. Amit Prat Joshi and Dr. Tufan Pati. We will have amongst us the other members who will be joining shortly, and we have sent the virtual and email ID and unique password for everyone. Join with us, enjoy this program, because we want to make this a grand success, and this scientific program will be a grand and excellent scientific feast. Long live IPS, long live IIPP. Thank you. On behalf of the entire organizing committee, I, Dr. Rajarshi Ghotakurta, personally thank you for who have not come today or who cannot join us, because COVID is spreading far-stretched in West Bengal and particularly in this district. Thank you. In 15 minutes from now, we will have with us the honorary editor of West Bengal of the national body IPS, Professor Dr. O.P. Singh, and we declare the session open for the CME. We will start the CME at 9:30 a.m. sharp. Please join with us. If you have any difficulties, call on the numbers that have been mailed to you. Thank you.
শোনো একদম টাইট ফ্লো মেইনটেইন করতে হবে কিন্তু
Hello, hello, 1 2 3, hello, 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 hello. Hello, hello, hello. পাচ্ছো?
Nityananda, we will start now. Good morning, everybody. Our first session for today is NMDA, receptor encephalitis, neuropsychiatry, main fascination by Dr. Iman Pal as a speaker and chairperson Dr. Tufan Pati, Dr. Alak Patra and Dr. Molay Kumar Ghoshal. And the sponsor for this session is Sun Pharmaceutical.
আর চেয়ারপারসন কেউ এসছে?
Yes, chairpersons are there.
ওকে, দেন স্টার্ট। চেয়ারপারসন তারা করুক নাকি আমি শুরু করব না তারা করবে? Okay, I am starting this. This is
Hello.
Wait.
Hello, I am also present here.
Sir, we'll call you in the right time.
Rajarshi, please send the introduction of a speaker.
Yes. Please, sir, go ahead and introduce the Dr. Iman Pal, please. Sir, please introduce Dr. Iman Pal as a speaker. Then I will play her presentation.
Okay. Good morning, everybody. We are starting today our Psycon 2020, first time virtual state conference. Our first program is NMDA receptor encephalitis. Speaker is Dr. Iman Pal. Now, to say about Iman Pal, you can see on the screen board, introduction of Iman Pal. I am requesting organizer to show it.
Yes, sir, we have her video. I mean, not the CV, but we directly play her video of her presentation. So may I have your permission to share her presentation?
So I request Dr. Iman Pal to start her speech.
Thank you. Thank you.
Good morning, everyone. So, at first, I would like to thank the organizing committee of Psycon for giving me this opportunity of presenting here. And this is the first session of the day, so I'll straight away proceed to the session. My topic is anti-NMDA receptor encephalitis, the neuropsychiatric manifestations. So, what is NMDA receptor encephalitis? There has been a lot of discussion on this in the recent times. It is a relatively recent construct. It was first identified in 2005 when 4 women who had ovarian teratoma, they were also presented with some psychiatric symptoms, memory loss, altered levels of consciousness, and hyperventilation. It was 2 years later that Dharma and
ইমান স্ক্রিনে কিছু দেখা যাচ্ছে না। সাউন্ড আসছে না।
Hello, Iman. Dr. Iman. Kindly. Iman. Hello. Iman, kindly.
It is being played.
You are not audible.
It is being played.
Okay? Just.
It is being played from your end. Kosubda, it is being played from there. Okay. This is a recorded presentation.
Okay. Thank you.
সাউন্ড নেই কোনো।
Sushant sir, please unmute your system and please play it from the beginning.
But this is in it still remained common. It was on the third position after HSV1 and acute disseminated encephalitis. The median age of symptom onset is around 21 years. Teratomas and other tumors are less common in pre-adolescent children. That is, the detection is less common. As I already mentioned, there is a female preponderance with almost 80% of cases being females. When it occurs in male sex, it is associated with some of the youngest and oldest cases. It is also commoner in Black patients and Asian patients, suggesting a possible genetic. So if we come to the neurobiology and pathophysiology of it, actually NMDA receptors are concentrated in the hippocampal region of the brain, and they are also found in other brain areas. So the encephalitis is a consequence of Ig and IgG3 antibodies binding to the blue N1 subunit of the NMDA receptor. What happens due to this binding is that there is decrease in the NMDA receptor clusters because there is internalization of the antigen antibody complex. So NMDA receptors are involved in a lot of functions, including long-term potentiation and memory formation. So this is evidenced by the fact that patients with NMDA receptor encephalitis later on they have persistent amnesia for their illness. So it can be hypothesized that there is a sustained hypofunction, the NMDA receptor encephalitis, and this can underlie a pathophysiology of various disorders, including psychosis, including Alzheimer's disease, including autoimmune encephalitis, of which NMDA receptor encephalitis is one. On the contrary, an overexcitation of the NMDA receptors will cause neurotoxicity and acute brain injury. So similarly, the NMDA receptor antagonists, they have psychotomimetic effect similar to that seen in NMDA receptor encephalitis. Agents like phencyclidine and ketamine, they have a similar effect. So a genetic vulnerability coupled with the antecedent viral infection predisposes a subgroup of people to develop anti-NMDA receptor encephalitis. But they can also, depending on the various epitopes, they can develop either encephalitis or psychosis or problem with memory. So what happens in a viral infection is that there is an inflammatory response, the blood-brain barrier gets disrupted. Autoantibodies enter CNS and they stimulate production of antibodies to the NMDA receptors, which can bind to the subcortical neurons. The immune response is usually self-limited and the antibody titers gradually decline, correlating with the gradual cognitive impairment, cognitive improvement. So if we come to the clinical manifestations, it usually begins with a prodrome of cold-like symptoms like nausea, vomiting, fever, headache, fatigue, followed by a spectrum of neuropsychiatric sequelae. So in the initial month itself, at least 90% of people will experience 4 out of the 8 characteristic neuropsychiatric symptoms, which include behavior or cognition problems, memory deficits, speech disorder, seizures, movement disorders, loss of consciousness, autonomic symptoms, or hyperventilation. So the symptoms can be organized into early stage symptoms and late stage symptoms. The early stage symptoms come typically within 2 weeks of the onset of prodrome, and they include cognitive dysfunction like confusion or amnesia, psychiatric symptoms like paranoia, delusions, hallucinations, aggression, self-injurious behavior, mood symptoms, and seizures, which can include both CPS as well as GTCS. So the cases often, this is one neuropsychiatric syndrome which usually presents to psychiatrists, and they are frequently misdiagnosed as new onset schizophrenia or bipolar disorder. So it is a red flag, and psychiatrists, they need to be careful. They should be suspicious about encephalitic etiology patients who present with an acute onset of psychiatric symptoms, which are not really typically responsive to antipsychotic medication and accompanied by fluctuating levels of attention, problems with memory and cognition, or subtle neurological abnormalities like brief facial twitchings. In children, the most common symptoms are behavioral problems as well as seizures, which can emerge at any point during the course of the illness. They also present often with movement disorders, orofacial dyskinesias or polychromia. It is important to distinguish between the seizures and the movement disorders because the management is different. some of the features may be similar. So EEG may be helpful in providing a differential diagnosis as well as the duration of the events, with seizures being shorter in duration, and whether they are occurring during sleep or not. These are differential. The later stage symptoms include movement disorders, hypoventilation, sleep disturbances, autonomic instability, in some cases catatonia. Adults more frequently have cognitive deficits and hypoventilation. They can also alternate between a state of agitation as well as a catatonic unresponsive state. If the treatment is delayed, the autoimmune process can worsen and can result in a progression of movement disorders. Abnormal movements include dyskinesias, chorioathetoid movements, dystonic posturing, abnormal ocular movements. They even share features with catatonia like posturing and waxy flexibility. Autonomic instability can result in both hyper as well as hypotension in body, as well as tachycardia, hyperthermia, urinary incontinence, hypersalivation. So if we think of the differential diagnosis, we can think it of as the neurological or organic differential diagnosis and psychiatric differential diagnosis. Among the neurological differential diagnosis, temporal lobe seizures, toxic and metabolic disorders, a focal brain lesion, and encephalitis. Encephalitis, including other viral as well as other autoimmune encephalitis, need to be considered. Whereas among the psychiatric differential diagnosis, we have to think of acute psychosis, functional psychosis. Some studies have suggested that compared to functional psychosis, the psychosis in NMDA receptor encephalitis is fragmented, the delusions are not well formed, not really very well systematized. There is also postnatal psychosis associated with ovarian pathology, which is similarities with the NMDA receptor encephalitis. The neuroleptic malignancy, particularly if antipsychotic treatment has been started, suspecting a psychiatric diagnosis. So this represents both a diagnostic dilemma as well as a challenge. So to come to a definitive diagnosis, we move on to the investigations. The mainstay of diagnosis is serum and CSF evaluation for viral as well as autoimmune causes of the encephalitis. Other investigations like EEG, MRI, CRP, ESR are non-specific, but they help in generating a differential. So for blood and CSF evaluation, what do we look for? We look for NMDA receptor antibodies. We look for other paraneoplastic antibodies, like antibodies to glycine receptor, to the GABA B receptor, GABA B subunit receptor, voltage-gated potassium channels to calcium channels, because they cause other symptoms similar to NMDA receptor encephalitis. Compared to viral etiologies, NMDA receptor encephalitis, they have normal glucose levels and the protein levels have a lower median values. In early stage, there is CSF lymphocytosis, whereas in later stage, oligoclonal bands are prominent. Seizures in the absence of fever, or seizures associated with movement disorders, language dysfunction, autonomic instability, these should give rise to suspicion of NMDA receptor. MRI, usually it is normal. Sometimes it can demonstrate medial temporal lobe involvement with discrete areas of hyperintensity in frontal or parietal cortex. The 18 FDG PET scans can show cortical hyper. Metabolism in stages. EEG shows non-specific slowing at some point in the illness. So, overseas, what do we test? Do we test the serum levels or do we test the CSF levels of the antibodies? So, studies have been equivocal about this actually. And there are some of the studies have reported that the serum antibody has lesser sensitivity compared to the CSF antibody testing. But the CSF antibody testing, on the other hand, is a more invasive procedure. The antibody titers, they correlate well with clinical outcome. After treatment or in the advanced stages, the CSF antibodies usually remain elevated if there is no improvement, whereas the serum levels, they reduce. So if we come to the management part, we have to treat both the causes of the encephalitis, that is the definitive treatment, as well as the clinical consequences of the encephalitis. That is, we have to manage the behavioral symptoms, we have to manage the psychotic symptoms. So both of these clusters are targeted. So for the first part, the definitive management, the first line treatment is immunotherapy. So we can use corticosteroids, IV immunoglobulin, plasma exchange, plus tumor removal where it is detected. So that has to be done. The second line treatment includes treatment with agents like rituximab or cyclophosphamide. Patients who do not have detectable tumors, but then their risk of relapse is higher. So the immunosuppression has to be continued for a longer duration. So they have to continue immunosuppression for at least 1 year with agents like azathioprine or mycophenolate. If we come to the management of the behavioral or the psychotic symptoms, here again large studies or large scale evidence is not there. Whatever evidence we have is for like case report based studies. So what has been found is, for example, haloperidol and aripiprazole, they have been reported to be associated with higher development of EPS, and they've not really been found to be very effective because of that. Whereas on the other hand, risperidone in a few studies, quetiapine in a few case reports, they have shown good response. So the rule of thumb is these patients are more sensitive to the development of EPS. So we have to use a lower dose. And the thing we keep in mind is that the antipsychotics can complicate the picture, particularly prior to a definitive antibody diagnosis. So unless the diagnosis, if the diagnosis has not really been done, definitive diagnosis has not been done, then we have to initiate with caution. Mood symptoms, some of the studies have used lithium and valproate. Very good results have not been, but valproate also has added utility as an anticonvulsant agent, so it can be considered in that light. The development of, if a person develops autonomic instability and rigidity, it can be mistaken for neurologic malignant syndrome. Then again, the corticosteroids which are used, they cause confusion with the steroid-induced psychosis, and they have to be managed accordingly. For the management of the sleep disturbances or the catatonic symptoms, benzodiazepines have been used. There are case reports about usage of ECT also in refractory cases. So when we come to the prognosis, despite all the associated negative factors, comorbidities, the majority of the patients, almost 75 to 80% of them, report a favorable outcome at 2-year follow-up. And the factors which are associated with a better outcome are if the disease is not very severe, that is, the person is not required any ICU admission. Immunotherapy has been started early, and there was a definitive tumor detection and it was removed. These are the factors associated with a better prognosis. A delay in treatment can lead to permanent hippocampal damage. Better cognitive outcome is seen in patients treated with immunomodulatory therapy within 3 months of the disease onset. And mortality remains 7%, quite high, 7% at 2-year follow-up. The recovery is a very slow and painstaking process requiring months of intensive rehabilitation with the help of occupational therapy, physical therapy, speech therapy. And the risk of relapse is 12 to 24%. It is higher in those who do not have any detectable tumor. Now we come to the challenges. From a neuropsychiatric point of view, what challenges does this diagnostic entity throw up? So we have to keep in mind that there is an increased awareness of this disease in recent times. But despite that, it is there a misdiagnosis of psychiatric disorder? Because they primarily present to the psychiatrist at initial presentation, and their overdiagnosis. So there a few studies have evaluated that. What they did was, for example, the study by Steiner et al. They prospectively evaluated almost 460 serum samples for NMDA receptor antibodies, and they found almost 10% and 3% of patients with schizophrenia and major depressive disorder to be antibody positive. Another study by Zanti et al. Was an observational cohort study in 46 adults with first episode psychosis, and they found 7% to be NMDA receptor antibody positive. The problems with these studies were they evaluated included IgA and IgM, not IgG, which is specific for the psychopathology. So that was a major fallacy, and then they only tested the serum samples, not the CSF samples. In contrary to the above mentioned findings, another relatively recent study, they did not find any antibody in patients with schizophrenia or the healthy control groups. This was methodologically more stringent, and they had 3 readings of the IgG subtypes. But again, this study also, they tested only serum samples and they did not test for CSF samples. So there might have been incidence of false negatives. So if we look at it at this point of time, the current evidence is unclear that whether patients with a primary psychiatric diagnosis, they possess higher rates of pathogenic NMDA receptor antibodies or not. That we cannot really say definitively. But at the same time, we are aware that it is a potentially fatal yet highly treatable disease. It presents with rapid onset to mental health services. So is a widespread screening feasible for this? And if we do screen for a lot of batteries are now available. If we do screen, do we go for a CSF analysis or we go for a relatively simpler serum analysis? So we have to keep in mind that the CSF analysis, though it might be definitive, whether the psychiatric presentation by itself should justify an invasive lumbar puncture or not. So in this case, do we require, what would be helpful is that if a pattern can be identified, a pattern of psychiatric presentation where the clinician thinks that, okay, in this group, with this pattern, it is justified that I go for a more invasive procedure. So is there any such pattern? Keeping these features in mind, there was another large-scale study conducted by Aldivani et al. They did a systematic review and phenotypic analysis of individual patient data on the psychopathology of NMDA receptor antibody encephalitis in adults. So what they did was they included a lot of studies which satisfied inclusion criteria, and they described almost 1,100 patients in total with NMDA receptor encephalitis. So they tried to find a common psychiatric pattern amongst them. What they saw was there was a lot of almost 20 lower level symptoms, right? Sleep disturbances, agitation, aggression, which could be further organized into 5 higher level symptoms like psychosis, like mood disorders, like catatonia. So, and then they concluded that actually the psychiatric presentation was not really fitting into any one particular diagnosis, but it was more of a mix of mood disorder as well as psychosis. So it was not a single disorder, rather a combination kind of presentation. So keeping in mind all of these factors and the various studies presented, the take-home message, what can we finally do in our clinical practice is, the implications are NMDA receptor antibody encephalitis might best be described as a mixed mood and psychosis syndrome. Given the advanced diagnostic psychopathology, the multi-stage neurological features, the subacute onset, and a predominant young female demographic associated with paraneoplastic teratomas. A very clear index of suspicion is needed for this group so that it can be identified at the very early stages and treatment initiated accordingly. So a selective and very clinically driven approach might facilitate early diagnosis. And what is important is the treatment has to be, because it involves so many domains, the treatment has to be include a multidisciplinary team, and early involvement by psychiatrists alongside their neurology colleagues is crucial. So depending on that, that is, we will take further decision. So that ends my presentation. Thank you.
Thank you, Iman. It was a nice presentation.
I will.
Thank you.
Okay. So actually, I have found in the last 3 or 4 years several cases of NMDA antibodies presentation in our psychiatry ward. They came to our psychiatry, and most of them they initially presented with psychosis, as you have told that usually this is an acute polymorphic psychosis like pattern. And then after admission, there were some clues which actually helped us to detect that either there was some confusion. In one case, there was epilepsy or Perseus continua. In another case, there was a seizure. In another case, there was a movement disorder.
Yes.
So all these things, actually, we referred all the cases to the neurology department, and they came with the diagnosis of possible NMDA, and all the MRI shows that there is some bilateral hippocampal medial temporal lobe hyperintensity. And the simple treatment of 1 gram of methylprednisolone mixed with 100 milliliter of normal saline given over a period of 1 hour for 5 days, actually many of them were improved. So we should have a high degree of suspicion. So that is needed. Actually, I don't know that the question where will the question will come? Question answer session will come. In many of the in 2016 there is a Lancet article in which they told that this on the basis of clinical suspicion, because many of the areas this CSF antibody panel is not possible, so you
Exactly,
sir. You can start treatment.
Exactly, sir.
So this
instead of waiting for an exhaustive panel, if there is a high index of clinical suspicion, I think it is better to involve the neurologists, and so and that has to be kept in mind.
There are many types of autoimmune encephalitis. NMDA is just one of them.
One of them.
So I don't know whether there is any question or not, because I told them that it's in the chat box.
No, sir, no question has come in the chat box.
No question has come in the chat box.
No,
but
sir.
I really, in the last few years, actually, what the mind does not know, the eyes cannot see. That is
exactly. Yes,
actually,
sir.
before 2007, nobody knew about this type.
Nobody knew.
And we have missed so many cases, maybe in the early practice of our life. Everybody of us have seen this type of cases, and we could not do diagnosis. And so that's the point. Actually, we should be cautious. We should be having a high index of suspicion to diagnose these cases. Alok.
Yes.
Alok. Alok, kothai gelo?
I am here, Malaida. I just want to say a few words. Actually, say 20 years ago, when I started practice here, on that time we have treated many cases as a acute disorder or psychosis, polymorphic psychosis, kind of disorganized behavior, polymorphic symptom, kind of seizure or non-epileptic seizure disorder kind of behavior, and most of the time having some cognitive impairment, say confusion, disorientation. So we treated them as just acute psychosis. But later on, when the investigation setup improved, that we get MRI, MRA, MRS, and CSF study within 1 hour in our setup. These days, we are getting, say, lot of cases are having viral encephalitis, which we are earlier treated as acute psychosis, functional psychosis. Similarly, I feel these cases, some of the cases, even though there is picture like viral encephalitis, but even CSF study is normal. Maybe those are NMDA encephalitis as we can detect here. But the thing what I want to point out that actually the difference we can make out from the presentation from functional psychosis. Initially, these people having basic presentation is a kind of confusion, disorientation, and very disorganized behavior, and not very
Yes.
typical,
Of
well-formed
typical, well-formed psych.
delusion, hallucination, nothing is there, and not fitting into any kind of say mania, depression, or any clear-cut
Yes.
psychotic
Yes.
symptom.
Psych.
And the thing is that after treatment, what happens in functional psychosis, they recover fully. But this kind of psychosis, encephalitis, there are some permanent cognitive impairment that remain, or some personality changes that remain even afterward. So actually, that's why we should have high, as Malaida said, that we have to be very careful in from the very beginning, and we have to suspect that it is some kind of encephalitis, and we have to do some treatment. Otherwise, later on we can't do. Once we miss the diagnosis and treat just as anti-psychosis, then if there is some cognitive impairment, if there is some extrapyramidal symptoms or some neurodeficit persist or some personality changes, that later on cannot be corrected. So in coming days, we hope that more specific diagnosis and more specific treatment will come, and we'll be able to treat NMDA encephalitis in a better way.
Yes, sir.
No, actually, I don't know how much is the time left, because if the last thing the Imam said, it is very important, and that has come in 2019 Lancet, that usually there is a polymorphic and there is a 5 higher level symptom, that is a mood disorder, behavior, sleep disorder, catatonia, and psychosis. These 5 actually they mix up and they give rise to a type of symptom which does not fit in any particular type of psychosis. Yes. And so we should be, it is not always that it will present with confusion, because confusion, if you present, that is a very important telltale sign of the brain dysfunction. But sometimes we miss it. I tell you that confusion comes later, and if earlier we institute treatment, better is the prognosis. That is one of the things that is, and I don't know whether that is not very studied, whether this NMDA receptor antibody encephalitis, after treatment, what is the sequel of their, how many become totally normal, how many have some psychiatric symptom, some neurological symptom, whether there is not very much. I think Imran can tell whether there is any study or not.
So some neurological deficits are persistent in many of them, like motor deficits are there, cognitive deficits, they persist. At 2-year follow-up, they have found. And that takes a lot of cognitive rehabilitation and all they have started. But even with that, some amount of deficits persist in a lot of patients. So not complete recovery is there. Significant recovery is there, more than 70 to 80%, but some residual symptoms are there.
Okay. Thank you, Iman. That is a very good presentation, very comprehensive, and in the short time you have covered many of the aspects of this very important topic. Thank you.
Thank you, sir.
Before just concluding, I want to say that those who are organizing, in the green room or console, some of your discussion and noise is coming from your side. So in next session, please take care of it. So otherwise, we had a very beautiful initiation of our conference, first program, and I am happy to be with my godfather or something, Dr. Malaida, and Iman Pal, very lucid and very attractive presentation. Only thing is that some point of time the
Slides were.
sound
Yes,
was
sir.
disturbed, so that will be taken care by Siraj and Rajarshi and Nityananda. And hence I am ending up this session. Now, Rajarshi,
Thank
please
you, sir.
proceed for the next session.
Thank you, sir.
Thank you, sir. Thank you. Our next session is psychiatric manifestation of neurological disorder in children and adolescent by Dr. S.K. Altaf Hussain, and chairperson for this session is Dr. Rajashri Roy and Dr. Indrajit Sengupta. And the session is sponsored by Intus.
হ্যালো, হ্যাঁ আমি আছি। আমি কি ভিডিও অন করব?
Indrada?
Hello.
Ready.
Hello.
ঠিক আছে. Okay. Good morning.
গুড মর্নিং।
You are not audible.
হ্যাঁ, ইন্দ্রদা আপনি টপিকটা ইন্ট্রোডিউস করে দিন, আমি স্পিকারকে ইন্ট্রোডিউস করে দিই।
Good evening. Good morning, everybody. Today's topic is psychiatric manifestations of neurological disorders in adolescents and children. So we are quite accustomed. Am I audible and visible?
Yes, sir.
We are quite accustomed with the psychiatric manifestations of the adolescent and children, like ADHD, bipolar, schizophrenia, panic disorder, separation anxiety, etc. Simultaneously we are quite acquainted with neurological disorders like epilepsies and its various forms, especially the occipital lobe epilepsies, which is very important in case of children and child and adult psychiatry. Even Wilson disease comes into the category of adolescent and children neurological disorder. Neurodevelopmental disorders are there, but it is both the aspects are discussed in a very frequent manner, but the interface between the psychiatric manifestations and the neurological disorder of adolescent and children are discussed very infrequently. So the organizers has selected this topic in a very showing their wisdom and insight, and Dr. Altaf Hussain is quite capable of representing himself. So I hand over my chair mic to Rajashri, Dr. Rajashri Banerjee.
Thank you, Indrada. Very good morning to all of you, and thank you to the organizers and especially to the organizing secretary, Rajashri, for inviting me as the chairperson for this session, which is going to be delivered by Dr. Altaf Hussain, who has done his MBBS from North Bengal Medical College and his DPM from IOP, followed by his MD in psychiatry from NIMHANS and a postdoctoral fellowship in child and adolescent psychiatry from NIMHANS, and he's presently attached as a consultant psychiatrist at the Institute of Neurosciences, Kolkata. Thank you for accepting the invitation, Altaf, and we look forward to a very enlightening session, which will be for 25 minutes with a 5 minutes question and answer. And I will give you a 5 minutes warning before the end of your talk. Over to you, Altaf. Thank you.
Okay, thank you. Thank you, Dr. Rajashri and Dr. Indrajit. Am I audible and visible?
Yes, doctor. Would you please do full screen?
Yes, sure.
Perfect. Thank you very much.
Okay, so very good afternoon to all. Good morning to all of you. Today, I'll be talking about psychiatric manifestations of neurological disorder in children and adolescents. Though it's a very big topic, so for justice to be done, I think a whole textbook is required. But however, I will try to cover most of the things that is commonly encountered in our clinical practices. So now just a slide about the psychiatry and neurology. So what are the conflict and cooperations if we talk about? Like for more than 2000 years, it has been thought that psychiatry and neurology are part of a single unified branch of medicine. Even Charcot, Freud, Bleuler, Jackson, more of them would think it as study of unified discipline of medicine, and they would consider it as a study of a brain and mind, though keeping the clinical and research interest separate. But after 20th century, there has been a schism that developed between neurology and psychiatry. When the neurologist started focusing more on the behavioral and cognitive aspects, those are associated with somatic symptoms and signs like Parkinson's disease or stroke. And the psychiatrist started focusing on mood and the disorder of thoughts. Those are minimally associated with changes in any neurological findings of signs and symptoms. But in recent advances of neurosciences, it is very difficult to precisely draw a line between psychiatry and neurology. If we see a person of Parkinson's disorder can present with depression and dementia, and at the same time, there is a very thin line between the presentation of some acute psychosis and a patient of metabolic encephalopathy presented with delirium. So, so the target of our today's discussion is not finding biological basis of psychiatric manifestations, but to understand each other in a better way and to form a holistic approach so that the children who are suffering can get a better service. Like if we talk about the clinical presentation, how varied it is, so you can see like neurological disorder can have psychiatric manifestations. Then neurological disorder can mimic psychiatric symptoms like non-convulsive status epilepticus. Then psychiatric disorder can mimic neurological disorder like dissociative disorder or functional neurological disorder. Then we have some systemic disorder which have both neuro and psychiatric manifestations, and some treatment related conditions like drug induced EPS. So today I will mostly discuss about the neurological disorder having psychiatric manifestations. So first we start with encephalopathy. There are various types of encephalopathies. Actually, encephalopathies are dysfunction in mental ability or behavior due to some underlying neurological conditions. So it can be static or progressive. Static encephalopathy, usually there is attainment of developmental milestone in children and adolescents at a slower rate, but they never lose their ability. That can be due to some genetic defect or infection, tumor, asphyxia, or trauma. Progressive, there is the gradual loss of acquired milestone. That can be because of uncontrolled epilepsy, some metabolic disorder, or some chronic infection. So most of the static encephalopathies are due to genetic alteration. They can have dysmorphic features. So I will briefly cover a few of the common genetic and chromosomal disorder that are associated with some neurodevelopmental findings. So Fragile X is one of such genetic syndrome. It occurs because of some trinucleotide repeat CGG code because of defective FMR gene. Usually these children present with speech delay. They have poor social interaction. They have features of autism spectrum disorder, and they have features of intellectual disability. They are often aggressive, impulsive, and they can present with seizure as well. So they have some typical facial and congenital stigmata. They are, though normal in structure. They have broad forehead, elongated face, large prominent ears. They can have crossed eyes, high arched palate. Their joints are hyperextensible, and they can have some cardiac abnormalities as well. So next we move on to Down syndrome, very commonly found. These children, because of trisomy 21, can have intellectual disability and a lot of behavioral issues. They have typical faces, slanted palpebral fissure with hypertelorism. Then they have protruded tongue. They can have some other associated physical abnormalities as well. Now, Williams syndrome. This is a microdeletion syndrome where a child is over-talkative. Usually, their speech is preserved in comparison to their intelligence. They can have well-filled faces. Now, like Dr. Alok was talking about encephalitis or due to infection. Yes, definitely herpes simplex encephalitis can present as psychotic symptoms, but we should be careful if there is pyrexia or confusion. Now we'll talk about some progressive encephalopathies. So among them, there are mucopolysaccharidosis, there are lipidosis, there are leukodystrophies, some chronic infection, and some inborn errors of metabolism. I start with some mucopolysaccharidosis. There will be defective long chain sugar metabolism, and because of that, these children have a lot of bone and joint deformities, and usually seen that they loses their acquire milestone during their early years of life. They have coarse facial feature like coarse eyebrow, then broad nose, broad lips, and all. So if we find any child with coarse facial feature having history of regression and milestone, we should check for mucopolysaccharidosis. And next one is lipidosis. This is the lipid storage disorder. It presents with ataxia, spasticity, seizure, coordination difficulty. Lipidosis children as well show similar features like cognitive decline, and they have learning difficulties. They also have dysmorphic feature. This includes Tay-Sachs disease, Sandoff disease, Niemann-Pick's, and Gaucher's disease. Now the leukodystrophies. Leukodystrophies are some group of inherited disorder. Those are characterized by abnormal myelin formation that may be because of defective metabolism, lipid, myelin protein, or some other organic acid. The cause may be different. This present with spasticity, ataxia, and optic atrophy. These children can have psychiatric symptom in terms of disinhibited behavior, impulsivity, emotional lability, and poor judgment. And examples, metachromatic leukodystrophy, that is quite, quite seen in OPD. Others are quite rare with psychiatric symptoms. Now, a vast topic is epilepsy. So, epilepsy can present with a lot of neuropsychiatric manifestations. 33% of children with epilepsy have psychiatric disturbance. So there are studies which have found a few things like interictal cognitive and behavioral disorders that are seen in epilepsy are resulting from combination of the underlying disorder, medications, and the seizure itself. Now, the most serious hazard of an epileptic disorder is frequently not the seizure, but the associated emotional disturbance because of the stigma, because of the harassment, bullying in school, because of the overburdened caregivers and all. And the relation of epilepsy with psychiatric illness is bidirectional. So, studies have found that children with epilepsy are more vulnerable to develop mental illness. At the same way, children, those who are having mood disorder, are more vulnerable. Mood disorder as well as neurodevelopmental disorder are having more incidence of epilepsy. Children with temporal lobe epilepsy are hyperactive, aggressive, depressed, moody. So there are increased risks for attempted suicide in children who are taking phenobarbital. Now, the psychiatric manifestation that are related to occurrence of seizure. Periictal, that we all know, is prodrome. Ictal, and ictal phenomena can be aura, that can well mimic psychiatric manifestation, automatism. And one more thing is non-convulsive status. Post-ictal delirium, depression, psychosis, like we see in adults, that can also present in children and adolescents. Interictal anxiety, mood disorder, psychosis, personality disorder. So I'll not go into details as those things are similar as adults. Okay, I'll just a few word about the non-convulsive status epilepticus. So it is a status epilepticus with lack of predominant motor component. So there will be status epilepticus with predominant changes in behavior and mental status, and associated with real-time EEG changes. That can be absent status or complex partial status. What is found during those processes are slowness in thought process, some cognitive difficulty sustaining in attention, and they can have a prolonged confusional state, mood disturbances, cortical blindness, or speech disturbances. Now again, we have a broad category, that is epileptic encephalopathies. So epileptic encephalopathies are the conditions where epileptic activity, repeated epileptic activity, contributes to severe neurological and cognitive impairment. I mean, which is more than whatever has been done by the etiology itself. So in epileptic encephalopathy, there are recurrent seizures with prominent interictal epileptiform discharges, diffuse abnormal background activity in EEG, and they are often very much resistant to treatment, and the causes are diverse. So commonly seen epileptic encephalopathy in children and adolescents is West syndrome. So West syndrome, children usually present with spasm, that is infantile spasm. They have intellectual disability, and typical EEG finding, that is hypsarrhythmia. Their spasms are usually in cluster, occurs shortly after waking. Initially, the ID is not that much apparent, though the regression can be plateaued after a while. Other one is Lennox-Gastaut syndrome, that is multiple types of generalized seizure with diffuse slow spike on EEG. These children can have intellectual disability. Can present with features suggestive of autism or psychosis. Actually, these children are quite self-absorbed, and they have their own world. They have a lot of self-absorbed behavior, so it can mimic autism or early onset psychosis. Landau-Kleffner syndrome, that is also, seen quite often in clinical practice. So usually a child was quite well, suddenly started being hyperactive, and whatever he was speaking stopped, and has stopped communicating with others. That is the usual history. So what we should look for is EEG changes during sleep. So in LKF, there is changes in EEG during sleep. So sometimes few terminologies are used, that is electrical status epilepticus in slow wave sleep. So this kind of changes are seen in LKF. Other than that regression, autistic regression, these children are hyperactive. They can have sleep disturbances. Usually with early treatment, the aphasia is reversible. Now I'll just briefly talk about few genetic epilepsy syndrome. One is tuberous sclerosis complex. The tuberous sclerosis complex, a child presents with epilepsy with developmental delay with lot of dermatological manifestations like adenoma sebaceum, then Ashcliffe macule, then a lot of freckles. I'll just show one picture of a child with tuberous sclerosis. The face, there are a lot of adenoma sebaceum. Second one is Angelman syndrome. This is a microdeletion syndrome. So child with Angelman syndrome usually that told happy puppet because most of the time they're happy, sociable, and they have ataxia. Because of the ataxic gait, they look like puppet. So I'll show you one facial symptoms. So they can have some facial stigmata, is wide open mouth, broad nose, deeply positioned eyes. Now, Rett syndrome is earlier thought to be part of autism spectrum disorder, but a lot of studies where it is proved that it has significant neurological basis. Rett syndrome, usually we saw a girl child was developing quite well, and after 6 months to 1.5 years, started showing regression, mostly in hand function. That coordinated motor function of hand is replaced by some stereotyped movement. They can have episodes of hyperventilation and seizures. Now, few chronic infection present with neuropsychiatric manifestation. SSP is a acute sclerosing panencephalitis, that is a late complication of measles infection. Usually, it is found after 5 to 15 years of the initial infection. Children usually, what we saw, child doing well suddenly started showing less interest in studies and academic decline, not able to remember things, and irritability, distractibility, shortened attention. Usually we can misunderstand that as ADHD, or some parent may say that child is showing some mischievousness, not concentrating on studies. But we have to find out whether there is any myoclonus or not. So if there is some myoclonus, definitely we check for SSP. AIDS infection also can present with neuropsychiatric manifestation. So in children, they can present with inattentiveness, impulsivity, depression, and in adolescents, they can present with acute psychosis. Now, this big category is inborn errors of metabolism. Wilson's disease, that is inherited disorder of defective copper metabolism. This children and adolescent presents with tremor, ataxia, and dystonia. 1/3 of the patient present with psychiatric symptom. The declining school performance, there are personality changes, impulsivity, labile mood, sexual disinhibition, and some other inappropriate behavior. Acute intermittent porphyria. It is because of defective porphyrin mechanism. As we know, it can present with some systemic manifestation like severe abdominal pain with peripheral neuropathy. Psychiatric symptoms commonly seen are depression, panic attack, and psychosis. Phenylketonuria, that is also seen quite often. There is an autosomal recessive disorder, inborn error of phenylalanine metabolism, child and so growth failure, and there is poor pigmentation, seizure, microcephaly, and intellectual disability. And now tic and Tourette syndrome, there are many things to discuss about tic and Tourette's, but I'll briefly just touch it. As you know, tic are sudden, repetitive, non-rhythmic, involuntary movement. You can say it's semi-purposive, semi-voluntary. And Tourette syndrome is a syndrome which is manifested by various types of tic, motor, vocal, complex tic. These children can have significant psychiatric manifestation that is usually overlooked, and because of that, it becomes difficult to manage those tic clinically. These children have a lot of anxiety symptoms. They can have OCD. They can have ADHD as well. So we have to target all the symptoms at the same time. Pediatric autoimmune neuropsychiatric syndrome. Again, a good topic. So there has been a change of this earlier terminology that was PANDAS, pediatric autoimmune neuropsychiatric disorder associated with streptococcus infection. But now it has been seen that it's not always associated with streptococcus infection, but that reason can be various. So the newer diagnostic criteria says that there will be abrupt and dramatic onset OCD with restricted food intake, And the cause found for the food restriction is maybe the obsessive preoccupation with texture of food or obsessive fear of choking or vomiting. It is associated with anxiety, emotional lability, depression, and some regression in development. They can have sensory symptoms, and they can have neurological some movement disorder like coriform movement or some tics. And PANS is confirmed when this is excluded as not because of any known neurological disorder. Now, autoimmune
You have
encephalitis.
5 minutes left. You have 5 minutes, please.
Okay, thank you.
Thank you.
So, autoimmune encephalitis is discussed in detail during the last session. So, if a child is showing some atypical psychiatric symptoms with history of seizure, catatonia, and definitely we look for autoimmune encephalitis. Systemic lupus erythematosus can also present with various types of neuropsychiatric symptoms. They can present with depression, they can present with psychosis and cognitive disturbances. Okay, so these are maybe I have missed few of the disorder, but those are the commonly seen or commonly discussed. So now how to approach in a child adolescent case to look for organicity or look for any neurological disorder that is underlying. Definitely we have to take a good clinical history that should include birth and developmental history, then detailed examination, general physical examination, detailed neurological examination, and we should examine the comprehension, communication, speech and language of a child, their non-verbal communication, their gesture, facial expression, their pragmatics, or their conversation and articulation abilities, their learning, attainment, their problem-solving abilities. And we should observe the child and observe for a while they're playing, and we should concentrate and see their level of attention, activity, sociability, then social referencing, their responsiveness, insight, and empathy. Now, some subtle sign. If we find these signs, definitely we should not do a premature closure. We look for organicity. The regression or loss of acquired skill. If there is regression, definitely we look for organicity. Recent onset speech difficulties, history of seizure or jerks, any abnormal movement or any motor weakness, facial dysmorphism, dermatological manifestation, abnormalities in genitalia like undescended testes, if there is perseveration and if there is release reflexes, and impairment in comprehension. So if we found this, then we must investigate, we must take help to further exploring the etiology or some comorbid condition. So I'll just conclude with few things. So we must learn about the pattern of presentation of common neurological disorder. We should have an index of suspicion, but we should avoid overdiagnosis and over-investigation. We must develop a skill to pick up subtle neurological impairments, avoiding premature closure. And then whenever we feel we ask for investigation, we ask for help, we take opinion from our colleagues of neurology, and further developing a better liaison. Okay, thank you. Thank you very much.
Thank you, Dr. Altaf. Hello.
Hello. Yes.
Am I audible?
Yes, sir.
Yes, sir.
Thank you, Dr. Altaf, for your excellent presentation. We have covered so many things in a very stipulated time. The credit must go to you. And now this floor is open for any question and answer. Rajeshri may contact them.
May I just check with the organizers and the host for the Zoom with Expertica? Are there any questions that has come to the from the audience to the Expertica platform, please? Can the host please confirm? Hello? Is there any question from the audience on the Expertica platform, please?
Not yet now.
Not yet. Okay. All right. Thank you. So yes, as we wait for questions and we request our audience to type their questions in the chat box, we have 5 minutes for question of discussion before we next move to the next session. In the meantime, Altaf, my question to you would be on the pans and the cans, because I've personally found this little difficult to manage these patients. And I'm really, I'm glad that you talked about the pans and the childhood adolescent acute neuropsychiatric symptoms. The overlap with the OCD symptoms is always quite a conundrum to me. From your clinical experience, would you tell us what's the best way to approach these patients and what is the outcome in terms of management therapy and working with our neurology colleagues?
Yes, definitely. I have also faced certain difficulties in managing these children. So as usually these PANs present as bouts of symptoms, they are kind of waxing and waning. With medications, at times they respond, and then after a period of lucid interval where the child is doing well, and suddenly again exacerbation of those symptoms, OCD, and then the problem what I faced, OCD symptoms is not that much problematic. Usually it responds with conventional anti-obsessive drugs like SSRIs and all. But what I found difficult is managing their other behavioral problem. Usually they are very defiant, they are clingy, they are demanding, and because of their problem, they can have tics as well. The other factors like other psychosocial factors also contribute. They are being teased at school, then they are being ridiculed, discriminated. Along with that, as this is kind of chronic thing, and the parents are also overburdened, and then at time they are also a lot of their expressed emotion that is mostly negative. So their problematic behavior mostly defines, they are demanding, they are not willing to follow household rules and all. It's quite more difficult.
Thank you. On that note, we actually have, I think, a couple of questions that's come from the audience. Indruda, may I take those questions, please?
Yes.
Okay. The first question is, don't you think, to the speaker, that basically this disorder is a syndrome, neurological manifestation of psychiatric disorder, or vice versa, are the two sides of one coin?
Yeah, okay, that we can say it's a two sides of one coin, because regarding tic and Tourette's, there has been a lot of discussion whether it's neurological or psychiatric. But like I mentioned during the earlier question discussion, we have to focus on the holistic management of the situation. If a child is having this kind of symptom, it's not only the symptom that is problematic for the child, because of the other circumstances that the child is facing because of the symptom. That is important, like as a whole. So we should take care of their criticality from the parent, their bullying at school, then boosting their confidence.
Admin, please mute yourself.
Teaching to handle the negative comments. So it's not just medicine to change the biology and to reduce the symptom. It's overall a holistic approach to take care of the pharmacology and the non-pharmacological part. So in that context, I would prefer to think those symptoms as more psychiatric than neurological.
Thank you, Altaf. And just one more question before we conclude this session.
Rajashri, am I audible?
Yes, Dada. Yes, you are.
Should I say something?
Please.
Oh, I just want to say, actually, all the childhood problem, whatever say like 10 years ago, whoever we are trained, we understood the such a children problem as a problem of the parents. So it's something wrong in the parenting, or say over involved parent, or over permissive, like that. But say in case of ADHD or any other kind of behavioral problem, so we develop a kind of negative transference to the family member. But one point actually, that some of the things are biological, or some of the things are organic in case of children, say for ADHD, like those who are showing, a children is showing temper tantrums. Now, if I don't fulfill the demand, how long the children will show temper tantrums, that particular thing is individual, and that is has something organicity there. How long the person will keep on, say, showing the disruptive behavior, anger outburst, and all that. So one point of time, it is beyond their capacity to tolerate, and in that time they fulfill. So what I want to say is that totally childhood problem or pediatric psychiatric problem, we have understood, say 10 years ago, as a psychological problem, family problem, parenting problem. But now that these kind of present findings, what Dr. Asif is presented, that some organic problem, some congenital defect, some neurological problem, and some biological construct is there in the children, that actually contributing, and that we have to manage, and management needs some pharmacological intervention also. So there is a need of changing our mentality, particularly those who are senior, so those who have are trained or got our degree 10 years ago. That's Rajashri.
Thank you very much, sir, for your input, for the comment. I would just talk about this context only. Like you said, ADHD, definitely there is some biological changes. So as psychiatrists, we are not denying there is any biological problem or some things there underlying. But the perception got changed, because it's not always the parents, they're permissive. So it is a thing, like we can make the parent understand that the child is hyperactive because of his illness. It's not he's being mischievous, he's a bad boy, he's not behaving well. So their perspective gets changed, and then their reaction to the child is better. So we make them understand that whenever the child is doing something, don't just blame the child or put it on a way that the child is deliberately doing it. Rather, we have to understand that maybe the child is doing this because of his nature, because of his biological nature. He's not able to control. Like those children with impulsivity, they are very much impulsive. They cannot control. We usually make the parent understand that because of this biology, so their perspective gets changed, and they are little receptive and little reciprocal to the children. So whenever they are doing something bad, the parents would understand and react in a way, okay, because of something you are doing that, but you can be better. Like that. Earlier it used to be, oh, you are a bad boy only, always you do the same thing. So the response is changed, and that helps a lot in changing the child's perspective, and the child then gets motivated to control or self-regulate. So that is a good thing of this biology. So there is a good understanding from the parent side.
Thank you, Dr. Altaf. I know there are two more questions waiting in the chat box, but I will stick to the time as requested by the organizers with my kind permission from Indra. Altaf, but may I request you to answer the two questions in the chat box, and what we will do is we will export these your answers to the Expertica website so that all the audience can listen to your answers. And may I now request Indra to conclude this session.
Okay, sure, thank you.
Thank you, Rajashri, for your beautiful coordination. And I thank again Dr. Altaf for his tackling this vast topic in a very beautiful and convincing manner. So I conclude this session here. and waiting for the next sessions to come. Thank you.
Thank you, panelists. Thank you, Chairperson. Our next session for our next session for today is
presentation. Now on behalf of the organizing committee
of COVID-19 and overview by Dr. Kaveri Bhattacharya. And chairperson for this session is Dr. Shayandeep Ghosh, Dr. KMR Karim, and Dr. Sharmila Sharkar. This session is sponsored by Altis.
Hello. Good morning. Audible?
Yes, audible.
Hello.
Hello, Shandita, you are audible.
Yes, this session is sponsored by Altis. I will now play
I'm
the
audible, so
video of Dr. Kaveri Bhattacharya.
hello. Good morning, everybody.
Yes, Shandita, continue. Please continue.
Yes. So good morning, everybody. We are organizing this kind of conference for the first time, both real and virtual, and I think it's already being a great success. So my kudos to the organizers, to Rajorshi and his whole team, to the backup team, to the Expertica team. And we have a very interesting topic, a topic of the day, that is neuropsychiatric manifestations of COVID-19. And to speak on that, we have Dr. Kaveri Bhattacharya. I'll hand over the mic to Dr. Sharmila Sharkar, my co-chairperson, to introduce the speaker.
Good morning to everyone. The topic is now neuropsychiatric manifestation of COVID-19. And you all know that we are passing through a very difficult time, and COVID-19 is actually impacting our day-to-day life. But those who are suffering from COVID-19, what will be their neuropsychiatric manifestation? Dr. Kaveri Bhattacharya will speak on that. And she is the associate professor and head of the department of Midnapur Medical College. She did her MBBS from Arjikor Medical College and MD from Calcutta National Medical College. She is an excellent academician and a brilliant speaker. I would request Dr. Kaveri Bhattacharya, please start your session.
Thank you, Sharmila. I think my recorded video will be shown.
Okay.
So, Sansan, we're not able to hear. Could you just turn up the sound, please?
It's not audible. Physical distancing measures and quarantine results in an widespread anxiety. Social isolation.
Madam, please unmute yourself. Madam, please unmute yourself.
I have unmuted, but it is the recorded one, na? You are showing the recorded version. I have unmuted myself. Should I go live? Psychiatric, psychological stress in general population, outcome of their illness. That patients who are subjects who are infected, they are worried about the outcome of their illness, stigma and amnesia or traumatic memories of severe illness. So this is the study. This is an actually systematic meta-analysis and systematic review. This is a systematic review and meta-analysis which is published in Lancet. This study has compared SARS, MERS, and COVID-19. So we know that viral infections are common and some are known to infect the CNS. and coronaviruses are single-stranded RNA viruses. Most causes mild upper respiratory tract infection, competent individuals, and severe acute Middle East respiratory syndrome or MARS. SARS occurred in 2002 in China and MARS in 2012 in Middle East. And on December 31, 2019, WHO was made aware of severe acute respiratory syndrome caused by coronavirus 2, which is popularly known as COVID-19. So this study covers China. This meta-analysis covered China, Canada, France, Hong Kong, Saudi Arabia, South Korea, Japan, Singapore, UK, and USA. This comprises of 47 studies which involved SARS, 13 of MARS, and 12 of this COVID-19, among which 7 are preprints. That means they are yet to be published till the article has been published in Lancet. Now, among the neuropsychiatric consequences of all three diseases, delirium is common in the acute stage of SARS, MARS, and COVID-19. There is evidence of depression, anxiety, fatigue, and PTSD in the post-illness stage of SARS and MARS, but there are few data yet on COVID-19. In SARS and MARS, in the acute stage, delirium was common, about 27.9%. Other common psychiatric findings were depression, anxiety, and insomnia. Mania and psychosis did occur in a small minority in a study in which all that subjects were exposed to steroids. So probably these manic symptoms were due to side effect of steroid. Other symptoms were insomnia, emotional lability, irritability, pressured speech, and euphoria. These were relatively common. And in these SARS and MARS, after recovery from infection, had sleep disorder, frequent recall of traumatic memories, emotional lability, pressured speech, and euphoria. That means symptoms of manicity were reported by patients and relatives after a short follow-up in the early period of convalescence. And emotional lability, impaired concentration, fatigue, and impaired memory were reported in more than 15% after 6 weeks to 9 months in the late convalescence stage. Anxiety disorder, depression, and PTSD were found. In COVID-19, we know that data on the acute effect of illness are limited. No data exists on the post-illness phase. So, in the acute phase, delirium is probably a significant clinical problem, as I have already stated. And in the longer term, prevalence of depression, anxiety might be high.
আমাকে আনমিউট করে কি হবে? আমি তো আনমিউট করা একই ব্যাপার।
With severe illness requiring ICU admission, neurocognitive impairment might be a feature. This is another selective review that was done by Hans and published in Asian Journal of Psychiatry. According to them, headache and myalgia are commonly noted in COVID-19. Altered smell and taste, cough, asthenia, and myalgia are the most common symptoms. There are reports of encephalopathy, encephalitis, meningitis, stroke, seizures, dysexecutive syndrome, neuromuscular disorders, Guillain-Barré syndrome, and other neuropathies are also reported in COVID-19. And neuropsychiatric sequelae, that means mental disorders due to diseased neurons. These are encephalopathy, delirium, mild cognitive impairment, mood swing, insomnia, suicide, and psychosis. Again, in 0.9 to very small percentage of patients, 0.9 to 4% of infected individuals develop psychotic spectrum disorder. Psychosis may be secondary to viral illness or treatment provided, or maybe due to increased psychosocial stressor that was during pandemic. Now, regarding psychotropic drug usage, they have advised to be treated with psychotropic drugs along with standard treatment for the viral illness. Benzodiazepines like oxazepam, lorazepam, antidepressant like escitalopram, citalopram, antipsychotic like olanzapine, and stabilizer like valproates are safe. But we should remember that the prescription should be individualized, because many of the patients there is some form of coagulopathy resulting in bleeding diathesis. So SSRI, which have a side effect like platelet aggregating inhibiting property, should be restricted. Benzodiazepines in delirium, benzodiazepines are to be avoided, and among antipsychotics, quetiapine or haloperidol, they are preferred in case of delirium. Melatonin is suggested for sleep-wake rhythm and consciousness disturbance, and in severely ill individuals for sleeplessness. Now, what are the causes of these disorders? That may be multifactorial. Direct effect of viral infection because viral infection may lead to neurasthenia and chronic fatigue. Altered sensorium or delirium might be secondary to direct neuroinvasion by virus, maybe central immune activation, secondary to multi-organ failure, hypoxia, metabolic derangement, or treatment related. The immune response in this COVID-19 or SARS-CoV-2 infection is of interest, and there might be a hyperinflammatory state in which there are increased concentration of C-reactive protein, ferritin, and interleukin-6. The link between inflammation and depression is well described and might explain some of the psychiatric morbidity. Now, side effect of few antiviral drugs like oseltamivir, corticosteroid, and interferon that may produce some psychiatric problem. Amnesia, delirium, hallucination, depression, and loss of consciousness are associated with exposure to chloroquine because these patients are given chloroquine. Chloroquine and other antiviral drugs can cause toxic neuropathy and myopathy. Social isolation, the psychological impact of a novel, severe, and potentially fatal illness, concerns about infective others, stigma, these also can cause psychiatric problems. Limitation of all the studies are they lack adequate comparison group and assessment of previous psychiatric disorder. There was no, the subjects were not assessed whether they have initial psychiatric disorder. So it is hard to separate the effects of the infection from the impact of an epidemic on the population as a whole. Now, the effect on healthcare workers. There is a study which is multi-centric and multinational study. This was done in both Singapore and India, and healthcare workers from major tertiary healthcare centers were recruited from Singapore and India. Most of the participants, they have physical symptoms. Actually, this study was done to assess whether there is any relation between physical symptoms of the subjects and their psychological stress. The commonest physical symptoms were headache. That headache may be due to PPE or face shield or mask. And other symptoms are throat pain, anxiety, lethargy, and insomnia. Anxiety was present in 15.7%, depression in 10.6%, and stress in 5.2% study participants. And among these subjects who had these psychological problems, about 50% of each class were moderate to severe degree of depression, stress, or anxiety. 7.4% of study cohorts screened positive for clinical concern for PTSD. They were given DAS-21 for stress, anxiety, and depression, and IES for these PTSD symptoms. Now, depression, anxiety, stress, and PTSD were significantly associated with presence of physical symptoms, and there is a bidirectional complex relationship between psychological stress and physical symptoms. Because all these physical symptoms are very non-specific and they are not specific of COVID-19. They can any time the subject can experience these symptoms, but whenever a COVID frontliner is experiencing any such distress, they may think that they are a bearer, asymptomatic or very mild symptomatic bearer of COVID-19 virus, and they have anxiety that they may infect other family member or other patients. So this can lead to this psychological stress. And one study was done in West Bengal. This was an online study and among doctors, and this was found that 34.9% doctors were depressed, 39.5% have anxiety, and 32.9% were stressed. This was done in West Bengal. Now, effect on internal migrant workers. We know that this is a sector of society that had suffered most during this pandemic. Indian industries, they They had about 100 million internal migrant workers. They are temporary, unskilled work, characterized by low wages, job insecurity, and economic vulnerability. They are predisposed to poverty, malnutrition, cultural bereavement, loss of religious practices and social protection system in their workplace, language difficulty, changes in identity, substance abuse, and poor access to healthcare. These are mainly migrants from rural to urban area, maybe seasonal or maybe during the whole year, either individually or in a group. They are susceptible to new communicable disease, just like COVID-19. They are also prone to develop common mental disorders. Even in the pre-COVID era, it was noted that mental health problems were high among these migrant workers as compared to non-migrants. A large-scale survey was done during this epidemic in China, which documented considerable psychological distress among migrant workers during the pandemic. And one Indian study that noted anxiety, depression in about 28% and self-reported mental stress in 8%. Now, these workers, they have to go under tremendous stress due to economic constraints, due to loss of work during and post-lockdown, and there is reverse migration. They have to forcefully migrate from their workplace to their original place. Mandatory isolation on return to their original place and social distancing increase the feeling of loneliness, causing mental issues, even leading to suicide. The effect on general population, there are several studies which are mostly online studies, and about 5 published new scales are there, which are coronavirus anxiety scale, obsession with COVID-19 scale, fear of COVID-19 scale, COVID stress scale, and questionnaire on perception of threat from COVID-19 scale. Almost all of them were developed as self-report and Likert type scale and validated using online surveys. Only the last one, that is being validated in other languages, but all are in English. Only the scales are in English. All scales were developed in pre-peak period of the pandemic in non-clinical samples consisting of middle-aged adults, a relatively less vulnerable group. So, sensitivity and specificity of these scales are questionable. Now, we should say that in current scenario, self-report scales might be useful as they are short, easy to administer through a paper or a digital platform, and feasible to be used when in self-isolation or quarantine. But it has a limited scope in our country. Most of our general population is they are illiterate and they do not have access of a smartphone. However, a study on general population in West Bengal has been done, and it is online survey, and it is noted that worry and sleep disturbances were common among the responders in the past 2 weeks. It didn't use any scale, any specific scale. It used a questionnaire, self-designed questionnaire. So this was their finding. And to conclude, we can say that there are many ways in which mental health might be adversely affected by a pandemic. Most people do not suffer from a psychiatric disorder following coronavirus infection, and the COVID-19 pandemic is still evolving, and the medical fraternity is posed with huge challenge. And thank you for your questions.
Thank you, Kaveri, for an excellent and detailed presentation. And I would now like to hand over the mic to Dr. Shormila Sarkar, to take the questions that we have. Over to Dr. Shormila Sarkar.
Do you have any question? I can't see anyone in the chat box.
No questions then?
No questions. So we can see that apart from psychological stress, there are several factors that are actually influencing the neuropsychiatric manifestation. That is the immune system alteration, the hypoxia due to this viral infection, and also the drug side effects especially. These all leads to the neuropsychiatric manifestation of the COVID positive patient. But the psychological stress or the economic burden also leads to some psychiatric problem or psychiatric manifestation in general population, in migrant population, and also to the healthcare provider. And the study shows that about 20 to 25% patient suffering from any kind of neuropsychiatric problem. But when we consider the healthcare provider, that is doctors, nurse, or other person, the percentage is going up. So we are the most vulnerable people, and we have most chance to develop some kind of depression or anxiety. So with this, I would
Just a point, Sharmila.
yeah.
I also think that about the neuropsychiatric manifestations which we are at present noticing, the picture could change over the next few months or a year. So that could be there. That is what the question comes now from Ranjan, that what about the delayed consequences of this viral load? So if Kaveri is there, she could answer this. Kaveri, is Kaveri there?
Hello. Thank you, Shandip. Am I audible?
Yeah.
Yes, Kaveri. Yes, Kaveri, you are audible.
Yes. The question is whether these COVID-19 will produce a delayed psychiatric symptom. As we have seen from SARS and MERS, our experience from SARS and MERS are the two coronavirus epidemic, that the patients in the long run, they do not have any psychiatric problem. In the initial phase, as I have mentioned, in the initial phase, they have like delirium, etc. And in the early convalescence phase, they often have slight manic-like symptom. And in the late convalescence phase, they have some memory problem, some anxiety, some depression, etc. But in the long run, they do not have any psychological problem. So from that, as COVID-19 is still ongoing, in few places they had reached peak, and in few places they are not. So it is now difficult to say what will happen in long run, but they are in acute stage, they are associated with delirium, and in the long run they are associated with depression, anxiety, in general population, especially depression, anxiety, and stress. But I think in the long run there will not remain any psychological morbidity in general population, or may not be. If there is no neurological brain injury, if there is no like CVA or other encephalitis, in that cases there may be consequences, but in mild asymptomatic cases or in general population, there will not be any psychological burden in the long run.
Kaveri, there is possibly another question from Abidda.
Yes.
Could you get it, Kaveri?
PTSD-like features had been seen in SARS and
PTSD-like features in
Yes. They have given also that PTSD-like features have also seen in frontline health workers. In the multicentric study, they have given IES, impact of event scale, and it has shown actually all the studies that I have done, they have given either DAS21 along with IES, impact of event scale, and we have seen that the PTSD symptoms are quite common in health workers. And in SARS and MERS, I can say whether they have, yes, PTSD symptoms are also seen in late convalescent phase of SARS and MERS. Hello.
Hello.
Yes, Sharmila, over to you.
So it is an excellent presentation by Dr. Kaveri Bhattacharya, and I think there is no question. So we can conclude here. I would like to thank the organizers, especially Dr. Raju Shigothakurta and team for organizing such an excellent academic program. Thank you.
Thank you, Sharmila. Thank you, Shandip.
Thank you, all the chairpersons and Dr. Kaveri Bhattacharya as a speaker. This session is ends here. Now we are going to open the virtual stall and the exhibition and a tea break. So I will request all of you, whoever is present in the virtual platform, kindly go into the exhibition hall and you can showcase all the stalls, our partners and the sponsors over there. Kindly do visit our exhibition areas. Thank you. Our next session will start from 11:35. Our next session will start from 11:35. morning, everyone. We will move to our next symposium, which is going to take place now after the tea break. So the symposium is called Treatment Paradigms in Neuropsychiatry, Mechanism and Efficacy. In this symposium, we have as a speaker Dr. Ovijit Chakraborty, Dr. Shubir Bhattacharya, and Dr. Devabroto Mojumdar. And as a moderator, we have Dr. Debashish Sharnal, and as a chairperson, we have Dr. Dilip Mondal. This particular symposium one is sponsored by Torrent. So I will ask moderator to take the control and kindly start the session. Sir, can you hear us? Dr. Sharnal? Dr. Mondal? Is Dr. Mondal is present?
Yes, he is present. Dr. Dilip is showing. Please ask him.
Yes. Kindly start, sir. Dr. Dilip Mondal, you can introduce Dr. Ovijit Chakraborty. Dr. Chakraborty is going to give the live presentation from his home. So if you kindly introduce Dr. Ovijit Chakraborty, and he can start.
I am sorry, but Ovijit is from where? Really, hello?
Yes, sir, we can hear you. Please go ahead.
Now,
we can hear you, sir.
Yeah, but Ovijit, the details of the speaker, I don't have.
He is here with us, sir. You please continue. You introduce the speaker.
Sir, senior resident at Calcutta National Medical College.
Okay. Thank you. So, Ovijit Chakraborty is a senior resident of Calcutta National Medical College and is a very bright student. So, let us see. He is going to present. The topic is that OCD, right? Hello?
Yes.
Yeah, that deep brain stimulation in OCD, right?
Right.
Thank you. Yeah, please.
Dr. Chakraborty, you can start your presentation.
এই তো একটু জাস্ট ঢুকলাম আমি তো
Hello?
Yes, sir.
Am I audible?
Yes, sir. Could you do full screen, please?
1 second, please.
Full screen. No, wait. On the bottom, when you see plus minus, there is a button there. Yes.
Now it is visible?
Perfect. Please go ahead, sir. Thank you.
Good morning, respected chairpersons. Good morning, everyone. I am Dr. Abhijit Chakraborty, now working as a senior resident in Calcutta National Medical College and Hospital. My topic of presentation is deep brain stimulation in OCD. As we all know, that evidence-based guideline recommended that selective serotonin reuptake inhibitors and behavior therapy as the first line treatment for OCD. But around 40 to 60% patients do not respond in either of the treatment. Around 30% of such patients respond to the augmentation therapy with maybe antipsychotic or any other augmentation therapy. It has been estimated that around 10 to 20% patients are refractory to all above available pharmacological and psychological treatments. Many of these patients have chronic, severe, and disabling symptoms causing significant social and economic burden. Deep brain stimulation have a role in this population, and in these patients, that means the patients who are chronic and severe OCD, who are refractory to available non-invasive treatment strategies. Now, coming briefly to the neurobiology of obsessive compulsive disorder, several studies and recent meta-analysis using functional and structural neuroimaging highlighted the abnormal activity and neurochemical abnormalities in the CST, the cortico-thalamus-cortical circuit, in the patients with OCD, including the orbitofrontal cortex, the anterior cingulate cortex, prefrontal cortex, and ventral striatum. Main hypothesis is that obsessive compulsive disorder is associated with the hyperactivity in the CSTC loop. The mechanism of DBS in OCD is still unknown, but the possibility of its therapeutic effect could be explained by global inhibition in this network. Now coming to the deep brain stimulation. With the advent of the new stereotactic surgical technique and the advances in the neuroimaging in the last few decades, we have seen that the specific target in the brain can be reached with a very much good accuracy. And DBS is the implantation of electrodes in a very specific subcortical region for neuromodulation. And understanding the neurobiology have improved the efficacy and safety of this procedure. We all know that for Parkinson's disease, FDA has approved the DBS since 2002. For essential tremor, it has been approved from 1997. For dystonia, it has been approved since 2003. And for OCD, it is approved since 2009. After meeting et al. Presented a paper of DBS for OCD in 1999, and subsequently by research, FDA has approved DBS for OCD since 2009. Now coming to the indication of OCD, indication of DBS in OCD. The main indication is the treatment refractory OCD. The minimum basic criterion is the treatment refractoriness. We have to establish that the patient is not responded to the evidence-based non-invasive treatment, including the pharmacological and psychological treatment. The most of the centers doing DBS are of the criteria that patient is non-responsive to at least 3 of the adequate treatment trials of serotonin reuptake inhibitor, including comipramine, with an adequate trial of cognitive behavior therapy, and the illness should be of sufficient severity, causing significant socio-occupational dysfunction. And most centers exclude that the severe personality disorder, those with medical comorbidities, and severe other psychotic disorder, some bipolar disorder are excluded from giving DBS. And as DBS requires a regular follow-up and long-term follow-up for programming and monitoring of effects and adverse effects, so patients who will be available and who will be for long-term monitoring, they are considered for DBS. And now there is a selection criteria for DBS by Indian Psychiatric Society guideline. The Y-box score more than 28 and chronic unremitting OCD causing substantial distress and impairment in the functioning. The following treatment options are tried simultaneously, trying systematically without any effect of symptoms. That is, 2 adequate SSRI trials for 3 months each, clomipramine trial for 3 months unless poorly tolerated, 2 augmentation trial, one of them being atypical antipsychotic like risperidone, aripiprazole, clomipramine, memantine, etc. CBT trial in 20 hours of ERP session, and they are demonstrated non-efficacy or intolerability to the therapy. Previous treatment trials have not been abandoned prematurely. Patients who are giving informed consent, they are willing to participate in pre-operative evaluation and post-operative follow-up. Relative contraindications are comorbid intellectual disability, psychosis, bipolar disorder, severe personality disorder, clinical and significant unstable neurological illnesses. And I have already told the contraindications. The patient are 18 years of age, significant comorbid psychiatric diagnosis, significant unstable neurological illness, unable to provide informed consent. Now the pre-surgical workup. The diagnosis of OCD and its presence of other comorbidities should be carefully evaluated by the treating team, and usually by clinically and some structured interviewing method like mini or speed. Symptom severity should be assessed by Wyburg scale. Revisiting the previous treatment should be again thoroughly assessed, whether patient was taken the medicines properly, whether the adherence of treatment was there, the adequacy of the CBT should be monitored. Comprehensive physical and neurological examination to be performed and documented properly. As a surgical treatment commonly performed with usually under LA or some minimum protocol, so routine blood investigation should be sufficient. A structural MRI should be done to rule out any brain pathology. The neuropsychological testing would include the test for intelligence, attention, memory, and a frontal lobe functioning, like frontal lobe assessment battery. A personality assessment like MMPI should be done, but it is not recommended by most of the guidelines, but is usually carried out. Now the components of OCD. Usually DBS has 3 components. In the 3-stage DBS is done. Number 1 is the surgery for stereotactic image-guided insertion of electrodes through the bilateral bar hole. It is performed under local anesthesia and mild sedation. The electrodes have multiple conducts, usually 4 per side. Intraoperative macrostimulation is done for monitoring of adverse effect. The patient is usually awake during the surgery procedure, so the effect of stimulation on speech and other critical motor functioning can be monitored on table. Usually there are 2 targets which are done in OCD. Number 1 is there are striatal targets, that is anterior limb of internal capsule, the ventral capsule or ventral striatum, nucleus accumbens, bed nucleus of the striata terminalis. These targets are close to each other and there is a substantial workup between the above targets. These targets are collectively called the striatal DBS, and it is the most common area of focus for DBS. Next is subthalamic nucleus. The subthalamic nucleus is most widely known for the site for idiopathic Parkinsonism disease. Hence, the most neurosurgeons are most efficient to do a DBS in this area, and recent evidence has that in DBS also in putting an implant also in the subthalamic nucleus can also help in OCD. There are other sites also like inferior thalamic peduncle, medial dorsal nucleus of the thalamus, median forebrain bundle. These are the preliminary evidence and need to be further researched. Now the second stage. Second stage involves the subcutaneous implantation of the pulse generator, which is
হ্যাঁ নতুন জয়েন করেছে। তাহলে ওদের ডিক্লারেশন ফর্ম ওদের মানে একজন, আরেকজন তো জয়েনই করেনি। আমাদের তো ক্লার্কটার কেউ নেই, আমাদের আবার ডিপার্টমেন্টের অফিস কোথায়? হুম 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 ঠিক আছে, ওকে। হুম হুম
স্পিকার কোথায়?
আমারই গন্ডগোল না, কেউ শুনতে পাচ্ছি না।
হ্যালো, কিছুই তো শুনতে পাচ্ছি না।
হ্যাঁ সেই
কেউ শুনতে পাচ্ছি না।
আমাদের ঘাবড়ে যাচ্ছে তো।
ডিপ ব্রেন স্টিমুলেশনের দরকার হতে পারে।
অভিজিৎ গেল কোথায়? ওকেই তো মনে হচ্ছে মিউট করে দিয়েছে নাকি?
Next presentation is Dr. Shubir Bhattacharya. I will.
না এই রঞ্জন, শোনাই তো গেল না, এর কি হলো? ও গেল কোথায়?
ভালো বলছিল তো বেশ।
অচলায়তনের রাজা।
আরে ও নেই তো দেখতে পাচ্ছি, ও কোথায়?
গেল কোথায়?
ও কোথাও এমন একটা জায়গা থেকে করছে, হয়তো নেটওয়ার্ক অ্যাক্সেসটা ভালো নেই।
চেম্বার থেকে করছে নাকি?
হ্যাঁ, পেছনে তো চেম্বারের ব্ল্যাক দেখলাম।
একদম চেম্বার থেকে করলে সেখানকার নেটওয়ার্ক কিরকম আগে জানতে হবে।
সেটাই
খুবই খারাপ অবস্থা। না ওকে একটা কল করে দেখা যেতে পারে যে ও কি অবস্থায় আছে, তাহলে ওর প্রেজেন্টেশন তো ভালো হচ্ছিল, শেষ করতে দেওয়া উচিত।
দেখছি অভিজিৎকে কোথায়।
Okay, I'm sharing the next presentation by Dr. Shubir Bhattacharya.
আগেরটাই শেষ হলো না তো?
আগেরটা শেষ হলো না তো?
আগেরটা শেষ হয়নি তো?
আগেরটা শেষ না করে
আগেরটা শেষ কনক্লুড করতে হবে, এইটা হয় না।
তাহলে কনক্লুড করুন।
ওকে একটা চান্স দেওয়া উচিত যে ওর কোনো কারণে নেটওয়ার্ক ডিস্টার্ব হয়ে থাকলে ও যদি ইমিডিয়েটলি লগ ইন করতে পারে তাহলে ও শেষ করে নিক।
ওর নাম্বারটা আছে কারো কাছে?
আমি কল করছি। দেখছি আমি।
টাইম কনস্ট্যান্টের ব্যাপার আছে কিন্তু।
করোনাতে তো 5 মিনিট টাইম নেয় না, করোনার গল্প শোনাচ্ছে।
टाइम कांस्टेंट ব্যাপার আছে।
उनसे भेदभाव मत कीजिए।
অভিজিৎ ভট্টাচার্য এসেছেন, উনি এসেছেন আবার।
কনফারেন্সে আছি।
স্যার আপনি কি আবার বলবেন?
হ্যাঁ করবেন তো। ওকে লেফট ওভার স্লাইড গুলো বলে যাক।
স্যার আমরা কি তাহলে পরে নেক্সটটা স্টার্ট করব?
অভিজিৎ পার্টিসিপেন্টের মধ্যে নেই।
হ্যালো
অভিজিৎ স্যার,
হ্যালো
অভিজিৎ চক্রবর্তী, আপনি আপনার লাস্ট স্লাইড গুলো বলুন।
আচ্ছা ওকে, আই এম অডিবল?
yes, you are
audible.
আপনি
Yes,
লাস্ট
you are audible.
আপনার রিমেনিং স্লাইডগুলো দেখান আপনার রিমেনিং স্লাইডগুলো দেখান
Okay.
Hello.
Hello. Sorry, I was out of way.
Yeah,
now
Dr.
The second stage. Hello.
Yeah, Dr. Chakraborty, share.
The second stage is.
Share your screen. Share your screen.
Now this. Hello. Hello.
Yeah, continue.
Hello.
Continue, sir.
শোনা যাচ্ছে আগে স্লাইড ফরওয়ার্ড করো।
আচ্ছা। Now the second as subtraction of the pulse generator, which is commonly intraclavicular space. There is an extension wire connecting the electrodes to the pulse generator that are tunneled usually subdermally through the neck to the scalp. And now the third stage involves the programming. Various stimulation parameters such as polarity, amplitude, frequency, and pulse duration can be modulated to obtain a balance between the effectiveness and the adverse effect of the treatment. Programming is generally done in an outpatient basis, which communicates wirelessly to an implanted pulse generator. For patients with Parkinson's disease and other movement disorder, the programming is relatively straightforward, as clinical improvement can be observed immediately after modulation of the stimulant. But improvement in the OCD and other psychiatric disorder is noticeable only after few months of the period. Hence, the parameter is adjusted on a trial or error basis based on the adverse effect, immediate subjective effect of the mood, energy, anxiety, and improvement on the OCD symptoms in a longer term. Although the exact mechanism of OCD-DBS is not clearly known, it is postulated that high-frequency stimulation in the regions result in functional lesion of the surrounding tissue, which may disrupt the dysfunctional circuit. This inhibition has been explained to various mechanisms, including depolarization blockade, exhaustion of a neurotransmitter pool, a release of the inhibitory neurotransmitters. The therapeutic success of DBS depends on identifying the proper brain target, accurately targeting the site with a lead, and delivering electrical current of proper amplitude and frequency. And here, the deep brain stimulation and the clinical response of various sites of obsessive compulsive disorder has been proved. A meta-analysis shows that all DBS studies took some improvement, and Y-box severity score is used for most of the patients. The meta-analysis is mostly done that in 2016 that found that the severity reduction of Y-box score is 45.1%, along with response rate of around 60% of the patients. The difference between the ventral tegmental area, ventral stratum, and the subthalamic nucleus target are usually same. And some long-term reports have shown that the initial improvement has been sustained over the period of a long-term follow-up. And the other areas like base nucleus of terminalis may be of some value. Now the effectiveness. As I've already told that all of the studies show some effectiveness. There was no demonstrable superiority between the stratum and the subthalamic nucleus. Now the predictors of the outcome. The predictors of outcome was the older age of onset and the presence of anxiety or religious obsession was predictor of a better outcome, and then any other obsession. The induction of the smile or laughter during the intraoperative stimulation was found as strongly predictive of the good response. Now coming to the adverse effect. Adverse effect usually complication of the surgical intervention, complication of the device, and the adverse effect of the stimulation. Complication of the surgical intervention include intracerebral hemorrhage during the lead implantation, which is possibly higher risk of subthalamic nucleus DBS than the striatal DBS. The risk of postoperative infection, which mainly meningitis or any infection in the chest wall pocket. The risk of postoperative seizure or headache may be there. Device related was the blockage of the lead or the extension wear around 2%, and a device related discomfort also may occur. And there is a anxiety of depletion of the battery of the DBS system. The adverse effect of the stimulation is dyskinesia, dysarthria, eyelid apraxia, gait disturbances, depression or suicidal ideation, mania, there are increased libido. These are usually reversible and modified on parameters of the stimulation. One thing to be mentioned that their studies do not found any significant deterioration.
Abhijit, try to complete the session at the earliest because there are 2 more speakers. Okay. We are running short of time. Please try to complete this your presentation as early as possible. I understand your problem. You have network glitch and other things, but please try to complete the session as early as possible.
Now the problem of DBS or lesion surgery, that a debate is still going on. Now I'm showing that a difference between the DBS and the gamma knife surgery, and it has been shown that both are, in case of efficacy, both are most comparable. Whereas gamma knife surgery usually less expensive, it has post-surgical follow-up is less frequent, but for DBS it is more expensive. The batteries require periodic replacement and more follow-up for programming is needed. And improving the effectiveness, we can adaptive or closed loop system, and you can use rechargeable pacemakers also. And there is the evidence that if we combine DBS, CBT with DBS, immediately after the DBS, there is some good result also. Now in conclusion, during the last decade, the DBS has appeared as an useful and most widespread treatment research for refractory OCD. Benefits of DBS are outweighs the risks of the patients of this refractory population. Advances techniques and increasing knowledge of neurobiology are likely to bring in further progress in this region. Thank you. Thank you very much.
Thank you, speaker. We have 2 more presentation with the permission of Dr. Devashish Shanal. I will now play our eminent speaker, Dr. Shubir Bhattacharya presentation.
Okay. Kindly play his video.
Yes.
The speech is in a video format.
Yes, I'm playing.
Kindly play the video, please.
Yes, I'm playing, doctor. Taking up too long.
Good morning, everybody. At first, I must thank the organizing committee of Psycon 2020 for giving me the opportunity to present before our respected delegates. In our second part of current symposium, I'm going to present a short presentation on VNS, that is...
Please start the presentation.
Yes. Doctor, give me 1 second. I'm just sharing.
সুবীর তো কথা বলা যাচ্ছে।
হ্যাঁ ইন্দ্রদা, শোনা যাচ্ছে তো?
হ্যাঁ, না শোনা যাচ্ছে কিন্তু ইয়ে হচ্ছে না,
আচ্ছা, ওটা ভিডিওতে আছে, ভিডিও ফরম্যাটে। ভিডিওটা চালিয়ে স্ক্রিন শেয়ারিং করলে বা স্ক্রিন শেয়ারিং করে ভিডিও চালালেই হয়, নয়তো
হ্যাঁ।
আমার এখান থেকে আমি তখন স্ক্রিন শেয়ারিং এ ভিডিও চালাতে স্টার্ট করব। একবার দেখে
সেটা জিজ্ঞেস করে নাকি করবি?
Can you see that?
সুবীর, বলছি
হ্যাঁ।
বলছি যে যদি সেটা করতে পারো ভালো হয়, তাহলে অডিও কোয়ালিটিটা বেটার হয় এখানে।
হ্যাঁ,
যেটা
তুমি
ঠিক আছে, তাহলে আমাকে
সুবীর তো নিজের ইয়েটাই শেয়ার কর, তোর ল্যাপটপেরটাই শেয়ার কর সুবীর।
সেই
আচ্ছা ঠিক আছে, জাস্ট একটু হোল্ড কর। হ্যাঁ,
দেবাশিস গালে হাত ছাড়ো, তা নাহলে হবে না।
তাহলে হাত এ তো বেশ গন্ডগোল হয়ে যাচ্ছে, টাইম
হ্যাঁ, তুমি
গন্ডগোল
গালে
হয়ে
হাত
যাচ্ছে।
দিচ্ছ, ইন্দ্র মাথায় হাত দিচ্ছে।
হ্যাঁ, মাথায় জলও ঢালতে হতে পারে, টাইমের যা গন্ডগোল হয়ে যাচ্ছে দেখতে পাচ্ছি।
হ্যাঁ, শুরু করে দে তো, এই যে এসে গেছে তো।
শুরু করো সুবীর।
অ্যাকচুয়ালি মনে হচ্ছে কিছু একটা। হ্যালো,
শোনা যাচ্ছে বলো।
মনে হচ্ছে এই ভিডিওটাতে কোনো একটা প্রবলেম হচ্ছে। জাস্ট একটু হোল্ড করো, আমি দেখছি আরেকবার। হ্যালো সুশান্ত দা, চলছে কিন্তু সাউন্ড আসছে না একদম।
তো সুবীর ডাইরেক্টলি লাইভ বললে কি ক্ষতি আছে?
সুবীর লাইভ প্রেজেন্টেশন, স্টার্ট দ্য লাইভ প্রেজেন্টেশন।
মানে তুই এমনি সুবীর ওখানে যেরকম চলছে চলুক, তুই ইউ প্রেজেন্ট ইট ইয়োরসেলফ ডাইরেক্টলি আর কি।
আমি তো
ডাইরেক্টলি প্রেজেন্ট করো, ওই ভিডিওর অপেক্ষায় থেকো না, টাইম কিল হয়ে যাচ্ছে অনেক।
আমি স্ক্রিন শেয়ার করতে পারছি না, কারণ ওখানে চললে আমি এখান থেকে স্ক্রিন শেয়ার করব না।
স্ক্রিন তো হচ্ছে
না, ওটা ওখান থেকে ভিডিওটা চালিয়েছে।
ভিডিওটা ব্লক করে দিলেই তো তুমি শেয়ার করতে পারবে, নাহলে পারবে কি করে?
সুশান্ত বাবু, ভিডিওটা বন্ধ করে দিন, সুবীর ডাইরেক্টলি স্ক্রিন শেয়ার করুক।
দুটো তো একসঙ্গে করা যাবে না, ওটা বন্ধ করলে
you can share your screen now.
Sir, are you able to share your screen?
না, শেয়ার করতে পারছি না, প্রবলেম হচ্ছে, শেয়ার করতে পারছি না।
Sir, please open your presentation first, then click on share screen.
এক মিনিট দাঁড়ান, এক মিনিট জাস্ট।
You have the backup presentation with you, Sushant Babu?
Yes, I have a PPT as well of Dr.
Yeah,
Subir.
just play the PPT. Just play the PPT. Don't play the video.
Okay, I will
just share the PPT from
you share the PPT from your end, and
yes, I think it's better. The PPT will be better.
And Shubir will say next slide. So that's
right.
Okay. I will do that. I will do that right now. Okay.
Make it full screen.
Sir, can you see now?
Yes, make it full screen. Absolutely fine. Shubir, please go ahead.
Am I audible?
Yes, absolutely fine. You're audible.
Good morning, everybody. At first, I must thank to the organizing committee for giving me the opportunity to present in Psycon 2020. In our second part of current symposium, please don't forward the slide. If I say next, then you can only, yes, okay. In our second part of our current symposium, I am going to present a short presentation on VNS, that is vagus nerve stimulation in depression. Next. VNS, like other neuromodulation techniques like DABS and RTMS, is a new therapeutic field in the psychiatric treatment. It gets approved by the FDA for the treatment of severe recurrent unipolar and bipolar depression in July of 2005. Vagus nerve, which is the 10th cranial nerve, has both afferent and efferent fiber and also sensory and motor fiber. When vagus nerve gets stimulated by vagus nerve stimulation technique, the neural psychiatry, which is responsible for depression, gets modulated and ultimately leads to the activation of or modification of frontal lobe prefrontal cortex and leads to relief symptom of depression. Next slide. Now, why VNS was introduced? There are limitations of existing treatments for clinical depression. In study outcomes, there are only ultimate response rate was only 47% and remission rate was 28%. With psychotherapy like cognitive behavior therapy, the response rates was 45% at 8 weeks and 58% at 16 weeks. Though electroconvulsive therapy or ECT has acute response rate of 79% and remission rate of 75%, but due to its stigma, its use is decreasing day by day and is not prevalent nowadays. Next. So 20 to 40% of depressed patients failed to respond adequately to our current treatment protocol for depression. Next. Now, how VNS was introduced? VNS was approved for pharmacoresistant epilepsy in Europe in 1994 and in the US in 1997. There were anecdotal clinical observations of mood improvement in epilepsy patients. So, observing the findings, later scientists or researchers studied pilot prospective study of VNS effects on mood in epilepsy patients treated either with VNS device or antiepileptic drugs. They found that there was significant mood improvement with VNS group with VNS stimulation in VNS group at 3 months. Next. The same finding was independently reported in a European study at about the same time with a group of epilepsy patients with mild depression. Next. The first pilot study to study the VNS effect on depression enrolled 30 patients with major depression of both unipolar and bipolar patients having major depressive episode of at least a 2-year duration and having history of failed for 2 adequate antidepressant trials. In that study, rapid cycling bipolar course and psychotic depression were excluded. Following surgical implantation of vagus nerve stimulation pulse generator and a 2-week recovery period of no stimulation, VNS stimulation was given along with existing fixed medication periodically for 10 weeks. Next. The result at 10 weeks were promising with a response rate of 40% and a full recovery or remission rate of 17%. Next. In the second pilot study with VNS in depression, which combined the initial study cohort with a further 30 treatment-resistant depressed unipolar and bipolar patients for a total sample size of 60. And again, in the case following surgical implantation and a 2-week recovery period of no stimulation, VNS stimulation was given periodically along with existing fixed medication for next 10 weeks. Next. And again, in this case, the response rate was 30% on the 28-item HAM-D scale, 37% on the clinical global impression improvement scale, and 34% on the MADAR scale. Again, remission rate was 15% on 28-item HAM-D scale. Next. But later, Ras et al. In their first large-scale controlled multicenter trial, that was a controlled pivotal trial of VNS in TRD, compared VNS with VNS SAM stimulation Again, in this case, following surgical implantation and a 2-week recovery period of no stimulation, VNS stimulation was along with existing fixed medication for next 10 weeks. Next, but in this case, the primary outcome was 15%, and the response rate in SAM or placebo group was 10%, and those were not different from each other. But on the self-report measure, the response rate was 17% for the VNS group versus 7% on the SAM or placebo control group. So Ras et al. Concluded that VNS is not useful, or VNS has no effect on treatment-resistant depression. Next. But the researchers were not happy with RAS because 10-week trials of VNS might underestimate its potential to treat TRD patients. Marangel et al. In their study to study 1-year outcome with VNS compared to treatment as usual. Again, in this case, following surgical implantation and a 2-week recovery period of no stimulation, VNS stimulation was given periodically along with existing fixed medication for 1 year. In this case, the time period was 1 year. Next. In this study, the response rate sustained from 40 to 46%, and remission rate increased from 17% at 3 months to 29% at 1 year. This finding ultimately led the manufacturer to submit to the FDA for approval for VNS as a novel treatment for treatment-resistant depression. Next. In 2005, the FDA approved VNS for patients with depression, unipolar and bipolar, failing to respond to 4 or more antidepressant treatments. Next. Please, the primary indications by FDA were chronic or recurrent depression, unipolar or bipolar, with a history of failure of the depression to respond to at least 4 antidepressant. The patients did not require to have failed TCT to be eligible. Psychotic depressions were not approved. VNS was approved for adults 18 years of age and older. Only neurosurgeons and vascular surgeons were allowed or approved to implant the lead, and trained psychiatrists can only program the VNS device. Next. After giving approval to VNS for depression, FDA received criticism from various researchers. Researchers said that for giving a drug as a therapeutic or as a treatment approach for any condition, there must be 2 positive, prospective, double-blind, placebo-controlled trial for the support for the efficacy of the drug. But FDA approval for VNS in depression rested on the long-term outcome data, which had a non-randomized active control group rather than a SAM or placebo control group. FDA later cleared their view. They said that it will be unfair to wait for 1 year for a depressed patient by not giving them any treatment. And again, VNS implantation is a surgical procedure rather than a drug only. So having one long-term outcome data is sufficient to approve for VNS. Next. VNS system with pulse generator generally includes 2 things. The pulse generator is just like the cardiac pacemaker, near about 2 inch in diameter and 2 ounce in weight, generally implanted below left clavicle, and the wire system includes electrode lead with helical windings that the surgeon wraps around the left vagus nerve, around carotid sheath. Next. This is a schematic illustration of VNS with pulse generator implanted in the left chest wall and electrode attached to the left vagus nerve in the neck in the carotid seat. Next. Now, how VNS works. As I said earlier, when vagus nerve gets stimulated via VNS pulse generator, it modulates the neural psychiatry which is involved in depression and ultimately leads to the activation or change in prefrontal cortex. VNS induced synchronization of orbitofrontal activity on the EEG, and it was also found to induce emergence of frontal slow waves. Researchers also found elevated serotonin metabolites, that is 5-hydroxyindole acid and GABA levels in the CSF following vagus nerve stimulation. Next. Now, how to dose VNS pulse generator? It is generally done on OPT basis and take about 30 minutes. There are 4 principal settings that are current charges, pulse width, frequency, and duty cycle, which ones have to monitor. The current charge is generally maintained between 0.25 to 3.5 milliampere with averagely needed current charge of 1 milliampere. The pulse width is generally maintained between 130 to 1000 millisecond with an average of 500 millisecond. Frequency is generally maintained between 1 to 30 Hz with an average of 20 Hz. And in the duty cycle, the pulse generator on time is maintained between 7 to 60 seconds with an average of 30 seconds. And the pulse generator is kept off for 0.2 to 180 minutes with an average of 5 minutes. The pulse generator is generally modulated. The pulse generator is generally modulated on weekly basis for the first month, every 15 days for the next second month, and thereafter it is modulated every month on every monthly basis. Next. That's it. Next. Vagus nerve stimulation is well tolerated and its safety is well established. The surgical complications are uncommon and generally includes wound site infection, which can be easily controlled by antibiotics. The cardiac complication, which generally includes asystole, was found during the implantation of the wire in the carotid sheath and during the first stimulation. It was found in 1 per 1000 patients, but there was no reported death during the procedure. The side effects that is related to stimulation were hoarseness, dyspnea, and cough. Again, these side effects can be easily controlled by reducing the charge or by intermittent omitting the device or shutting off the device. The psychiatric adverse events were manic and hypomanic switches or hypomanic episodes that were also found in very few cases. And again, those adverse events can be easily controlled by reducing the charge or intermittent switching of the device. Next. In the 4 main study with VNS, the common adverse effects with VNS were noted were hoarseness, cough, dyspnea, neck pain, pain at the site of implantation, headache, dysphagia, vomiting, nausea, and dyspepsia. Next. Now, there was a controversy with VNS that VNS was noted to increase suicide rate. There were a 2-point or greater increase in score on the suicide item from baseline was found in 3% patients of SAM or placebo group and in 2% case of VNS group. But the real fact was, in longer term, after 1 year of VNS, most patients, near about 56%, had a reduction in suicide score. Khan et al., when challenged the controversy, found that the suicide attempt rate in the antidepressant group in their study, in the antidepressant group was 2.9% and 2.7% on placebo group. and those were not different from the VNS group. So we can say that in longer term, VNS has no effect on suicide, or rather can decrease the suicide score. Next, VNS was well adherent to the patients. Once implanted, the VNS device can remain functioning for up to 8 years. The treatment delivery is automatic and assured. Russ et al. In their study found that the continuation rate of for the VNS device was 90% at 1 year, and the discontinuations were mainly due to or secondary to adverse events. Next. Now, if we compare VNS with ECT, we can find that unlike ECT, no adverse cognitive effects were noted with VNS, and it is free of stigma. But the therapeutic benefit is clearly slower than ECT. Researchers propose that we should view ECT and VNS as complementary to each other, not as a fighter. Next. Now, if we going to prescribe MRI to a patient who has VNS implant, we should give attention to the point that MRI of the neck or spine is contraindicated with VNS implant, but MRI of the brain with a special chain receive coil is permissible. Next. Later, VNS was modified to transcutaneous VNS, that is a wearable devices that had that convey electrical impulses that targeted at ear at cutaneous branches of vagus nerve. Later, transcutaneous VNS was tested in clinical trials for treatment-resistant major depressive disorder as of 2017. Next. A study to found efficacy of transcutaneous auricular vagus nerve stimulation in treating major depressive disorder, researchers concluded that transcutaneous VNS therapy can effectively ameliorate the symptoms of major depressive disorder. Next. Next. Now, in summary, to conclude, VNS is an important new addition, neuromodulation technique to treat treatment-resistant depression, both unipolar and bipolar patients. VNS is FDA approved in 2005. VNS appears to be a very safe, and studies reviewed that efficacy is promising. It is less therapeutic than ECT, but it has less stigma, and we should view ECT and VNS as complementary to each other. Next. Thank you. Thank you very much. Thank you for giving me the attention.
Hello.
Yes.
We can start off with the next speaker.
Yes, the next speaker is Dr. Deobroto Mojumdar. So I will play his video right now.
না পেছনে আরো বাকি
a threat to patient's life, but it can be a disintegrating experience for a clinician. It needs rapid intervention, intense engagement in therapeutic alliance or crisis intervention would be the only resort for most cases, as all the psychotropics need time to develop their effect. This is exactly why the new agents ketamine and esketamine is luring us. It may fill the gap. Let us examine if it can, and if yes, how. Well, suicide scenario in India itself stands third in incidences. Last year, according to NCRB, there had been more than 12,000
Devabroto,
suicides.
is there no sound associated with this? I can hear no sound.
না না এটা রেকর্ডেড তো রেকর্ডেড হলেই সাউন্ড আসতে হচ্ছে
সাউন্ডটা খুব বাজে
বাজে বলে না, একদমই সাউন্ড শোনা যাচ্ছে না। এটা বেটার হচ্ছে দেবব্রত, তুমি দেবব্রত স্লাইডটা শেয়ার করো, এই ভিডিওটা অফ করে স্লাইড শেয়ার করে দাও, তুমি নিজে বলো।
বলছি আমার খুব সুবিধা হয় যদি ওই সুশান্ত যদি একটু পোস্ট রাইটটা দিয়ে দেন, তাহলে আমি শেয়ার করে দিচ্ছি।
হ্যাঁ সেটাই করো, ভিডিওটা অফ করে দাও, এ কিছু শোনা যাচ্ছে না, প্রেজেন্টেশনটা মাঠে মারা যাবে।
Sir, will you share the
I can Sushant, can you give me the
কন্টিনিউ হলে চলবে না, শেয়ারিং রাইটস দিতে হবে।
Sharing rights is already given, sir. You can share.
Sir, we have already given the sharing rights, so you can share your.
আমার মনে হচ্ছে subsequently also for the rest of the sessions of today and tomorrow, those who are physically present should share their slides. Those who are not physically present for any reason, physically mane even on the web, they should share their slides. It's much easier.
Is my screen there?
তো start করো।
Can you see my screen? Right.
Yes, we can see.
এটা তো ভিডিওটা হয়ে যাচ্ছে মোস্ট প্রবাবলি। This is the video. I don't think this is the PowerPoint presentation that we are sharing.
দেবাশিস দা, এই ভিডিওটার অডিওটা ঠিকঠাক আছে তো?
কোথায় কোনো অডিওই তো নেই, সাইলেন্ট।
খুবই স্যার খুবই সাইলেন্ট। আপনি পিপিটিটা দেখান and আপনি পিপিটিটা দেখান and you just talk on live. You have the PPT, right, doctor?
Right.
Yes,
Right.
just close this and start the PPT. I think that will be better. Just close this.
Okay. I was just trying to take the shortcut, but you won't let me. That's the problem.
No, everybody is complaining the videos have very sound issues, very slow. We have been playing what we have received from the speakers, so.
Is it okay now?
Doctor, share your PPT screen.
Yeah, I have. Can you see the PPT?
No, doctor, we can't see. Share the current screen. Share the current screen.
এটাকে মিনিমাইজ জুম হয়ে যাও, টপ স্ক্রিন শেয়ার এবারে go to the presentation. This is the PPT. Share.
It's coming, doctor. Can you full screen it? Press F5. F5, yeah. Bottom. Yes. Yeah. Go on, doctor. Go on.
Good afternoon to the moderator, the chair, and all the delegates. Suicide is really a threat to patient's life, obviously, but it is no less a disintegrating experience for the clinician as well. And so far, as it is an rapidly escalating situation in our clinic, we do not have a proper answer to it that can treatment that can intervene in terms of a few seconds or few minutes or even hours. So mostly we depend on engaging the patient in various modes of psychotherapy, crisis intervention, etc. And that's exactly where ketamine can intervene. I mean, it gives us some hope that it may act as an emergent mechanism to help suicidal patients. Suicide has always been a big risk in our state, particularly it being the third one ranking in the entire country. Now, most of the suicidal patients are depressed, even if they do not have a working diagnosis of depression, even in case of psychotic patients or other borderline personality disorder patients or other patients, depression is the commonest psychopathology accompanying the act of suicidality. Well, that was kind of rationalization, because I can only share whatever knowledge I have gathered about ketamine use in case of suicidal patients. Because most of the evidences are based on depressed patients. Obviously, FDA also approves esketamine for patients of depression only. What would be a typical acutely suicidal patient's features? An agitated, a melancholic, or a recent increase in panic features, cyclothymic temperament, or mixed state of bipolar affective disorders. Associated alcohol abuse and cluster B personality disorders are very common. Patients with past history of self-harm, suicidal attempt or ideation, violent behavior, various negative experiences in childhood, particularly sexual abuse, are very common features in these patients. What would be the acute risk factors that we must look for? Thinking about rapid escalation of suicidality, profound hopelessness, mood congruent nihilistic ideas, global insomnia, substance intoxication, recent negative life event, specifically loss of job, loss of spouse, second one being one of the biggest risk factors. Increased anxiety or frank panic attacks, as I have already told, recent discharge from mental health facility. Access to high lethal means, just like in first world countries, it's the firearm. In our country, particularly in rural setup, having access to pesticides and etc. are very important factors. And obviously past suicidal attempt, which is singularly the most common predictor of future suicidal attempts. One point is to be noted that it is important to inquire about the worst phase of suicidal ideation in recent times and in current severity, because it has been shown in various studies that the extent or severity of suicidal ideation in the immediate prior period of the act itself is not always properly correlated with the chance of the act. Rather, the most severe situation in last 1 year before the actual act, or last 6 months before the actual act, is much more closely correlated with the actual act of suicide. 75% of suicides had no contact with mental health services provider in preceding 1 year, and 16% suicide in inpatient settings, and 24% within 3 months of discharge. Now, these are the revealing features of Appleby study, Appleby et al. In 1999. That is pretty serious, because this is where intervention at primary care level or even at society level can act. 75% suicide patients won't come to mental health service provider within a year. That's pretty serious. And Isometsa and Longwist in 1998 showed that was a great study. That was very important for us to get some insights that in medically serious suicidal attempt patients, they followed cases for 10 years. I don't exactly remember the total number of the subjects, but 25% made another attempt in the entire time period. 12%, and majority of that was in first 2 years. 12% eventually died by suicide. That is 1 in every 8. So even those patients who has already been treated for 1 attempt and already in the register, they are at serious risk. And Bush in 2003 showed something very interesting. He did a series on inpatient suicide attempt patients, and he showed that many of the patients were put on to check on themselves, that is constant observation, whatever we call it. Even during that, the patients could commit suicide. I mean, could make that act happen. That is how acute these acts can be. All these points toward one thing, that we need to do something here and now about suicide. Now, there comes in ketamine. I mean, ketamine is luring us. Well, it was first synthesized in 62, and in 1970, that was another emergency FDA first approved for battlefield anesthesia. And the journey been till 2020 when it got the first approval for major depressive disorders with features of acute suicidality for esketamine. That's a very significant thing. We need to understand that it is not approved as a treatment for suicidality. It is approved for major depressive disorder with features of suicidality. It's a racemic mixture, ketamine, and esketamine is the S enantiomer. Esketamine is pharmacologically more active, at least as an anesthetic. It is available as an aerosol, and ketamine is available in various forms, oral, subcut, sublingual also, but what is used is IV form. It is extensively metabolized in liver by cytochrome P3A4 mostly, and the metabolites are norketamine and hydroxynorketamine, both are active, particularly the norketamine one. And 90% is excreted in urine as dehydrohydroxynorketamine. So that extensive amount of easy excretion makes it a very safe drug. Elimination half-life is 2 to 2.5 hours for ketamine, 5 hours for norketamine. That's very important because when we are going to use it in office practice, that gives us some safety margin, because if there is some reaction, I mean adverse reaction to it, it can be dealt for a few hours and then most likely the patient will be safe. Well, people are curious about Spravato, particularly since there had been this publication in possibly Times of India, and everybody is asking, well, do you know about Spravato? Do you think this will prevent cases like SSR? SSR is a phenomenon now. Now, well, FDA has approved, but makes me curious because very recently, in last 10 years, we had our experience with NASA and the first partial agonist as antipsychotic, and we had to come back to the real ground very soon. These things come with a big promise, but not always deliver. Now, how does it act? Pharmacologically, this is a specific inhibitor of NMDA receptor in open state. NMDA receptor allows calcium with the through the integrated channel. Now, in response to glutamate and glycine binding. Now, when it is open, inside of the channel, it has got a PCP binding site where ketamine also goes and bind, or esketamine goes and bind and stops the flow. Now, what happens then? This inhibits the GABAergic interneurons that can inhibit actual glutamatergic neurons in various brain areas, particularly the brainstem areas, amygdala, and hippocampus and dentate gyrus. Now, what happens then? Obviously there will be less inhibition or lack of inhibition on the glutamatergic neurons, or release of glutamate that will increase the glutamate release, and as NMDA receptors are no more available, they are blocked through ketamine, they start acting on AMPA receptors, AMPA kinase receptors, as well as the metabotropic receptors. Now, these AMPA kinase receptors, they increase sodium entry into the cell, and there is formation of local action potential that helps in release of BDNF immediately through increase in sodium entry and calcium entry following that. But in the long run, what happens? There is activation of two enzyme cascades. One is ERK enzyme cascade and another is AKT. These two impinges on, these two goes to the common pathway of mammalian target of rapamycin protein. Well, I'm not going even trying to get into the biology, I mean biochemistry of it. Simple thing for us, the clinicians, is this will increase the formation of BDNF, this will increase the formation of TRKB receptors for BDNF, and this will increase in formation of various other proteins which help in increasing dendritic spine growth and for enlargement of dendritic tree, leading to further synaptogenesis. So the loss of synapses, which is common in depression, particularly in hippocampus and other areas, that gets a chance to get restored. So here, ketamine is helping through glutamatergic action rather than blocking it, to increase in BDNF, to facilitate BDNF function. The immediate effects are, so these, we have already discussed about these things, the surge of glutamate and dopamine, as this NMDA receptor stops the dopamine and serotonin release from the midbrain neurons. So stopping the NMDA receptor functioning helps in dopamine surge also, which leads to action through nucleus accumbens. We'll come to that later. Now, this is the reward circuit. You all know about this. What happens here? The amygdala, hyperfunctioning in emotion-related disorder, anxiety or depression, keeps suppressing the midbrain dopaminergic neurons. And there is a lack of dopamine function in nucleus accumbens. This gives to a constant negative appraisal of the situation. What happens when, I'm sorry, my laptop's battery is going. I'm very sorry for this interruption. Just give me 1 minute. Okay, I'm audible, right? Hello?
হ্যাঁ audible বলো
Yeah, you're audible.
শোনা যাচ্ছে
Fine, thank you. Thank you. So when the glutamatergic NMDA receptor function is blocked at the ventral tegmental area, there is a dopamine surge, resultant dopamine surge into the nucleus accumbens. So that gives a reward sense. The mesolimbic reward pathway becomes active again. So that can break the shackle of depression. This is one putative pathway. Now, let us examine glutamate's role in suicide patients. Now, autopsy studies show that reduced density of NMDA glycine binding site in suicide victims, an increased concentration of particular glutamate receptor subunit in locus ceruleus of MDD with suicidal ideation, and glutamate level as checked by HPLC in 8 different brain regions of suicide patients shows no significant difference between suicides and comparison group. Well, that leads us to nowhere. Some study shows there is abnormality in glutamate functioning, some don't. Now, what was found by Lazé et al. In 2007 from STAR-D cohort, there is association between ionotropic glutamate receptor gene GRIK2, which is a part of the kinase receptor, GRIA3, which is a part of the AMPA receptor, and increase in suicidal ideation in patients receiving SSRI. So patients receiving SSRI having increased suicidal ideation may have a genetic background, I mean a diathesis, which is related specifically to glutamatergic pathway. That's a very significant finding. Genetic studies are as good as autopsy or as bad as. Now, Quintivano and Okuendo in 2014 in American Journal of Psychiatry on the same issue, I cannot remember the issue, but these two are great works. They did extensive study on all the accumulated research of glutamate functioning in suicide patients. Quintivano found increased concentration of NMDA receptor in hippocampus in both depression and depression with suicidal ideation patients. Highest density of PCB binding sites are seen in dentate gyrus, hippocampus, and anterior forebrain. So that means NMDA receptors are key players in these areas. PCB binding site means the NMDA receptors, which has got those binding sites within the channel where ketamine acts. Now, low expression of SKA2 gene in prefrontal cortex in suicide descendants. This has got relation with glutamatergic function. Okuendo's study was more revealing. It showed that poor stress response system has got three components: neuroinflammatory, neuroplastic, and glutamatergic dysfunction. Now, obviously, neuroplastic dysfunction is also associated with glutamate, because hyperglutamatergic function associated with continuous cortisol rise can lead to loss of BDNF function and resultant loss of dendritic tree in hippocampus. That is pretty much well established by now. Now, female suicides were more likely to carry BDNF polymorphism, which is a malfunctioning polymorphism, thus decreased activity dependent BDNF secretion. Higher BDNF gene DNA methylation in suicide victims. These patients, these are particularly the victims who had experienced childhood sexual abuse or other traumatic experiences. Now, this is an epigenetic phenomena which works through BDNF gene. Now, glutamate is also indirectly related here because glutamate can correct the BDNF function, as we have already seen, or the BDNF more efficient binding of BDNF to TRKB receptor. Ketamine acts via AMP kinase receptor to increase that particular gene of TRKB. What looked most interesting for me in this particular study was they worked on teenage suicide patients with diverse diagnosis too, and what they found was lower BDNF expression in prefrontal cortex, fewer full-length TRKB receptors in PFC. That obviously will mean less functioning receptors and less functioning binding of BDNF with TRKB, as well as in hippocampus. Less BDNF and TRKB mRNA, that is less expression of those proteins in prefrontal cortex. These were subsequently supported in adult suicides with diverse diagnosis. Now, this diverse diagnosis point is very important because this is the only place where I can tell you that, well, our today's discussion was ketamine in suicide, not ketamine in suicide with depression. Now, but this is the only hope that possibly ketamine may work in suicide patients across diagnosis. Now, there are other supportive studies. Now, Abdullah, in their MR spectroscopy study on brain, showed that there is indication that overall reduction of glutamatergic synaptic volume is there. Now, before I go to typical administration protocol, let me diverge a little, and I'm sorry, I'll have to read a note. Okay, I look like a newscaster, but I would like to go through it fully. Now, I never feel guilty about being repetitive whenever I'm talking about
kindly
suicide.
finish it quickly. We have the next speaker as well at the venue, so kindly conclude.
What is the time that I have? I may have.
Doctor, you have another 2 minutes.
2 minutes. Well, then I think I'll have to leave it for the discussion. Now, talking about administration of ketamine, preparation is no abusive substance or stimulant. This is how we can practice it in the clinic. Benzodiazepine in previous 24 hours, finalize diagnosis and MSC and rating scale, the usual rules, and then take a consent, then the proper administration in the clinic. This must always be an office-based, clinic-based practice in a specialty setting. Now, recording vitals, the dosage should be 0.5 milligram per kg diluted in 50 to 100 ml normal saline infused over 40 minutes. Why? Because this is the commonest protocol that has been used almost by all the studies. After it is over, it can be flushed with another 15 ml of normal saline. For next 2 hours, monitoring should be done of the vitals, as also recommended by FDA. Ondansetron may be used for emergent nausea or as a pre-treatment. Post-procedure, suicidality can be checked again, better be checked with a structured scale. Not to drive for 24 hours, no alcohol for 48 hours, preferably never. No benzodiazepine for next 2 to 6 hours, but regular medication, including psychotropics, will continue because ketamine is just an adjunct, not established treatment, or not an established treatment for depression. Now, schedule twice weekly for 4 weeks. Again, why? Because this is the commonest protocol that has been used by the existing studies. Precautions should be for respiratory depression, anaphylaxis, and hallucinatory experience and agitation with the drug, which is most likely to be short-lasting. Efficacy studies, only ketamine had significant effect in reducing acute symptoms of depression, while in a Cochrane review, 11 particular glutamatergic modulators were tried. Ketamine versus midazolam, there is a study which was published in 2008 in the last one. Response in 24 hours was available with ketamine, not so with midazolam. Actually, the 40 patients getting midazolam had to be taken over to vitamin arm. Out of that, 35 had to be taken over after the first day. It was a single dose study. These two are very important. Wheat et al. Showed evidence of effects in favor of a single dose treatment of ketamine along with regular psychotherapy for reduction of suicidal ideation in adults. And unfortunately, the effect were apparent only up to 72 hours. Now that may support the dosing schedule of twice a week. Saying it all, this was also published in 2020. They did a meta-analysis on 4 double-blind randomized control trials of esketamine. The earlier one was of ketamine, twice weekly dose, and anti-suicide effect across studies was found to be inconsistent. Why? Because with a structured protocol for assessment of suicide, the effect was unyielding. But with MADRS scale in one study, it was good. The implication, I have 2 more slides. I think I get the time. Implication in practice, well, esketamine is not yet available in India, already dropped by NHS by the beginning of this year for unyielding cost-benefit ratio. Available evidence is mainly on antidepressant effect. That too lasts only till the end of 4th week. If alone, with psychotropics, that is good. Cost of esketamine is very prohibitive, but ketamine is very easily available and cheap. It needs a proper office setup though. And I will say, given the current administrative or clinical nihilism around ECT, India may become a very prospective alternative for acutely reducing suicidal ideation. The lithium, clozapine, and ECT, we must remember the previous ones. Clozapine, the only one getting FDA approval for the symptom of suicidality, not alone, but in schizophrenia. For ECT, ketamine can be synergistic because it improves seizure quality and protects immediate cognitive dysfunction too, because it has got immediate effect on BDNF release and BDNF-TRKB interaction. Now, take-home points are: it must be supervised and only supervised setting. Thorough psychoeducation, the patient and the family member must be told that this is for an immediate intervention of a short-lasting effect. The regular medicine is not to be discontinued, and this doesn't mean that the need for observation, need for the special cares is any less. An opportunity to rapidly improve the well-being, quality of life, relief of immediate traumatic experience, which treatment adherence may be, which can help facilitate treatment adherence later. Maybe that your circuit works in here. I could not elaborate, but please refer to a study by Crystal that shows how ketamine can change the experiential part of the suicidality and as well as depression. Need to watch for abuse, overuse, and misuse, and a good candidate to accompany ECT. And well, we can wait for other NMDA receptor modulators. Thank you.
Thank you, Doctor. Now I will ask moderator Dr. Devashish Shanal to conclude the session because we have already passed and in the venue Dr. O.P. Singh is waiting. So
yes, unfortunately there will be no time for questioning, sadly, because the time couldn't be adjusted that way. So we are open. We are closing this session and we are thanking all the speakers for their marvelous presentation. Thank you all.
Thank you, speakers, and thank you, Dr. Devashish Shanal and Dr. Dilip Mondal. Our next sessions for this afternoon is neuropsychiatric aspect of Parkinsonism and update by Dr. O.P. Singh, and the chairperson for this session is Dr. Malay Kumar Ghoshal and Dr. Shamol Chakraborty, and this session has been sponsored by INTAS.
প্রকাশ রেডি হচ্ছে? কি একটা আওয়াজ হচ্ছে?
Please start.
ওকে, so we can. আর কিছু বলার নেই. I think the time is running short, so we can conclude afterwards. So you start your session without going into the because.
The speaker is Dr. Om Prakash Singh. Needs no introduction. He is the honorary editor of Indian Journal of Psychiatry, and the topic is neuropsychiatric aspect of Parkinsonism. Very debatable topic. these psychotropic drugs may cause these Parkinson-like symptoms, and this Parkinsonism itself cause depression, anxiety, and other psychotic features. So now I request Dr. Om Prakash Singh to start the session.
Thank you, Samalda.
আওয়াজ হচ্ছে কি একটা আওয়াজ হচ্ছে গো
I'm really gap-filled speaker, but I'm very happy to be here and speak in the state conference. And I will be talking about neuropsychiatric aspects of Parkinsonism. So whenever we think schizophrenia and Parkinsonism, we think both are kind of different poles. One is considered hyperdopaminergic state and one is considered hypodopaminergic state. However, we know that psychiatric disorders have always motor symptoms, and it has been considered core features of schizophrenia. In fact, even before the advent of antipsychotics, all the older description of schizophrenia describe a lot of motor symptoms. Conversely, Parkinson disease have also been considered as a pure motor disorder, but it has a lot of prominence of psychiatric symptoms. So, Parkinson's system is defined by motor signs. We know that they are defined by motor signs, bradykinesia, rigidity, postural instability, and raised tremors. And asymmetry of motor signs and a good response to dopaminergic drugs are additional characteristics that support the diagnosis. This occurs due to neurodegenerative disorder, which primarily affects dopamine neurons of the SNC or substantia nigra pars compacta. So the loss of DA from nigral projection leads to difficulty in movement, including slowness of movement, rigidity, postural instability, and resting tremors. So this is about Parkinsonism, a brief, but it has a lot of non-motor symptoms. Interestingly, non-motor symptoms of PD can predate the motor signs by several years. Non-motor symptoms constitute a major part of illness, and they are responsible for poor quality of life. And again, there has been, L-DOPA has been for treatment, and there are a lot of issues connected with the side effects of L-DOPA in the treatment, and it is responsible for a lot of So, and symptoms which extend beyond DA loss. So there are three things can be happen, whether psychiatric symptoms in Parkinsonism are drug related, or whether they are related to the illness, or they share common pathophysiology. Slide is taking some time to change. So coming to why they are together. So norepinephrine and 5-HT neurons are also affected by PD process in most patients and may be implicated in primary affective symptoms resulting from DOPA treatment. Because in L-DOPA in rat models interferes with norepinephrine and 5-HT related functions in affect-related areas and induces symptoms of anxiety and depression. So when dopamine increases, this leads to dysfunction in serotonergic and noradrenergic symptoms and leads to anxiety and depression, particularly when patients are treated with L-DOPA. Then DOPA monoamine, there is a theory that it is not only dopamine depletion, it is monoamine depletion. So any dysfunction occurs prior to significant depletion of DA neurons. Serotonergic cell loss in raphe nucleus is evident prior to nigral neuronal DA death. So dopaminergic depletion only hints at maybe collective monoamine dysfunctions rather than isolated dopaminergic dysfunctions. Dopamine is co-released with norepinephrine. Following dopamine loss, L-DOPA is converted to dopamine in norepinephrine neurons, and released into forebrain areas and works as a false neurotransmitter. So norepinephrine neurons take dopa and secrete it, so leading to dysfunction of serotonergic and norepinephrine neurons. So depression is related casually with Parkinsonism. And if we come to the comorbid psychiatric disorders, the common one comes readily to mind is depression. So prevalence is around 70 to 35%. Risk factors include female gender, advanced age, early onset and severe disease, comorbid anxiety, rigid akinetic variety. Majority of the patients who show on and off or mood swings show depressive features. Some symptoms of PD are depressive symptoms, and cognitive impairment worsens depression. So depression is a core symptom of Parkinsonism. So why it occurs apart from some pathophysiology I discussed, but etiology is exactly non-known. If you consider it that it's a reaction to the illness which does not explain it, because it is much higher than what happens in other chronic diseases. Affective symptoms can predate 4 to 7 years before PD, and immune factors are considered to play a major role both in the etiology of depression and anxiety. So there is evidence of I have already talked monoaminergic dysfunction in all the PD patients. Dopaminergic and noradrenergic transmission seems to be diminished in limbic areas of depressed patients with PD. And reduced cortical binding of 5-HT1N receptor was found in these patients. So there was some changes found in monoamine system and serotonergic system, particularly in depression. So there has been a structural change in the raphe nuclei of depressed patients in Parkinsonism. Cortical cholinergic deficiency has been found in depressed patients with PD. It has been postulated that depression in PD is different from depression in elderly. So slightly different because the response to the treatment is also different. And PD patients undergoing subthalamic deep brain stimulation, including increased rate of suicide attempts. So patients who has been given deep brain stimulation in PD, particularly subthalamic deep nucleus, there has been increased rate of suicide in them. Anxiety is extremely common. Comorbidity with depression is very high. Anxiety worsens the motor symptoms and further accelerates the anxiety. There is evident decrease in anxiety in elderly, whereas there is sharp increase in anxiety in PD patients. Normally, anxiety decreases with old age, but there is a sharp increase in PD patients. And they have very Youngbein-induced panic attacks. They are more common in off-phase and theoretically increases serotonin, inhibits dopamine release and worsens anxiety. What is most interesting is the OCD and punding. OCD spectrum disorders occur frequently in diseases affecting basal ganglia. So we know that Tourette disorder and all those disorders, there is increased OCD symptoms. They have Tomer et al. Observed that obsessive symptoms, particularly contamination, cleaning, are associated with dominance of violent motor signs. So they are associated with motor symptoms. And repetitive behavior have been associated with treatment of PD. So particularly, punding is a word. Punding is a word. What is punding? Punding is behavior described as repetitive, stereotyped, and purposeless, like holding paper, sorting levels, assembling and disassembling objects, skin picking, humming, increased writing. They are related to person's hobby or work experience and soothing and leads to social isolation. Person is busy with those kind of behavior and socially isolated. And this occurs with higher dose of dopamine. So with higher dose of dopamine, incidence increase from 1.4 to 14%. So punding increases or repetitive behavior increases in patients treated with L-DOPA. And another very important, which is quite common, is impulse control disorder and dopamine dysregulation syndrome. So it is very common in patients, 6% in normal PD patients, and around 13.7% in patients who are being treated with L-DOPA. Pathological gambling almost exclusively occurs in on period. Hypersexuality is associated with dopamine agonist. Change in sexuality include spontaneous penile erection, increased libido, and new sexual habits which contrast dramatically to personality. So suddenly change in personality, increase in sexuality, compulsive eating in shopping is also described, and there is lack of insight. And this is associated with levodopa treatment. And dopamine dysregulation syndrome is overuse of drug, which is beyond required to relieve motor symptoms. Then coming to psychotic symptoms, we all see they are quite common, 15 to 20% of prevalence. Complex visual hallucinations are common. They are similar to visual impairment hallucinations, sense of presence, and patients are generally observer than participant in these hallucinations. And auditory hallucinations tend to be very simple, like buzzing, ringing, etc. And patients having early onset have more severe kind of delusions. Sleep disorders are very common, and in fact, RBD is hallmark of Parkinsonian or basal ganglia disorders, and also predates dementia of subcortical origins. So RBD is quite common. They may be caused by, and again, other like narcolepsy, like sleep attacks, restless leg syndrome, obstructive sleep apnea, and periodic limb movements occurs frequently in PD. And they may be caused by degeneration of sleep regulation centers in brainstem and thalamocortical regions. Apathy and fatigue is very common, almost 42% of the patient. Frontostriatal disruption is probably related to apathy. They perform poor than non-apathetic patients. Neuromuscular rigidity or neuroinflammatory mechanism may be responsible for apathy. Dementia has been associated with Parkinsonism quite extensively described. What is important is memory is the free call is affected first, rather than learning new information, which is in dementia, the learning new information comes first, but here free recall is affected first. Advanced age, later onset of disease, longer duration of disease, psychosis and other atypical neurological symptoms are risk factors. So coming to how we are going to treat. Already we have discussed common symptoms are depression, OCD, impulse control disorder, dopamine dysregulation syndrome, psychosis, sleep disorder, apathy and fatigue, cognitive impairment, and dementia. So studies has found that nortriptyline is better suited than, particularly there has been compared to the paroxetine, whereas paroxetine has not been found very effective in depression in Parkinsonism, but nortriptyline has been found to be superior. Desipramine was found to work faster than compared to citalopram. So maybe TCA antidepressants are better in these patients because some of their side effects also, like anticholinergic side effects, are beneficial in PD patients. So they improve also drooling and tremor. So TCAs are, as a rule, better than SSRIs for treatment of depression in Parkinsonism. For pramipexole improves the motor signs as well as depression. Its efficacy was compared to fluoxetine. Omega-3 fatty acid has been tried. RTMA is found to be similar as fluoxetine. CBT was also found to be effective in some open label studies. Anxiety is very common, 30%, social phobia around 50%, panic disorder around 35%. Again, there is no specific data for treatment in anxiety in Parkinsonism. It is based on treatment protocols are based on treatment of anxiety in older peoples. Optimization of anti-Parkinsonian treatments improves anxiety. Menjitol found positive effect of nortriptyline in anxiety patients, whereas paroxetine was ineffective. Again, paroxetine was not found to be so effective as nortriptyline in these patients. If benzodiazepines are effective but should be used for short period only, bisphoran in low doses has been found to be effective, particularly for dyskinesias, but may worsen Parkinsonism. There are open level studies of citalopram, which is found to be effective. Again, psychological support, counseling are also been found to be evaluated. Regarding OCD, there is no systematic studies on the pharmacotherapy of OCD in Parkinson's patients. Higher doses of SSRI may worsen Parkinsonism. However, most of the time, OCD symptoms are not severe enough. And funding is basically controlled by optimizing the drug rather than giving SSRIs. DDS or dopamine dysregulation syndrome is a challenge to clinicians. Clozapine, quetiapine, valproate, topiramate, donepezil, amantadine, cyproterone, and deep brain stimulation all has been tried, but basically it requires optimization of dopamine treatment. Psychosis, though it was described pre-levodopa days also, but mostly associated with levodopa therapy. Again, I have said complex visual hallucinations are common, and this is one of the commonest cause of hospitalization for these patients. Environmental changes and simplification of treatment should be tried, and again, delirium has to be ruled out. Treatment, now one drug has been approved by FDA in 2016 for psychosis in Parkinsonism. In India, it is not available. It does not have any kind of dopaminergic action or serotonergic. It has serotonergic action, particularly a mixture of inverse agonist and antagonist activity on 5-HT2A receptors and to a lesser extent at the 5-HT2C receptors. It do not have significant anticholinergic, antidopaminergic effect. So pimavanserin is a different class which has been approved for psychosis in Parkinsonism. Still, perhaps India, it is not available. Off-label clozapine has been tried. Then again, quetiapine is a good alternative. Olanzapine and risperidone improve psychosis, but of course, they worsen the motor symptoms. Ondansetron and anticholinergic drugs in opioid trance have been also been found to be have good effect. So sleep hygiene is the first treatment. Long-acting for sleep. Long-acting dopaminergic drugs are helpful in insomnia caused by worsening of motor symptoms. Clonazepam helps in initiation as well as RBD. Antidepressant with sedative properties may be helpful. Improving sleep gives benefit to other symptoms also. So while treatment of symptom of sleep, these drugs can be tried. For apathy and fatigue, again, there is no definite treatment which has been indicated. Antidepressants have not been found to be very effective. Methylphenidate has been found to be effective in both apathy and fatigue. Coming to dementia and cognitive impairment subsequently leading to dementia is common, around 24 to 30%. Anticholinergics are found to be effective, whereas anticholinergic and anti-dementia drugs worsen cognitive functions and dementia. So there is a lot of question regarding cholinesterase inhibitors in Parkinsonian dementia, whether this should be given or memantine should be tried. Malada is there, he will be able to clarify more. So coming to an end of my presentation, psychiatric symptoms and disorders are very common in Parkinsonism disorders. They occur due to specific changes and shared neuropathophysiciology. Also, treatment leads to some emergence of psychiatric symptoms. Though neuropsychiatric symptoms are very common or non-motor symptoms are very common, they have not been very systematically studied. There is a lack of data regarding drug efficacy. An extrapolation of treatment based on pathophysiology is the most prevalent treatment. So we extrapolate in whatever the treatment we are providing to elderly for these disorders. Same kind of treatment is provided here, though there is no robust evidence for this. So thank you. Thank you.
Thank you, Om Prakash. Excellent, excellent presentation. I must tell that I must দারুণ ভালো representation হয়েছে. It is really good. The presentation is excellent. Actually, you have covered almost all the things in this short time, and there are really some controversies regarding this, whether this treatment emergent psychiatric symptom or they are actually inherent. They are considered to be the inherent of Parkinson's disease. But one thing is sure, that non-motor symptoms actually impair quality of life more than motor symptoms. That is, they are more disabling than motor symptom. It is now thought. I just there are some questions actually. Shubir actually had depression with PD generally needs pramipexole, ropinirole to improve adequately, unlike other depression. Your opinion? That is one question by Shubir. So, actually,
pramipexole has been found effective in depression in Parkinsonism. That is, I mentioned that pramipexole has been found to be effective. It take care of motor symptoms as well as non-motor symptoms of depression. So pramipexole has some evidence, and again, nortriptyline has found to be effective.
Can I add something?
It was. I will thankful to Gautam also, because we had this, both of this presented this symposium in Nagpur.
Pramipexole is really good, but the anti-depression effect is not so good as far as my clinical experience is saying. Regarding anxiety, it's okay, and depression, having with sexual problem, definitely pramipexole is a drug of choice in that cases. It is my personal experience. Hope you can add.
Actually, there is a movement disorder society. They have recently, actually 2018 or 19, they have come out with a recommendation of treatment for non-motor symptoms. And in depression, they have 3 choices, actually pramipexole, venlafaxine, and CBT. TCA also is there, but you already know that in old age TCA use has some hazards actually. So we don't use TCA, but otherwise TCA is also good. But this movement society has given venlafaxine and pramipexole are the 2 drugs which they have there recommended.
Thank you, venlafaxine I have missed.
There are some recommendation. I will tell that in apathy they have recommended rivastigmine. I don't know whether this recommendation, they have actually found some study and they have recommended rivastigmine in apathy, and in particularly in cognitive impairment, they have given preference to of rivastigmine over donepezil treating cognitive impairment. And in psychosis, as you have told, that this pimavanserin is the drug of choice, but it is not available in India. And clozapine and quetiapine can be given, but they can be given in very low dose. Actually, 1/10 of the dose that is required for treating psychosis, it can be given. So clozapine is maximum dose 50 to 65 or something like that, and quetiapine is up to 75-80 milligram. That is enough. And regarding sleep, melatonin is another alternative. And esgopiclone also they have recommended. This is the recommendation of the Movement Disorder Society that I have told you. But
thank you, Malada, for adding. Anything else?
Hello, sir. Which combination is better, 1:4 or 1:10? Levodopa, carbidopa?
Actually, so far I know that carbidopa 75 milligram is needed for blocking this peripheral dopa decarboxylase. Actually, you have to block the peripheral dopa decarboxylase. So it is probably 75. So if there is 110 or 125, if 125, then only 3
doses.
Can I ask something, please?
শোনা যাচ্ছে না।
আবিরদা বলো, শোনা যাচ্ছে? হ্যাঁ শোনা যাচ্ছে আবিরদা, বলো।
আচ্ছা, আমি posted in the chat box. Can I have some sort of well presented Omda as usual? Can I have some insight on the treatment of REM sleep behavior disorder associated with Parkinsonism?
RBD.
RBD.
Actually, RBD has got, it is difficult to treat. RBD. Om ki bolte dekhiye? Have you got RBD treatment?
RBD, basically, clonazepam has been found to be effective. Can give, and also low dose TCS are also effective in cases of RBD.
Actually, in normal, in not Parkinsonian, but RBD is it is a synucleopathy. RBD is one of the hallmarks of synucleopathy. At night, so that he does not harm himself or other. So that is
connectivity. Sir, Ranjan here, a question from the venue. Sir, how to differentiate clinically between the Parkinson disorder psychosis (PDP) versus dopa-induced psychosis? PDP versus Parkinson disorder psychosis versus dopa-induced psychosis clinically.
A very critical question. Only thing I can say, dopamine-induced psychosis is there will be slightly manic kind of element to it. There will be more activity. There will be slightly grandiosity, and of course, visual hallucinations are much more, and paranoid symptoms are much more. So, slightly dopamine-induced, basically, slightly there will be more activity or manic kind of symptoms will be there, along with the psychosis. So that will differentiate.
Maulana, can you please repeat the treatment of RBD because your audio got disconnected?
RBD, the main treatment is clonazepam, and you can give, but this pramipexole and this group of treatment, I don't know whether they can, but basically clonazepam, and sometimes you have to restrict the person so that he cannot injure himself or other. But otherwise, RBD I have sought, but I could not find the very good treatment for RBD.
Because there's a problem of tolerance with clonazepam as well, isn't it? So you have to go on increasing the dose, so that becomes a problem.
And regarding Ranjan's question, I think whatever may be the first thing that it is the treatment we do. What we do is that it is like this, whether in SLE, the steroid-induced psychosis, or SLE is that is the same thing. Sometimes we actually reduce the dose of the anti-Parkinsonian and see what happens actually. And if you can find that there is some temporal relationship with the anti-Parkinsonian drug and then there may be also this. If it is more in the on phase than in the off phase, then you can think that this may be a case of drug-induced. But initially, from the treatment point of view, we usually reduce the dose of anti-Parkinsonian, particularly those known culprits are this dopa agonist, and next is this syndopa. Otherwise, this amantadine and this A also, this we also use this anticholinergic drug that is also sometimes cause psychosis. That is the so. If there is improvement, then it's okay. If there is no improvement, then you have to try other ways. Okay.
Sir, what's the role of SSRI?
We have to conclude this session.
Actually, Om has one slide. Yes, SSRI sometime we use SSRI, but sometimes it worsens Parkinson's symptom because you know that this serotonergic and dopaminergic, they have some interconnection, and so there may be some. If you block serotonergic, there is also chances of this. If you increase the serotonergic transmission, there is chances of dopaminergic blocking, and that can lead to increased Parkinsonian syndrome. But that is more of a theoretical concern, I think. But we can use it because SSRI is we all use. Actually, I don't know whether Om Prakash can tell that we all use.
Sertraline and quetiapine.
Dr. Ghoshal, we need to conclude this session right now because the next session is Dr.
Okay.
Thank you.
Thank you, everybody. Thank you, Dr. Singh and Dr. Ghoshal and Dr. Chakraborty.
Okay, thank you. So, okay, thank you.
Our next session is suicide, Jane Complex or the Society by Dr. Kaustubh Mukherjee, and chairperson will be Dr. Dinen Banerjee and Dr. Hena Bharat Roy. And this session was sponsored by Sun Pharma.
দেখা যাচ্ছে অন্ধকার হয়ে গেলি দেখো কোকা কোলা খাচ্ছে।
এই যে দিনুদা,
কেমন আছেন?
দিনুদা আমাদের দেখতে পাচ্ছ?
হ্যাঁ, অন্ধকার হয়ে গেলি। হ্যাঁ, ঠিক আছে, দারুণ করেছে। না, বিকেলে আসছি না ভাই, সত্যি বলছি।
নিয়ে চলে আসো।
না না, দিদিও যেতে পারবে না, আমিও যেতে পারবো।
Dr. Chakraborty, can you start your presentation? Dr. Kaustubh Chakraborty, can you start your presentation, Doctor?
যাবে বিকেল বেলা, ভালো খাওয়াবে রাত্রি, প্রচুর খাওয়াবে, বিস্কুট যা আছে খাও। একটু চা দাও তো, ওই কোকা কোলাটা দেখে খুব হলো না, ওই থাকে পড়ে আছে, বুঝেছিস?
Can you full screen, Doctor? Doctor, can you full screen? Yeah, right hand side. No, below. Come below. Yeah, full screen, Doctor.
না, এক্ষুনি লিফট করবে, যেই কোর্সটা বলতে শুরু করবে আমি ওই লিফটটা ঠিক করে দিয়ে এখানে কি লেখা আছে
Doctor, make it full screen.
Press F5.
F5, press F5, Doctor. Doctor, press F5.
Hello.
Yes, Doctor. Yes.
Dr. Hena Bharat Roy. Am I audible?
Yes, doctor, you are audible. Dr. Hena Bharat, you are audible. Dr. Chakraborty, please start. Dr. Chakraborty, please start. Dr. Kaustav Chakraborty, please start your presentation. Everybody is watching.
Sound.
কিচ্ছু শোনা যাচ্ছে না।
কিচ্ছু শোনা যাচ্ছে না।
কিচ্ছু শোনা যাচ্ছে না।
সাউন্ড বোঝা যাচ্ছে।
কোনো সিনক্রোনাইজেশন নেই। কোনো সিনক্রোনাইজেশন নেই।
হেডফোন ইউজ করতে হবে।
May I call up?
কৌস্তব কি বলেছে একটা শব্দ বোঝা যায়নি।
Very good afternoon, members of this house, the August gathering. Now we have a presentation from Dr. Kaustav Chakraborty, who is the Associate Professor and Head of the Department in College of Medicine, JNM Medical College, Kollani. And may I now call upon Dr. Kaustav Chakraborty to present, because the link was not working well, the pre-recorded version, he will present it physically. So, a big round of applause for Dr. Kaustav Chakraborty.
Good afternoon. Good afternoon, all the delegates. I'd like to thank the organizing committee of Psycon 2020 for giving me the opportunity to speak on a very contemporary topic of suicide, gene compels other society. As a layperson, people would ordinarily think that these are the biopsychosocial issues, particularly psychosocial issues that compel a person to commit suicide. Whereas with a psychiatrist and brain scientist know that there is a big role of gene and heritability issues that commonly predispose a person to commit suicide. So with this brief introduction, I would like to go to the next slide. This slide shows two figures, one of Mr. Sushant Singh Rajput, a very talented young actor who committed suicide few months back. There has been raging debate in social media and news media regarding whether this has been a suicide or a murder. There have been allegations of abatement of suicide, money laundering, drug abuse, and you say the scale is the case is still sub judice, and the other picture diagram shows a farmer looking haplessly towards a hanging rope. Many cases of farmer suicides happen in our country every year, and those cases are very little talked about in national media and newsprint media. Now, before I go on to the core presentation, I would like to focus this NCRB data which has been recently released. 5 states, namely Maharashtra, Madhya Pradesh, Karnataka, Tamil Nadu, and West Bengal, contributes majority of number of cases of suicide in India. According to this NCRB data, more than 1.39 lakh people committed suicide in the last year, and among those, 10,281 farmers, cultivators, and farm laborers were there. 7.4% farmers committed suicide previous year. The male to female ratio of suicide in India has increased from 68.5 is to 31.5 in 2018 to 70.2 is to 29.8 in 2019. So there has been a slight increase in male to female suicide ratio. The highest proportion of suicide victims were educated up to matriculation. So as we can see that they were educated, so we would assume that they had the idea that suicide is not probably the best way to solve their daily life problems, but they still committed suicide. When we talk about the age group, it is the 18 to 45 years of age that is most vulnerable to suicide. And it is a very interesting to see that 2/3 of the suicidal victims were married. So as per our common belief, we think that marriage is probably protective to suicide, but it is not probably as per the national data. And 2/3 of the suicide victims had an annual income of less than 1 lakh. So poverty and unemployment were a contributory factor. Hanging, consuming poison, drowning, and self-immolation were the prominent methods of committing suicide in India. So hanging comes first. Even it supersedes poisoning. Family problems, family issues were the most prevalent cause because of which people committed suicide, followed by illness, drug abuse, marriage and related issues, love affairs, bankruptcy and indebtedness, failure in examination, and so on and so forth. So these are the reasons for which people committed suicide in India last year. Now, when we talk about suicide, it is really a heterogeneous behavior and varies in the degree of intent and amount of clinical damage done. So like most of the psychiatric disorders, it is a heterogeneous construct. Suicidal deaths are near fatal but highly lethal suicide attempts are similar from demographical, clinical, and neurobiological point of view, and therefore they have probably common diathesis. However, there are very little clinical predictors, and no biomarkers till date have been established to help clinicians to predict suicidal behavior or to target with treatment. Harrington and Mann proposed a stress diathesis model of suicidal behavior and describe it to be the result of an interaction between stressors that may be early life stressors as well as stressors in later life and a susceptibility to suicidal behavior. Contrary to a popular belief, most people with major psychiatric disorder never manifest suicidal behavior, indicating there is importance of diathesis in addition to a disorder. And about 50% of the risk of suicide is inherited. And this percentage is probably higher in women than in men. Epigenetic is a thing which is above genetics or beyond genetics. Epigenetics effect in childhood might also increase an individual risk of suicidal behavior through an effect on their diathesis, which I will elaborate in later slides, and an increase in the risk of mood disorders. So suicidal behaviors results in impairment of mood regulation and decision-making process, which involves serotonergic, dopaminergic, HP axis, noradrenergic system, and other neurobiological abnormalities. Now, this is the stress diathesis model proposed by Herringen and Mann. It suggests that genetics predispose a person to early on a genetic background, the childhood traumatic experience, particularly emotional and physical abuse as well as sexual abuse, those things play out themselves, and then they develop a sensitivity to social stress, they develop impulsivity and ideas of pessimism or hopelessness. On and above that, if they have psychiatric disorder or adverse psychosocial events, stress in later life like financial marital problems, exacerbation of psychiatric disorders, so all these work together ultimately to lead to suicidal behavior. Now, it would be very wrong if we don't talk about Emil Durkheim's functionalism. When we talk about suicide, he was the first one to give a social model of suicide. Functionalism was the dominant theoretical perspective in sociology in 40s and 50s. From the mid-60s onwards, its popularity declined because of the competing models which gave better explanation of social causation of psychiatric disorders and partly to changes in fashion. Functionalism begins with the observation that behavior is in society is structured. This means the relationship between members of society are organized in terms of rules. So what the functionalism says? It says that all elements within the society are interconnected and work together. If one dynamic is changed, it will alter the whole society. Society will change to accommodate this change. Everything has a specific function in society, and society will always function in harmony as it will accommodate change by changing itself. So when a society changes too fast, it creates a state of anomy or normlessness. So in a normless or anomic society, if a person cannot adjust himself or herself to that ever-changing or fast-changing society, people are predisposed to psychiatric disorders, and ultimately, eventually, they can commit suicide. So he described 4 types of suicide: anomic suicide, which is caused by weakening of the collective conscience; egoistic suicide, which occurs when a person's social bond are loosened or lost; altruistic suicide happens when individuals are too strongly bonded to their society, for example, Shotidaho Protha; and fatalistic suicide results when the collective conscience of the society is so strong that the individual feels helpless, for example, slavery. Now, this is another theory of suicide proposed by Auden et al. In 2010. This is called interpersonal theory of suicide. Here, Auden described 2 constructs, one of thwarted belongingness and one is perceived burdensomeness. Now, thwarted belongingness, it hampers the reciprocal social relationship and it creates a sense of loneliness, whereas the perceived burdensomeness creates the ideas of guilt within the person and a sense of liability. These 2 constructs on the background of acquired capability, which again in terms of acquired from childhood physical, sexual, emotional abuse, combat exposure and previous suicidal attempts, predispose a person to commit a lethal or non-lethal suicide attempts. So who are at risk? Because we have to be very careful while taking a psychiatric history of a person, particularly patients with depression, schizophrenia and bipolar. There are some pointers that warn us that these people may commit suicide in near future. So these are the biopsychosocial risk factor. We all know that mental disorders, particularly mood disorders, both depression and bipolar, schizophrenia, anxiety disorders, and certain personality disorders. Alcohol and SUDs play a huge role in predisposing or exacerbating the suicidal ideas in a person. Ideas of hopelessness. This has been a concern school, homelessness, relational or social loss, easy access to legal means, and local clusters of suicide that may have a contagious influences. And there are some socio-cultural risk factors. lack of social support or sense of isolation, particularly at an elderly age, stigma associated with health-seeking behavior, which is very much into play in our society, barriers to accessing healthcare, particularly mental health and substance use treatment, certain cultural and religious beliefs, and exposure to, including through media and influence of others who have died of suicide. This is very much relevant in current context. Now, I will be moving on to the rather difficult part of this presentation, that is genetics of suicide. So much of the data of genetics of suicide has been obtained from family studies, twin studies, and adoption studies. Now, these are difficult things for me also, but I will try to be as easy as possible for you. Family studies have indicated familiar aggregation of suicidal behavior. So that is very clear. Population registries in Denmark and Sweden have provided large data set to explore the familiarity of suicide. Increased rate of suicide in offspring of suicidal parents were found compared to offspring of non-suicidal parents. So therefore, most of the studies have shown a higher rate of suicidal behavior in relatives of suicidal victims or attempters compared to relatives of non-suicide controls. Now, twin studies and adoption studies are done to measure the influence of genetics and environment on the probability or causation of suicide. Twin studies have suggested heritability of suicidal ideation to be 43%, suicide plan or attempt 44%, and that of serious suicide attempt at 55%. So what we can see that suicide is highly heritable. Lifetime suicide attempt concordance rate was found to be 25% and 13% for monozygotic and dizygotic pairs respectively. Therefore, twin studies support a genetic basis of suicidal behavior and suggest that the genetic component of suicidal behavior may be independent of the heritability of psychiatric disorder. There are ample support on this hypothesis. Adoption studies on suicide are relatively few in numbers. Danish adoption registry suggested an increased rate of suicide in biological relatives of suicidal adoptees compared to biological relatives of non-suicidal adoptees, and none of the relatives of the adopted family in the studies were affected by suicide. So these observations also support a genetic component of suicide. So all these studies I have mentioned till now indicate towards a genetic component of suicide. Now, host of candidate genes has been proposed in relation to suicide, and you name it any of the neurotransmitter system, be it serotonergic, dopaminergic, noradrenergic, BDNF, and other signaling molecules. These candidate genes belong to all those systems. Now, in serotonergic system, TPH1 and TPH candidate genes have been investigated, and several common single nuclear polymorphisms have been described in the upstream regulatory region and in intron 7. 5 serotonin transporter linked polymorphic region is another candidate gene which have been vastly investigated. 44 nucleotide insertion deletion polymorphism of 5-HTT-LPR and short allele, that is SS or LS, of 5-HTT-LPR gene genotype has been implicated in suicide causation. Other serotonin receptor genes like 5-HTR1A, 1B, 2A, 2C, regarding these genes, there have been inconclusive evidence, so also for MAO-A and MAO-B genes. In relation to dopaminergic system, the tyrosine hydroxylase gene located in chromosome 11p15.5, the evidence has been inconclusive. However, COMB gene, which is mapped to 22q11, a valine methionine polymorphism, a low functioning methionine allele, has been associated with suicide risk. DRD2 gene is located in 11q22. This is another putative candidate gene, and a functional promoter insertion deletion polymorphism RS1799732. This has been also implicated in suicide or suicidal behavior. Now, HPA axis is also involved in suicide. polymorphism of CRH gene, T allele of RS4782887 confers risk of suicide. BDNF, a valine methionine polymorphism, is associated with risk of suicide, and this has been replicated in numerous studies. Tropomyosin related kinase B or NTRK2, again polymorphism of this gene has been consistently associated with suicidal behavior. So we have evidence for certain candidate genes, and regarding other candidate genes, the evidence has been largely inconclusive. C129A allele of ADRA2A gene of adrenergic system has been associated with risk of or female suicide completion. Increased methylation of GABA1 gene of GABA neurotransmitter system has also been implicated in suicidal behavior. Regarding signal molecules, protein kinase B ATK1 gene, 2 polymorphisms were associated with suicide attempt and violent attempt. So these are the things, candidate genes, those have been implicated in suicide. Data from suicide also come from genome-wide association studies. Significant linkage has been found in chromosomal region 2p, 5q, 6q, 8p, 11q, and xq. Collaborative study of genetics of alcoholism found a marker D2S1790 near chromosomal region 2p11. Genome-wide association study of individual with bipolar disorder found an association signal on 2p25 at a threshold of genome-wide significance. So these are the highlights of various studies, the landmark studies. Another polymorphism downstream of the guanine deaminase gene was most significantly associated with increased suicidality during antidepressant treatment. We all know that antidepressants have been accused of increasing suicidality in certain group of patients. Meta-analysis of top findings from radiant and Stardust samples revealed an association of RS1377-287 in the solute carrier family 4 member 4 that is called SLC4A4 gene. Now, having talked about genetic contributions to suicide, how these genes interact with environment. Suicide is a complex phenotype that involves both genetic predisposition as well as distal and proximal environmental factors. Now, what has been consistently replicated is the personal history of childhood abuse has been repeatedly implicated as a risk factor for suicidal behavior. Sexual abuse itself can explain 20% of the risk variance in suicide. Individuals carrying the short allele of HTT-LPR and who experience childhood maltreatment or increasing number of stressful life events at a later age were more prone to suicidal ideation or attempt, and this has been replicated multiple times. So these are the robust findings. Bipolar subjects with comorbid SUD had 39.5% rate of lifetime suicide attempt compared to those without SUD at a rate of 23.8%. So presence of a psychiatric disorder increases the chance of committing suicide, but it may not be the sole factor. A forensic study found that polymorphism of TPH2 genotype appeared underrepresented in the group of suicide victims who took alcohol before committing the suicide. GenDep clinical trial suggested that the BDNF markers RS962369 and RS11030102 were significantly associated with suicidal ideation, as was the RS1439050 marker in the BDNF receptor gene NTRK2. Now, coming to the last section of the genetics of suicide, the epigenetic mechanisms. So we have talked about genes, we have talked about candidate genes, we have talked about findings from the genome-wide association study, and we have also talked about gene-environment interaction. Now, at what level this gene-environment interaction happens? This is the thing that we call epigenetic. Epigenetic signatures are heritable and they can be modified by environment. Epigenetic mechanisms in suicide include molecular modification of DNA sequence, particularly hypermethylation, post-translational histone modifications, and non-coding RNA gene silencing. This epigenetic mechanism in suicidal behavior has implicated the role of key biological pathways I have already mentioned, namely the polyamine system, neurotrophic signaling, lipid metabolism, and HP axis. Now, this diagram aptly show that the 4 pathways that are involved in the epigenetic mechanisms, key enzymes that are responsible in maintaining intracellular polyamine concentration has been reported to be DNA methylated, histone methylated, or post-translational mechanisms as microRNA regulations. Enzymes and key genes which are related to chemical or electrical synapses have been reported to be hypermethylated, hypomethylated, or histone methylated. Now, 2 genes that are involved in HP axis regulation, which regulates the release of cortisol in response to stress, has been reported to be hypermethylated in suicidal brains. Postmortem studies of suicidal brains have also revealed 2 key polymorphisms in BDNF and TRKB genes. Now, TRKB gene was regulated via microRNA modification and histone acetylation, whereas BDNF was regulated by DNA hypermethylation of the promoter region of the gene. Now, having said about the genetics of suicidality or suicide, I will shortly go into the cellular changes. There has been changes in several cell types, that is neuron and glial cells such as astrocyte and oligodendrocytes in cortical and subcortical area of brain. Suicide was associated with more serotonin neuron and more TPH2 gene expression and protein per neuron in brainstem area. There were fewer mature granule neurons in hippocampus and smaller volume of dentate gyrus with less angiogenesis. There was deficiency of NA neurons in locus coeruleus in people who die by suicide. 2 brain regions, one in anterior cingulate and medial prefrontal cortex and one in lateral prefrontal cortex, were shown to have activity that was correlated with suicidal lethality. Uptake of 11-methyltryptophan is low in orbital medial prefrontal cortex of people who have attempted suicide and in proportion to the degree of suicidal intent. Investigators have noted higher brainstem 5-HT1A binding in people with depression who have attempted suicide, which was greatest in people who had higher intent and did more medical damage to themselves. Now, these are the summary of neuroimaging findings, findings from MRI studies. In suicidal victims, the right-sided volume deficits were found in cortical areas, particularly orbitofrontal cortex, dorsolateral prefrontal cortex, superior temporal gyrus, and insula. There has been right-sided volume deficit in basal ganglia, increased volume of thalamus and right amygdala, bilateral inferior frontal white matter tracts. There has been increased periventricular white matter hyperintensities and lower anisotropy in left OFC and left anterior limb of internal capsule. Functional neuroimaging studies found that there are changed reactivity to several stimuli noted mainly in bilateral orbitofrontal cortex, right ventromedial and anterior cingulate, and dorsal prefrontal cortex. It is very interesting to note that these regions are involved in emotional processing, decision making, impulsivity, aggression. So, which definitely predicts the suicidal behavior. There was decreased functional connectivity between anterior cingulate and posterior insula, and decreased connectivity between strial motor and sensory network. So these are the fMRI findings.
Doctor, you have 5 minutes more.
Now, supports have also come from neuropsychological findings. There is an association between susceptibility of suicidal behavior and impairment in cognitive control. Susceptible individuals overvalue sign of social rejection, and which is evidenced by hyperreactivity to angry face. The involved brain circuitry, which I have just described, determines the processes that individual use to control cognitively, which emotions they generate, and then decide how to deal with those emotions. So deficiencies in decision making, and the suicide is considered the only way to stop the intense emotional or mental pain. A meta-analysis was done in 2014, which included 25 studies, more than 2,000 participants. A total of 7 neurological tests were employed in this study. Iowa gambling test and category verbal fluency performance were lower in suicidal attempters than in patients with control, and healthy control with no difference between the last two groups. And Stoop performance was also lower in suicide attempters than in patient control and healthy control. So suicidal victims or suicidal attempters performed on this neuropsychological test. Now this is another model, borrowed from neuropsychology, which describe 3 traits: loser status, no escape, and no rescue, which largely correspond to sensitivity to social stress, impaired problem solving, and idea of hopelessness, impulsivity, aggression. Now these constructs again correspond to certain neurological tests, which again correspond to certain brain areas, which I have just described in my previous slides. Coming to the neurochemicals, I have already described this, but again I am highlighting just the main things. Low CSF concentration of 5-HIAA, that is 5-hydroxyindole acetic acid, was associated with suicide attempts and in some studies of patients with psychiatric disorders. Serotonin and 5-HIAA concentration changes in cell bodies of serotonin neurons in brainstem of individuals who committed suicide independent of psychiatric disorders, and there was increase in 5-HT1A autoreceptors. In norepinephrine system, there is deficiency of NA neurons in locus coeruleus and low 3-methoxy-4-hydroxy phenyl concentration in the CSF, which predicts risks of suicide attempts. There is a strong association between HP axis and suicide. This has more to do with DNA methylation of glucocorticoid receptors, resulting in less expression and impaired feedback inhibition and excessive stress response to cortisol. There is deficit in glucocorticoid receptor chaperone protein FKBP5, impairing translocation of glucocorticoid receptor to the nucleus. There is increased level of corticotrophin releasing hormone, which lead to death of glial cells, therefore decreasing glutamate uptake and resulting glutamate cytotoxicity. Both BDNF and TRK receptor levels are decreased in the postmortem brain of suicide victims. PKC activity, that is protein kinase C activity, protein and mRNA expression are significantly decreased in prefrontal cortex and hippocampus of teenage suicide victims. So summarizing the whole thing, the early life adversities in the form of childhood physical, emotional and sexual abuse on the background of various genetic factors causes epigenetic modification, particularly DNA hypermethylation of certain brain neurotransmitter systems and genes, which lead to suicide or attempted suicide. So what are the take-home messages? Suicide and suicidal behavior are heritable to a great extent, probably to the tune of 50%. Early life sexual and physical abuse and stress in adult life may explain some degree of variance to the tune of 20 to 25%. Social factors, for example, unemployment, debt, relational loss, homelessness, presence of psychiatric disorders and SUD may predispose a person to suicide. An epigenetic mechanism holds the key, which remain dynamic throughout lifespan and is also heritable in nature. So thank you. Suicide is a permanent solution to a temporary problem. This problem can be tackled and life is beautiful. We all should enjoy it. Thank you all the delegates.
Thank you, Dr. Chakraborty. Am I audible?
Yes, yes.
Thank you, Dr. Chakraborty, for your detailed description for relation of suicide with society and other side genetic pole. It is a vast, it is a very much complex subject, and we are standing beside the shore of the sea, and many classes will be required to be probed in this subject. Again, I thank you very much.
Any questions?
Question from any side?
No question has been received. No question has been received. We have another 5 minutes. Dinner
কোনো
manager,
question
we have
থাকলে
5
তো কেউ করতে পারেন।
Any question from the audience?
We have 4 more minutes. So anybody want to ask question, or I will ask the moderator to conclude this session with the comments.
Presentation. Very informative. I just want to ask one thing. You have said about 7 neuropsychological tests.
Since we do not
You have asked about 7 neuropsychological tests with AGP and other that. I don't understand this thing.
No, these are the 7 neuropsychological tests: Iowa gambling tux test, Stoop test, trail making part A, part B, Wisconsin card sorting test, category and semantic verbal fluency, and CPT, continuous performance. So these are all neuropsychological tests used to assess cognitive dysfunction, cognitive status of a particular patient. So psychologists are very much conversant with that, and those who are having training with the psychologist or psychologic department of a psychiatric hospital, they are conversant with this test. And Wisconsin card sorting test, a particular test which is associated with repetitive performance, shade shifting, those constructs, and they help in evaluation of cognitive performance in a dementia patient or elderly patients who is having cognitive problems.
Another one point. In clinical practice, in hospital and chamber also, when one patient having suicide attempt, after that, when the family member think about 30-year lady and her young girl or young boy, she and her husband and her family member are asking, sir, is it heritable? I am saying that it can be. So, sir, can we start treatment from 7 years or 10 years? What should be our opinion?
Now, like there has been some suggestions that we start treating schizophrenia before it actually happens. So one can start treatment from the prodrome stage itself, or one can start schizophrenia before even the clinical symptoms are evident. So nothing has been suggested in cases of suicide. But if somebody asks you whether suicide is heritable, it is yes. How much of it is heritable? You can give data from the twin studies, like in monozygotic twin, it is 13% heritable. In dizygotic twins, in monozygotic twins, it is 25% heritable, and in dizygotic twins, it is 13% heritable. So these are the things that you can tell because these data you have. But if a particular father or mother has committed suicide, so what is the probability of the child committing suicide? There is increasing risk, but you can't definitely tell how much is the risk, because we know that these things do not follow the Mendelian pattern of inheritance. These are all polygenic in nature, and environmental factors do play a role. So thus you have to answer the parents.
Can I ask a question? Am I audible?
Yes.
Am I audible? Kaustav, can I ask a question?
Go ahead.
Okay. Thank you, Kaustav. It was an excellent presentation. I just have a, I just have an observation, because there is a discrepancy in the data comparing the Western and the Indian data. Psychosocial factors predominate over here to the extent that family problems contribute to 35% of suicide and unemployment to another around 18%. So there is a discrepancy in terms of environmental factors being more dominant in the Indian context as opposed to the Western context. So would you attribute that to the epigenetic risks? Because as you mentioned, the heritability is around 25%. So the rest, is it contributed by the epigenetic risk?
Abhirta, hello, Abhirta, can you hear me?
Yeah, I can hear you. I can hear you.
I think you are probably right. There is no way to determine the genetic component of suicide, particularly in Indian context. Indian suicides are more often than not impulsive in nature, and there is a much more altruistic component to Indian suicides, particularly pharma suicides, where the genetic heritability or the genetic component plays a much lesser role. This is in my opinion. I have no data to establish this particular statement of mine. But yes, the impulsivity factor, the unemployment, poverty factor, indebtedness, and altruism, these probably play a much bigger role in Indian context than our Western counterparts. And genetic heritability in Indian population, it is there. Probably it is more in our clinical population rather than the community population. So that is my humble submission.
Everyone, thank you everyone. We have
yes, I think there are few, Shubir, there are suggestions that few of the candidate genes like the 5-HTT-LPR, 5-HTT-LPR gene has been linked to suicide as well as mood disorders, as well as alcoholism, as well as childhood impulsivity and aggression. So there are some commonality when we talk about in terms of candidate genes, which are both shared by suicide victims and patients with mood and psychotic disorders. But what the studies have suggested, the twin studies, family studies, and adoption studies, and also from the genome-wide association studies, that heritability of suicide is more or less independent from heritability of psychiatric disorders.
Thank you. Thank you.
Thank you, Kostabda.
Yeah, thank you everyone. Thank you, Dr. Banerjee, Dinan Banerjee, and Dr. Hena Borat. And we move to the next our session, that is a panel discussion face to face with COVID-19. And our panelists for this panel discussions are Dr. Devashish Shannal, Dr. Mukutananda Kundu, and the moderator for this panel discussion is Dr. Avinandan Brahmo, and chairperson Dr. Rajarshi Niyogi and Dr. Arnav Sarkar. And this particular session, this panel discussion is sponsored by pharma company called Intas. So I will now tell Dr. Anirban Brahmo and Arnav Sarkar to kindly proceed and start the panel discussion session. Thank you.
So today we have two panelists, Dr. Muktananda Kundu and Dr. Devashish Shannal. Is it right?
Yes, unfortunately, Dr. Ashish Mukhopadhyay is not available,
yes,
I believe.
Yes, he was the panelist, but he dropped out.
Oh, okay, and among the chairperson, both are present, Arnav and Rajarshi.
Yes, Dr. Rajesh Nyogi and Dr. Arnav Sarkar.
Arnav Sarkar. So may I now request Dr. Rajarshi Niyogi and Dr. Arnav Sarkar, two of my junior brothers, who are chairing this very interesting panel discussion. So to the start with, if they want to speak something, our chairpersons, Dr. Rajarshi and Dr. Arnav, please. Dr. Rajarshi.
Rajarshi sir is in the venue actually. So, Dr.
Okay,
Sarkar.
so Dr. Arnav
Yeah.
Sarkar. Arnav,
Yeah. I am here.
Hello.
If you want to say something about this very interesting topic, live session with the COVID warriors. So, what is your view? If you want to say something.
Yeah,
as a
surely.
chairperson.
I have a lot of things to say actually, because I am one of the few psychiatrists who are actually in the front line of the COVID warrior. Because I am now currently I am in Sagardatto Medical College. So now everyone knows that Sagardatto is a COVID hospital. So we have to encounter a lot of patients with COVID, and the patient are also having a lot of psychiatric comorbidities. Are also we are encountering daily. So actually, most of the people who are we are encountering the COVID positive patients. A lot of patients. There are almost 350 beds now currently running in Sagardatto Medical College. Among them, most of the patients are having the anxiety. Not only the patient and the patient party also. Whenever they are getting positive, and that their scenario is looking like that they are having an acute stress reaction. That I am having COVID. What should I do now? And we are also encountered a lot of histories. Just few days ago, I have seen in newspaper one young person he's committed suicide after getting the positive report. So psychiatric morbidity, one of them is anxiety, and a lot of people are actually the coverage and all other things make them very anxious that COVID positive is like a very serious issue. Although we know the mortality rate is quite low, and the patients are most of the patients are getting cured very without or minimal illness. But yes, it is an issue, and it is increasing. The pre-existing psychiatric illness is there. I want to invite the other chairperson Rajashri to say something.
Dr. Rajashri.
Thank you so much. This is my lucky day to be meeting with you virtually and other people in the podium. We know the most burning topic, the topic of today. I think there's a feedback here. So this is one of the most presented topic, one of the most pertinent topic, one of the most topic that we are knowing. I mean, we are knowing about this topic more and more, and we are getting by and far newer experiences every day as we practice with the COVID patient. We had, and I also personally have had our brush with COVID patients, and this is, I think, this is by far the most talked about topic in psychiatric circles, and this is by far the most important. And we have great speakers, we have great moderators. I think I would I won't do any much ado, and I'll tell the moderator to start the topic and set the ball rolling. Okay, over to you, Dr. Aurobindo.
Thank you, Dr. Rajashri. You have rightly said that this is a very interesting topic. So today we have two panelists, Dr. Muktananda Kundu and Dr. Devashish Shandal, my very favorite two senior dadas. I am starting with Dr. Muktananda Kundu. So Muktada, when you first apprehend some symptoms of COVID, and so what was your initial reaction? And when you had these symptoms and you went for the testing and you got the positive report, so what was your initial reaction at that time?
Let me start. Am I audible, Aurobindo? Am I audible?
Yes.
Hello.
You're audible. Yes, you are audible.
Okay, let me start with a quote from Tagore.
Yeah.
প্রাণ মরিতে চাহি না আমি সুন্দর ভুবনে মানবের মাঝে আমি বাঁচিবারে চাই এই সূর্য করে এই পুষ্পিত কাননে জীবন্ত হৃদয় মাঝে যদি স্থান পাই. This is our motto of all. At about I am practicing and I am attached to the district hospital Howrah, I know, and I am practicing in Howrah as well as in Kolkata. In the mid-week of July, suddenly it was on a Sunday evening, there's a torrential rain, and the night I felt irritation in my throat. On the 13th or 14th of July. Hello? It was
yes, you are audible.
It is 13th of July. In the evening, I felt some irritation in the throat only. not much cough, no running of nose, no loss of taste or smell, whatever it may be. The next day, at the night, I had a temperature of 102. And before that, I had a peculiar symptom, severe burning sensation all over the body, burning sensation only. Then I took only single paracetamol. The next day, the temperature gone, and it was all right. Only temperature was mild, only 99 or 98.45 lakh days. Nothing happened. But I had a suspicion that I am going to my chambers, I am seeing the patient. So there might be a chance of COVID. So let's have a test. After 3 or 4 days, I myself went to Bellevue Clinic and have a test done there. On 14th, next day, on 16th, I myself did a CT chest, and there I find a spot. And in the left upper zone, very small opacities. I contacted the doctors who are treating on Bellevue the COVID patients. He said nothing will happen. This might be a case of COVID. You just go home and take rest, and some medications like azithromycin, and let me know if anything happens. Let me know. We'll call you back. And the next day, that is on 17th. On 17th, I got the result. They're COVID positive. And then and there, I took the decision to get admitted. But I called my doctor. He said, no, you go home, no problem, it will be all right. But a panic struck me. I am in home where I am in a flat. So strictly home isolation is not possible. Moreover, it will be a burden to my family, my daughter and my wife. Najee, to get rid of that burden, I myself went to Bellevue and asked my friend to get myself admitted there. And that day on 17th of evening, I received the result. And on that particular day, I got admitted there to be on safer side. And you know, I was otherwise asymptomatic there, but my results were abnormal. Like D-dimer test was very high. I was asymptomatic. Oxygen saturation was quite normal, 97 to 99%. Still, D-dimer was abnormal. Then they started the treatment. And I was definitely panicking on the first day. Definitely I was panicking. So what will happen if I don't get the bed there? And the scarcity of beds was so much so that beforehand I got admitted.
Yes, yeah, you are right. But how do you feel when you got a bed and you got admitted in the hospital? So staying away from the family members.
Definitely,
So what was your feelings then?
At one end, I was relieved that at least I got a bed and at least I am in the safe hand. But you know, you take the case microbial infection vis-a-vis. If I did have the microbial infection, then I could have my family members with me. They could have gone with me. They could be there and I could be there in my home itself. But here, none was accompanying me there. I alone went there. And my daughter and my wife stayed in home back and strict home isolation. I didn't know what is going on in home and they couldn't know what is going on there. Only the communication was through the mobile phones and the 1 or 2 video calls. And definitely I was panicked that time.
Yeah. So mobile phone was allowed in the hospital.
Mobile phone was allowed in the Bellevue clinic. That was
Okay,
the only hope and the positive.
Yes, yes. Okay, thank you, Muktada. So now I'm moving to Dr. Devashish Shandal. I will come back to you, Muktada, again. So Devashish, First of all, I want to congratulate both you and Muktada because you are, in true sense, you are the COVID warriors. So my question is, because you were there in the home, unlike Muktada who got admitted. So what was your experience in home isolation? You are totally isolated from your patients, from your family, friends. So how do you manage this, and what was your experience at that time? If you
Honestly,
share that.
I thank you, Aurobindo, for allowing me to speak here. Now, none of us are basically willing to fight this war. We are forced into fighting this war because this infection came to us. I was, after just a lockdown, that month of April onwards, I was actively involved in practice. That is, I had started the periphery practice, I was doing the Kolkata practice, and I was expecting one day this COVID chap will catch up with me. But interestingly, I got infected not from chamber, not from my patients, but from a very simple program, as a puja program that was being held in my in-laws' house. So that was a very unfortunate thing. And that also had a disastrous result. My mother-in-law died of COVID. Another elderly lady at that house also died of COVID. And almost all the household members in that particular house in Baranagar got infected. Now, when I came back from there, I had a fever. I thought that, well, nothing has happened to me. Then onwards, I began to have a sighing respiration. There's a deep respirations coming in. I checked my saturation, nothing. For last few years, I have been a bit panicky. My younger child has been giving me a lot of panic. He has hemophilia, he had Guillain-Barré. So I was having incredible differential diagnosis in my mind. But, well, saturation was normal. Okay, fine. I went on. I was also continuing my practice and so on. Then my mother-in-law's diagnosis came in. She had almost 90% lung involvement. So, and immediately I realized I have got it. So I got myself tested. And when I, in a particular lab where people know me, they called me up that your younger son's report has been done. Your report is still pending, but who will come to get your eldest son tested? And I immediately understood that both me and my wife are infected, because no one, otherwise this discussion won't come in, because otherwise I would be taking him for testing. So when I came to know that I am positive, and my wife is also positive, my immediate cause of concern was not myself. I was extremely worried about my two children, especially my younger child. I was totally not aware, and in fact, I had consulted with almost every hematologist here who said that COVID's response in hemophilia is totally unknown. It can be disastrous as well. So I was scared about him. I'm not scared about me. So immediately, well, I did my biological markers of this disease. Again, just like Muktada said, though I had very little symptoms, my markers were way off. Interleukin-6 and all those things were very high. I had asked people that, well, do I need to get admitted? They said, well, no, go ahead with home isolation. Now, that home isolation is a very easy thing. Home, sweet home, as our Honorable Chief Minister has said, but it is not very sweet, because thank God we had a house which has 2 floors. So we got ourselves quarantined in the ground floor, and our children were basically to stay in the first floor. And we were keeping in touch with them using latest technology, Zoom and all those stuff like that. Now, it sounds very nice, but it was not nice at all. The 2 children were worried that what will happen to us and how they will manage on their own. So that was a very big problem. And we were scared that if they got positive, they are unfortunately tested negative, then there would be even more problems, how to manage the entire thing. So that was the first initial issues. Every night I used to feel that, well, if today I suddenly develop shortness of breath, how will I get admitted? Thanks to the excellent ambulance service and other things in our state, well, it is very likely before I get admitted, I will have my judgment day with God. So that is also a very likely possibility. So that was there. Now, the problem was that it was the home isolation. Though the government doesn't give much of help to people who are home isolated, I realized that I have to provide some declarations, very annoying declarations, that I am willing to stay in home isolation, and I have to produce a doctor's certificate that I am supposed to stay in home isolation, and my own certification won't be sufficient. another doctor has to certify me. Now, for me, okay, we doctors can get certificate from our colleagues, but for other people, this must be a very disastrous stuff, because how can a person who is COVID positive, who will come and give them a certificate coming to the house? So that sort of thing. So then we came into another problem. What about food? We obviously can't go to the market and buy the food. How will you get food? At least the children needs to have some food. Now, obviously, we arranged for a home delivery, but I had to try at least 10 providers for that. One was willing, but they said, well, we will keep the entire food about in a sort of a street corner, and someone will have to go and collect it for us. So they won't come very close to us because we are COVID positive. So we realized it is also something to do with the stigma of the disease. Then, of course, we found that no one would come to us to collect our house's garbage. It might sound very simple. It might sound very minor stuff, but it is not so, because usually the entire household garbage began to accumulate. Yeah, no one will come because we are COVID positive. No clearance, nothing. Of course, the damage had already been done. Our house was sanitized by the corporation from outside. The spraying was done. So we were branded COVID house, with people avoiding us like plague. So this went on. Luckily, we developed no major symptoms. Both of us, me and my wife. We continued with this. Our children, well, they were just counting days when we will get released from this quarantine and this level sort of stuff. Then the days, but within this quarantine period, my mother-in-law, who was admitted with severe COVID symptom, died in the hospital. We couldn't attain her death. And of course, we also faced the painful tragedy of family members who are not allowed to attain the last rites of the patient, not even allowed to see the last rites. We don't know what happened at the end. So very painful stuff. Not only our own pain, sorrow of being quarantined, facing a deadly disease firsthand, some biomarkers going haywire, scare of getting admitted, well, possibility of death. But again, death of some very close family member whom you cannot attend the funeral. She was a very religious lady. We don't know what happened to the last rites of her, but nothing was allowed. Though court orders are there, as you know, that family members should be allowed to attend. We couldn't possibly attend because we were COVID positive, but others could have, but nothing of that. So ultimately, when we came out of the quarantine, well, we were thankful that the worst has been over, but we also faced that we were lucky. At least 2 of the family members were dead because of this virus. We were lucky our body was able to resist the virus. Well, this entire experience is something, as a psychiatrist, I must say, has changed me a lot. It is easy to counsel people about deadly diseases. A lot of people come to us worried. Well, they think that they have COVID when they do not have. But here we are, we face the disease. We know family members have died. Well, that is a really scary experience. It is something that I realized we used to scold people. Why are you scared of this disease? Our government also tells us there's nothing to worry about COVID. But we realize this is a disease which has a lot of issues. Even after recovery from COVID, the things were not very simple. I found that though I did not have any saturation problem when I was having the COVID disease, I had difficulty in doing day-to-day work. I started my chambers very fast, trying to catch up with the monetary loss. I found doing chamber was also very difficult, very tiring then. I thought, well, that I don't need to see patients, and feeling of extreme hot sensation for the body, multiple body aches. Well, these are still continuing as a post-COVID is there. So this disease, in my experience, I see it has changed me, made me more humble possibly. But even so, I understand that I thank God for having at least had the mercy of sparing the children from the ordeals of the disease and for allowing us another day to fight in this world until our death, which will come one day or other, but not of COVID, hopefully. Thank you.
Thank you, Devashish. So, my next question to Muktada, what Devashish just mentioned about this some sort of stigma in the society. So, what he has faced from the neighbors or from the community. So what is
Yes.
your experience?
Yes, it is there. It was there, and still it is there, because whenever just before the COVID, pre-COVID state, just before having the COVID, whenever I used to go to the hospitals or the chambers, people around here or my neighbors used to frown at me. Oh, this guy is going to hospital. This guy going to chambers, and obviously he will be coming with the infections, and these guys are responsible for spreading the disease. And they wish if I could not use the lift. Naturally, we feel something segregated. I used to use staircases other than lift. Hello, hello. Am I audible?
Audible.
I just use staircases. Just they wanted me. They actually they treated me as the carrier of the disease, as if I am carrying lots of infections with me from the hospitals or the chambers. But the people here, they used to go to the market for very minimum issue, but they think they are well. They may not wear the mask properly. They may not wear the gloves or others. But I used to wear the gloves, caps, helmets, mask, everything. But still, they suspected me and they frowned at me as if I'll be carrier. And moreover, they after the COVID attack, they barred my maids to come in my house for work. They tried so that our maid may not come over here. They threatened otherwise my maid that they won't allow them to work in their houses if they come to our house.
Okay.
So in some way or other, we feel humiliated there.
So being a doctor, in any point of time when you are positive, you've really felt helpless, though you are a doctor, while you are in hospital or you are at home.
Yeah, I practically in hospital. I was there for 8 days, and my family is in the home. I don't know how they're running the family course, and I asked 2 or 3 of my friends to supply the fruits or the vegetables in the gate. They used to do that. But otherwise, I was very scared that how my wife and my only daughter, they are maintaining my household chores, and how the people are treating them, how the scavengers are maintaining the cleanliness of our corridors, because they couldn't take they couldn't come to take our just garbages regularly. Twice in a week, they used to come over here and collect my garbage from outside.
So when you came back from hospital, from neighbors, you got the support, or they are basically avoiding you or your house?
Basically, it was a campus, so there was a rule. They hold a meeting for me at least, when they will allow our maids, when they will allow our lift, everything. So they told me that okay, at least 2 weeks you take rest in the home. Thereafter your maid will be allowed. But in between, even after 2 weeks or so, our maids are not allowed by the others. They came at least after 3 weeks. And people used to keep safe distance from me, knowing fully well I'm negative and there is no chance of spreading the disease. Still, they were avoiding. Still, they couldn't keep talking to me.
Okay,
Practically
that is really
avoiding
unfortunate.
tendency.
That is unfortunate. So now, Devashish, my last question to you is, because time is short. I think most of the doctors will want to know how you have initiated your practice then, because you are in full-time private practice. So how you have initiated your practice practice. I mean your mental strength also, how you cope up with the situation and your mental strength, because you have already mentioned you got some body ache and other things during practice. So the initiation, how you have initiated your practice, if you just tell in few words. Please unmute, Devashis. Devashis, please unmute yourself. Devashis, please.
The whole issue is basically to practice or not to practice, just like Hamlet's famous question, to be or not to be. Now, this epidemic, unlike the very great projections of our governments, is not going to go away so soon. So what is going to happen is that we have to continue with the whole process for some time. So from the beginning, from the month of May itself, I had made clear that I will have to practice, but of course, see a limited number of patients. Try to take precautions. Now that, when I restarted, initially I was myself not able to see a lot of patients because I was fatigued very easily. Starting it off, well, the thing is, it is, as you obviously know, in Kolkata, it is easier to screen people, to take better precautions. So the practice in Kolkata is far more organized, structured. You can screen, you can do a lot of things. You can even have a social distance in the chamber. In a periphery level, well, nothing of that sort can be done. No one understands any damn thing about that. And unfortunately, a lot of patients are not willing to wear masks. They absolutely vehemently deny that they won't wear a mask, it's not needed. Some of them even have an argument that this disease doesn't happen in rural areas, it happens only in Kolkata. Kolkata people bring the infections to them, and of course, doctors bring infection to them, not the other way around. So my initial decision was that anyone who is not wearing mask, not allowed. That patient is cancelled, number one. Number two, of course, minimize the physical examination. That's very, very clear. Once upon a time, I used to do a lot of physical examination of the patient. Now, even the blood pressure is being checked by assistants. Only in very complicated scenario where you need to check something with appropriate precautions, I will be doing a physical examination. And this has been a helpful thing. After recovering from COVID, at least 3 of my patients from one chamber, where I've seen a few large number of patients there, they were positive on that day. They did RT-PCR, they were all positive. So I was lucky not to get reinfected possibly. So that sort of thing is there. Yes, we have to take our precautions. Mask, N95 is imperative. And of course, wearing a face shield, very important. Keeping a social distance. There is no use of trying to be a hero. It is not going to help us because people won't consider us a hero. I may tell you here that when I recovered, a particular few patients in Kolkata had asked me, "Doctor, did you get your test negative result?" So that they're thinking about ourselves as hero and taking a lot of risk is not going to be a very sellable commodity. People don't really consider us heroes. They consider us as a utility, which they will use when they need and throw away when they don't need. So we have to take our own precautions because after all, when the chips are down, we are alone with our family. And our professional colleagues will be helping us, but others, patients, are mostly very insensitive about the whole stuff. When I was in quarantine, when people was to call me for appointment and stuff like that, they were not very happy that doctor is not seeing patients. They say that I have an emergency I need your emergency appointment. Why you're not giving me appointment and stuff like that. So the entire thing is something that we are getting a vicious feeling that, well, people just consult us, they pay money, so they think that they have every right to seek consultation anytime, irrespective of whether we are ill or not ill. So if that is so, we need to be more cautious about our own health because that is going to be very supreme importance to us and to our family members. So that may sound very bad, but it's a realistic sort of assessment. Though it might sound that, well, doctors should sacrifice their life and stuff like that. It is a very heroic statement to make, but already more than 350 doctors in India have made that supreme sacrifice. But as we know, governments don't even have data about them. So we are just numbers adding to the death row that is happening here. So we have to be very cautious, see lesser patients, very important. Try to keep the distance, very, very important thing. And of course, insist on that whoever is coming to you must wear a proper mask and wear it properly. If not, refuse to see the patient. We have every right to refuse to see a patient. If the person is not taking that health precaution, refusal. With just one anecdote experience I'll end. After I came out of this, tested negative, my elder son's birthday was there. We wanted to buy some food from a local restaurant. We are a very good patron of that restaurant. They know us very well, but they refused to deliver us food. They said that you had COVID now. So we said that, well, we have tested negative. What's the problem? They said, no, we shouldn't deliver. There will be a lot of problems. Our employees will have problems. And then later on, if our customers come to know that we are delivering food to COVID patient, then there could be problems. So that sort of thing, there is a very unfortunate thing. And there is not only the stigma, there is a extreme amount of misinformation in the public. With that sort of thing in mind, we have to be cautious. And since we do not know whether reinfection is possible or not, I, Muktada, and all other doctors who have come out of the COVID experience should be cautious again that we can also again get reinfected. And all other doctors who are yet to join the COVID club with the passport of RT-PCR positive status, I would request everyone to take precautions not to join that club, because that club is a dangerous club and can take heavy tolls, including life of a person. Thank you.
Thank you, Devashish. It's really unfortunate that we doctors, when we are in need, we don't get that help from the society or government or anyone. We are really helpless. Muktada and Devashish clearly mentioned that they thought a lot about their own health, about their family members, getting things not possible at that time. So it's a miserable condition. And I think many doctors from other areas also, they had the similar experience. Now we are going to end this session. So may I request our chairpersons if they want to comment in brief something. Dr. Arnab or Dr. Rajoshi, anyone?
Hello. Yeah. I have something to say. I want to share one of my experience in this regard. As you know that I was in CNCI, California Cancer Institute, second campus duty, COVID duty, and later I have done my duty in our own hospital in Shagodotto. So there is a very good chances of get positive. And few days ago, a lot of people here know that I am blessed by a young male child few days ago in 29th of July. Before that, when I'm in terminal pregnancy period of my wife, and that time, few days ago, I was get a few RTI-like symptoms, pain in my calf and throat pain, common cold, etc. And that time I was ignoring that symptoms. And just after 3 to 4 days, my wife started complaining the same similar type of symptom just like me. Then I get quite worried, because as she was in terminal stage of pregnancy. That time I communicated with my teacher, Dr. Devdatta Ghosh in gynecology, and he told me that do the COVID test of our whole family, and if she got positive, I will not do anything to her. You have to take her in your college in Shagodotto. That time my own condition was quite worried. I was quite worried at that time, and I do everything, and luckily my and the whole family's results become negative, and that gave a lot of relief, trace of relief to me. And that is all from my side, and thank you for this very beautiful presentation, and thank you Muktada and Devashish. Okay.
Rajoshi, if you want to say.
Yeah, thank you. Thank you for letting me in. I have a bad feedback, please. Can you, is it okay now? Okay. So, two very harrowing experiences with my patient. Two COVID positive patients. I was just relating this to my senior colleagues now. The first patient was the sister of an intern of Arjigor Medical College, she preferred to be admitted, many of his psychotic symptoms, she preferred to be admitted at a private nursing home. As a result, as a rule, the RT-PCR was done, she was asymptomatic, she came to be COVID positive. And then that she was COVID positive, the family, that she was asymptomatic, the nursing home turned her out naturally. So because the nursing home doesn't have, no let me tell you, at least in Kolkata, I have found out that there is no nursing home, private nursing home, which caters to COVID positive acute cases. This is a very, very bad part on our side. Whatever. They said that they are developing these facilities, and they said that she cannot be kept in definitely. So she was turned out, and the family decided that she was asymptomatic, decided to take her home. She rummaged her home. She sort of created a huge ruckus. I was doing the medications. I naturally had to sort of go soft on medications and avoid the medications which prolong the QTC. Her COVID regimen was started. That was also online. And she was sort of, quote unquote, according to ICD terms, she was declared to be fit in ICMR terms. And in ICMR now doesn't actually approve a repeat COVID testing. So on day 16, after day 16, on day 17, she was readmitted to the nursing home. And as a rule, the nursing home also did repeat RT-PCR testing, which came to be positive. This testing might be due to, according to the experts who actually treat COVID, which I inquired, might be due to the remaining RNA fragments. Whatever, you cannot tell whether this is due to the COVID still remaining in her body or due to the RNA fragments, which are very much picked up by the RT-PCR. And in both of the times, she had low viral load, no symptoms. She was again turned out by the nursing home. Now starts the harrowing time. That her medications were reduced. She was still in the relapse. She was still very violent. She was still very agitated. And her caregiver, her mother and the sister, they were the main caregivers, and she had delusions against both of them. So now she was then referred to Medical College Kolkata, which is our COVID hospital, which actually caters to COVID patients of all facilities. That is the term that they use for Medical College Kolkata. Medical College is now operating COVID patients with pregnancy. They are now doing normal deliveries of COVID patients with pregnancy. Normal delivery of COVID patient. The Medical College is doing elective operations also on COVID positive patients. But what happened is that the Medical College principal and the Medical College superintendent turned out this patient. So this patient was left in the lurch. I tried to sort of get the patient into a COVID hospital, which is a private nursing home and which has no facilities to care for psychotic patients or manic patients. And now she's in the hospital. They are having a harrowing time. I am having a harrowing time, and she is still COVID positive. Her COVID test, the repeat RT-PCR test, has gone to them. So this is the problem with the patients who are COVID positive. And today morning itself, we had a situation at Arjigor. I am at Arjigor Medical College. We had a patient who was homeless. Many of you know him probably. He's been with us since 15 years. And he's mentally retarded, has seizures, and has psychosis. And he is COVID. He has become COVID positive due to an infection in the ward, maybe which was gotten from the attendant of the ward. And now this patient, we are sort of at a loss because Medical College is not taking this patient. We are at a loss about how to manage this patient. The bottom line is that in West Bengal and in Kolkata, still now we don't have a facility where we can treat COVID positive patient with acute mental symptoms. And this is, I think, is a very harrowing time for the psychiatrists at large and the patients definitely, their family members. I think this need to be taken up with the IPS maybe or our colleagues maybe or with the state administration so that we can have a facility so that they can treat COVID positive patients with psychosis, with BPAD, whatever, with mental illness. So this is all that I can comment up to now, and I think we need to take up this issue with the administration, with the hospitals, with the COVID management of the state.
Yes.
Let our patients thrive when they're. Thank you.
Thank you, Rajesh. Thank you, Dr. Abhi Mukherjee wants to comment. Yeah.
Yes.
Yes.
There are two things I want to say. One is that I don't find a single family who has not been touched in some way or the other with COVID. And I also had a personal experience which I won't share because I'm not part of the panel. So there's no point, but I can empathize with Devashish with regards to, the last rites not being allowed to take part in the last rites, how harrowing it can be to the family due to the personal experience I had. I just wanted to ask both Muktada and Devashish that were they on any prophylactic medication and did they take anything? I mean, Muktada was in hospital, so I'm asking Devashish specifically that did they take anything for their mild symptoms? Were you taking any medication after you were detected with COVID, and even prior to that, were you on any prophylaxis, namely hydroxychloroquine?
No, I was not taking hydroxyquinone. I was not on it. And when I had COVID, I was on ivermectin, doxycycline combination, along with, since my inflammatory markers are way up, so I was on steroids when I was having this problem and other supportive medications. So I was never on prophylactic. And even after recovering, having documented high antibody rise as well, at this moment of time also, I am not on prophylactic because this status is totally very controversial, whether after exposure to COVID, you should be on prophylactic or not. But I am planning after 2 to 3 months when antibodies are supposed to wane out, then possibly ivermectin will be a safer choice as a prophylactic for me.
Muktada, please. And on any
Muktada, unmute. Muktada, unmute yourself. Muktada, unmute yourself. Muktada.
Hello, am I audible?
Yeah.
No. Unmute. Muktada, unmute. Unmute yourself.
Hello, now it is audible?
Yeah.
In the month of April, I consulted my physician friends who advised me to take the hydroxychloroquine as a prophylactic measure, and I took it.
So you were on hydroxychloroquine when you had
at least on the first day 2 tablets, then weekly for another 6 weeks I had. And moreover, as I reside in a cooperative society, my condition was better because officially they declared to help me. Officially they declared to provide assistance from the gatekeepers, to provide assistance from otherwise.
Okay, thank you.
Okay, thank you very much. Thank you, Dr. Muktananda Kundu and Dr. Devashish Shandal, our two panelists, and Dr. Rajoshri Niyogi and Dr. Arnab Sarkar, today's chairperson. Thank you, the organizing committee of Psycon 2020, for giving me the chance to moderate this very, very interesting and experience sharing session. And I hope all of you will have a good and sound health. Thank you. Over to the organizers. Thank you.
Thank you, Dr. Mo. And now we will move forward to our lunch break. And post lunch break, we have our debate session, which will be moderated by Dr. Abir Mukherjee. So from now on till 3:30, we'll follow to the lunch. Thank you all.
Thank you.
We'll see you after the lunch.
ভালো দেখাচ্ছে অংশমান, চুল ঠিক করতে হবে না।
আরে বস কেমন আছো?
চলছে, নামটা চেঞ্জ করো, ওয়েন্দ্রিলার নামে হয়ে গেছে, রিনেম করো।
আচ্ছা শালা, এটা কি করে চেঞ্জ করে?
রিনেম একটা অপশন থাকবে তো।
ওই ওয়েন্দ্রিলার ওখানে ক্লিক করব?
হ্যাঁ, ও রিনেমের অপশনটা দাও।
পেয়েছি।
কট ইন দ্য অ্যাক্ট, চুল ঠিক করে।
কটের আবার কি আছে?
না কিচ্ছু নেই, ভালো তো। এই
তুমি তো ভার্চুয়াল আছো তাই তো?
হ্যাঁ, আবার কি?
কালকেও রাজস্বী বলছিল চলে এসো দাদা, সবাই মিলে এখানে হবে। গৌতম দাও করে বলছে, এরকম বলছে। গৌতম দা বলেনি, রাজস্বী গৌতম দার হয়ে বলছে। বলছে ভাই এটাই কর, আর ঝামেলা করিস না। আমার মনে হয় কিছু গেছে জানো তো।
হ্যাঁ, 13 জন 14 জন গেছে। 3:30 বাজে প্রায়।
জনতা কোথায় গেল?
আছে সবাই, অনেকে আছে।
আচ্ছা,
হ্যালো,
সবাই এসে গেছো?
সবাই মানে আমি এসেছি, অংশমান এসছে এই পর্যন্ত দেখতে পাচ্ছি, বাকিরা তো সবাই অবগুণ্ঠন আবৃত।
তোমাদের মধ্যে সুব্রত এসছে, তথাগত এসছে, সুব্রত দাস।
আচ্ছা, ওদের ইয়ে থেকে আসতে হবে কিন্তু টেকনিক্যাল
দাস এসছে, আমি তো ঠিক চিনি না সুব্রত দাসকে। অংশমান দা হ্যালো, কেমন ব্যাকগ্রাউন্ডটা লাগছে সাইকনের?
ফার্স্ট ক্লাস, তোমাকেও দারুণ লাগছে।
Ma'am, we will start in 10 minutes. In 10 minutes we'll start.
Who's having delayed lunch now? I was told it's going to be at 3:30.
The last session was extended, no?
Yeah, it was, but we were still going to, because see, we have the the guest speaker at 5 o'clock. So we thought this would be still acting as a buffer time. Because I rang Rajoshi.
Another 5 minutes we'll start.
Please.
Please start as soon as possible. Otherwise,
yes, please. Let's not make lunch. ওই তো আমাদের তো লাঞ্চ হয়ে গেছে।
and
বেশি লাঞ্চ খেলে শরীর খারাপ করবে।
Because everyone has come prepared, না? শুধু তাদেরকে তো দিতে হবে।
Oh, sorry, we are live already. I'm so sorry.
No, that's okay. We are between ourselves.
No, you haven't spoken anything which is
out of the order,
which is unclassified.
Yes.
But still, it's on YouTube, you know. And
okay. So, is Rajushi, are you there in Gautam Das place, or are you?
না সকালেও আমাকে 20 পয়সা না
Okay.
না গো।
Okay.
My children have exams coming up, so I can't take that much of a risk.
Of course.
Nothing will happen. I'm sure I'm already been infected 20 times by this time. The way
But
I have
still.
moved around.
But still.
But still.
Okay, I mean, officially, I think all the year are there, na? যারা সুব্রত আছে, আরেকজন সুব্রত দাসকে দেখতে পাওয়া হয়। ও
Sir, I think we should start now. And did everybody come? Subroto?
No, there will be a voting in the beginning. Okay, so the more people joining, the better it would be. But anyway, we can't wait indefinitely. That's also true. The call is on Rajashri to take a decision.
Is here? Rajashri কোথায় আছে?
Rajashri na, তোমাকেই বলছি. You are in.
But Amit will be guided by the organizers. Let me quickly ring them once. Still, জানো তো? দাঁড়াও, এক মিনিট আমি।
তথাগত।
নমস্কার স্যার।
স্যার করছিস না?
আচ্ছা, তথাগত আর সুব্রত মানে সুব্রত নস্কর একদিকে আর অংশমান আর সুব্রত দাস আরেকদিকে, তো?
একদম স্যার। অংশমান স্যার, আপনার টাইটা খাসা।
থ্যাংক ইউ। এটা টাই র্যাক বলে একটা কোম্পানি আছে, তারা খালি টাই বানায়, বুঝতে পেরেছিস?
না, সেটা ইউটিউবে চলে গেল কিন্তু অংশমান। টাই র্যাকের অ্যাডভার্টাইজমেন্ট হয়ে গেল।
Speak to not.
তো গৌতম দাকে বলছি, গৌতম দা রাজস্বী ফোন করেছে প্রোগ্রাম স্টার্ট করতে, বলছি হ্যাঁ না কিছু বললো না। 35 is the latest. Okay. I think there's no reason we should not start now.
No, there isn't any
okay.
reason.
We have the the technical team. Maybe start. Sushant.
Ma'am, we are ready.
Yes.
You're ready for the poll?
Yes.
As well? Okay.
Yes, ma'am, we are ready when you're ready.
Okay.
The poll is also through, isn't it? Okay.
We will start, yeah. So it's being streamed. Good afternoon to everyone. On behalf of the Psycon 2020 Organizing Committee, it is my honor and my privilege to welcome you back at the post-lunch session on the first day of this exclusively virtual conference jointly organized by Indian Psychiatric Society, West Bengal State Branch, and Indian Association of Private Psychiatry, West Bengal State Branch. And to cheer up and excite us, we have a very wonderful debate that is being lined up. And the moderator for this session is none other than Dr. Abir Mukherjee, who really needs no introduction, but still I would like to say our very senior dada and a consultant psychiatrist of at medical hospitals in Kolkata. And we have our speakers, Dr. Subhrata Noshkar, who is a consultant psychiatrist at the Institute of Neurosciences, Kolkata, Dr. Tathagat Chatterjee, who is a senior resident at KPC Medical College, Kolkata, Dr. Subhrata Das, who is a RMO at Purulia Medical College, West Bengal, and Dr. Angshuman Das, who is a very senior consultant psychiatrist practicing in Kolkata. And the exciting topic for the debate is neuropsychiatry is not a product of Cartesian dualism. And now I hand this proceedings over to Dr. Abid Mukherjee. Over to you, Abida, for the session, which starts at 3:30 to finish at 4:15. Thank you.
Thank you, Rajashri. Thank you very much for the kind words, and good afternoon to everyone. Good afternoon to everyone listening and to the panelists as well, or the speakers. I'll begin by saying that what's in a name, said Juliet in Romeo and Juliet. But it did turn out that there's lots in a name. If you go by Shakespeare and if you go by our day-to-day activities. The words of William Shakespeare still resonate in our ears when we start today's debate. A rose in any other name might smell as sweet, but would neuropsychiatry by any other name mean the same? Or does it require any name at all? Would biological psychiatry or organic psychiatry be a better way to call it? Or are these too divisive or misleading? do we really need to differentiate schizophrenia from brain injury as different specialities? There are 4 young dynamic speakers who would fight it out this afternoon, trying to convince us either way. So we have for the motion, Dr. Subroto Noshkar and Dr. Tathagato Chatterjee, and we have against the motion, Dr. Ongshuman Das and Dr. Subroto Das. And the topic, as Rajashri has said, is neuropsychiatry is not a product of Cartesian dualism. I want to repeat, neuropsychiatry is not a product of Cartesian dualism. There are a few ground rules which I want to mention before we start the debate. We will start immediately with a pre-poll debate, with the audience about, picking their brains about what they think should be right. And then again, we'll have a post-poll debate at the end that would be strictly on the basis of what has been spoken over here and not on the basis of any preconceived ideas that they possess. And there will be 6 minutes each for the speakers, for the motion and against the motion. And then there will be a 4-minute rebuttal from one speaker from the for side and one speaker from the opposition side. So am I clear? Is the rules clear? So there will be a bell which would sound at the end of 5 minutes of each talk and another bell at 6 minutes. So basically I would request you to be within the 6 minutes, not only due to the brevity of time, but also due to, if you exceed 6 minutes, then it will go against you. So that said, with the rebuttal also, there will be a bell after 3 minutes, and then there will be another bell at the end of 4 minutes. So if everyone is ready and if all the rules are clear to everyone, then we'll start with the polling. The polling will happen in 2 places and it will be collated. The results will be collated.
Not the right time to talk.
Hello, am I audible?
Yes, sir.
Okay. So yes, so the polling, there will be a polling pop-up which will come in the Zoom platform, which we are using, and there is a polling button in the other portal which the audience is using. So simultaneously, the polling will take place in these 2 portals, and then the results will be collated for us to have a look at how many has voted for and how many has voted against. So I would request the organizers to please start the polling process. Okay, so I hope everyone has polled, so we can stop and we can share the results.
I have 63% agree and 38% disagree.
Okay, I'll write it down. 63% agree and 38%. Okay, 38.
Yeah. Average count.
Disagree. Right. Okay. Okay, done. So now it's all up to you, the against speakers, to convince the House that no, it's you should think differently. Okay. So who among the 4 speakers would begin the okay, Tathagato. So I would request Tathagato to start his deliberation. Thank you.
Thank you, sir. Is my presentation?
Yeah.
Can you guys see my presentation?
Yeah, you can do a slideshow, please, if you can.
Yes, sorry, sir. I'll just get right. So good afternoon to everyone. So as we already spoke about, that the topic for the day is neuropsychiatry is not a product of Cartesian dualism. I will be speaking for the motion along with Dr. Noshkar. So without further ado, let's start. Yeah. So Cartesian dualism, as we all know, we have spoken about it a million times. It basically starts with the concept of consciousness. René Descartes spoke about it way back in the 17th century. And he basically said that the mind and body are two different separate entities, and that they act on their own. They causally interact at times, and they're entirely two different entities. And one does not influence the other at all given points of time. One of the very famous sayings of his is that I think, therefore I am. Opposing the dualism, there is what we call as monism. There are two types of monism. One is the phenomenalism and one is the materialism. So phenomenalism is also known as subjective idealism. And what it states is that only mental objects, that is,
sponsor staff.
Can you mute yourselves, please, the audience? Thank you. Yeah, carry on.
Thank you. Thank you, sir. So what phenomenalism states is that only mental objects, that is only the mind exists, and it does not believe in the physicality of it all. An Irish philosopher at that point of time, very famous person named Bishop Berkeley at that point of time said that what we think of our body is merely just the perception of the mind and nothing else. Then we come to materialism. That is basically what we are going to talk about today. It basically is a belief that nothing other than the material world exists. And so the two supporters of materialism are basically the behaviorists as well as the biological psychiatrists. So the behaviorists basically say that psychology is what is concerned with only observable actions. What they mean by that is only the stimulus and response should be spoken about, and nothing that cannot be monitored or scientifically proven should be taken into account. Biologists also argued that the mind does not exist because there is no physical structure called the mind. They said that only the brain exists, and brain is the basis of consciousness for all human beings. Philosophy and philosophers who are in favor of monism. So we go back way back in time when the principles of Carvaka, which basically does not accept anything other than the material world. They say that there is a metaphysical side and there are only 4 elements that everything is made out of: the air, the fire, water, and earth. And so they deny that there is anything called a separate entity such as the mind. There's only a physical entity, the materialistic world, and that's about it. Amongst some of the famous philosophers, we all know about John Searle. So he came up with the concept of biological naturalism, which basically he states is the relationship between consciousness and brain. He defined 2 main domains. One was at a lower level, which he said that sensations that we get from anything such as pain, tickling, even itches, they're at a lower level neurobiological processes in the brain. And that there was a higher one, which is known as the mental phenomena, and they dictate the higher level functions of the brain. He also came up with the term called intentionality, which he described as the power of minds to be about to represent or to stand for things, properties, and states of affairs in the world. I'm not going into the details of the Chinese room argument because we are all quite familiar with it, but he spoke about that as well. The other one that I wish to talk about is Russellian monism. So this is named after the famous Bertrand Russell. So he described the entire process on the domain of metaphysics. And he said that there are basically 3 core parts to it. One is the structuralism about physics, which describes the entire world in terms of the spatio-temporal structure and dynamics. What that means is the world being described as in time and in space. He talked about something which he called as quiddities. So quiddities are basically properties that underlie the structure and dynamics which the physics describe. And he spoke about quidditism about consciousness, which states that quiddities are relevant to consciousness. The next theory is that of reflexive monism. Reflexive monism was developed by Max Fellmans. He basically stated that the world, when it evolved, that it was in an undifferentiated state. And when it started differentiating, that certain people were left with certain organisms rather were left with what we term as consciousness, and that comes entirely from the physical material part and has nothing to do with something like the mind, which cannot be proved about. A similar combination of monism and reflexivity was also found in Vedic writings like the Upanishads, as well as Buddhist views of the Chittamatra and Dzogchen. So we will, of course, be talking about the rise of biological psychiatry, because that is what it comes down to. It boils down to the fact about biological psychiatry versus other aspects of psychiatry. So when was the first wave of biological psychiatry? So it happened way back in the 1800s. So at a point of time when basically the psychiatric disorders for the first time was linked to neuropathology. A very senior psychologist, a very senior theorist at that point of time, Wilhelm Greisinger, famously declared at that point of time, mental disorders are disorders of the brain. Then came the second wave of biological psychiatry, which had basically two facets to it. The first one being the development of genetics. And the second one, of course, was the discovery of effective medication like lithium way back in 1949, chlorpromazine in 52, imipramine, haloperidol, and diazepam. So some of the pioneer drugs that were discovered at that point of time were found to be effective, and hence biological psychiatry came into being. At the same point of time, it's also interesting to add that Thomas Szasz and the anti-psychiatry movement also came into being in 1980s. The third wave of biological psychiatry, which we believe is still ongoing even at this point of time, came with the development of molecular neurosciences, number one, and the second was the birth of cognitive neuroscience as well as neuroimaging. When I'm talking about neuroimaging, I mainly point to functional MRI, because at that point of time, it was believed that with functional MRI, one could see the brain functioning at every given point of time, which we of course came to know that that is not the case. But even then, at least the functional part of the brain being functioning was being caught on an MRI machine for the first time. The other part, of course, was huge data sciences and huge computational power came into being. Data sciences, omic data sets like the epigenome, metabolome, proteome, or connectome, all of this came into being. When all of this were combined, we could basically come up with a better idea of the neuropathology for the psychiatric disorders that we talk about. One of the last things that I would like to talk about are the newer strides that has taken place in biological psychiatry, especially in the last 2 or 3 years. The thing that has come into being is one of the newest theories that has come into being at this point of time is what we call as a nested hierarchy. So nested hierarchy is nothing but, if we have all seen the Russian dolls in which one doll is kept inside another and another doll is kept inside another. So basically, whatever is in this hierarchy, whatever is at a lower level, they are completely imbibed at a higher level as well. So that is what a nested hierarchy is. So nested hierarchy talks about that the neurons are assembled and that they interact with each other in a spatially, that is space, as well as temporal, that is time, coherent fashion, maintaining a so-called metastable balance. And metastability itself refers to competition of complementary tendencies of cooperative integration and autonomous fragmentation. So what that means is that the lower level neurons, they function together as well to take decisions, as well as they go to the higher level as well to integrate and take higher decisions as well. So what this theory states is that that at this integrative time or at an autonomic time, if the stabilization does not take place, that is when it leads to psychiatric disorders. So as I was saying, and these can be managed, this can be seen and spoken about and measured entirely by EEGs, according to the researchers. So what it says is, in normal conditions, the interactions among neuronal assemblies are dynamically arranged according to moment changes in the internal states, which is emotional, motivational, and etc. And the number and type of available external sensory stimuli, while at the same time they keep a metastable balance. So when this balance is lost for a particular individual, that is when it leads to a kind of a psychiatric disorder. Whether it's depression, whether it's schizophrenia, whether it's anxiety disorder, this is what leads to it. And he termed this entire thing, Northoff was the person who came up with this new term, and he termed it as spatiotemporal psychopathology. As you can see that according to him, he has given a kind of a diagram that at spatial dimension as well as a temporal dimension for different diseases like depression, schizophrenia, substance abuse, that there is upregulation or downregulation of the neuronal activity. Accordingly, we get the neuropathology of the disease as well. That is what I would like to talk about. That is what I wanted to talk about. For the motion, I would now ask Abir sir to intervene and talk about it from the next person.
Thank you, Tathagata. Thank you very much. So you were basically you started with the historical perspectives, and then when you went on to the different kinds of monisms, the materialisms, the behavior theorists and the biological theorists, and then you veered towards the first, second, and third waves of biological psychiatry, and then you mentioned about this new concept of spatiotemporal psychopathology. Very interesting. Biological psychiatry is just one aspect of neuropsychiatry, the one kind of nested cohort of neuropsychiatry. But yes, it's an interesting observation. Now I would like to go to the first speaker against the motion. Who would that be?
Myself.
Okay. So Shubroto, Dr. Shubroto Das. Shubroto, once you're ready, I think Tathagata, please stop sharing your slide so that Shubroto can.
Sorry, I'm so sorry, sir.
I would request the organizers to keep a track of time, please, before Shubroto starts, because I have, and to give a bell after 5 minutes and then another bell at 6 minutes. Thank you.
Can I start now?
Yes.
Okay. Good afternoon, everybody. I will be countering the claims.
Do you have a slide sharing, or do you
no,
just?
Sir. I didn't make any slide.
Okay. Fine.
Good afternoon, everybody. I would like to counter the claims made by the previous speaker. The dualistic nature of neuropsychiatry has its roots in the history. 17th century philosopher, scientist, and mathematician René Descartes, he proposed the theory of body-mind dualism. Even today, his concepts of dualism is very much relevant in neuropsychiatry. Neuropsychiatry, as the name suggests, is an attempt to integrate two different yet related sciences. On one hand, there is basic neuroscience, which studies how the brain works and brain's anatomical structures and physiological processes. And on another hand, there is behavioral, affective, and cognitive neuroscience, which studies how this brain work is related to human experiences. To be precise, the aspects of brain as the part of environment and organism system. How the brain and mind relationships are measured. They're measured by the correlates between altered mind variables and altered brain variables. For example, amygdala gets activated during the perception of fear, or hippocampus shows increased activation during the task of memorization. Some researchers believe that a strong correlation between these brain variables and mind variables indicates that neural activity underlies mental functions. But this idea is metaphysical, and it cannot justify the assumption that brain causes behavior and not the vice versa. There are data which suggest that social and cultural activities can significantly influence not only brain functions, but also brain morphology. Is it possible to conceive a mental function for a brain if it is kept inside a jar in normal saline solution? No, it is not possible. To conceive a mental process, the brain has to be placed inside body, and further this brain body system must be embedded in environment, and this system has to actively interact with its environment. Also, mental processes cannot be conceived separately from other bodily processes like sensory processes or respiration and others. However, some researchers, they try to reduce the complexity of human mind to mere neurobiology. They believe that human mind is barely some electrical discharges and chemical changes. This attempt, again, has been criticized by many prominent neuroscientists. Uh, However, if neuropsychiatry wants to uh, explore human mind, they must go beyond their biological code and also explore disciplines like psychology, sociology, and perhaps other disciplines. However, uh, to be successful, such reduction must be fulfilling at least two criteria. One is conceptual reduction, which means to replace mental concepts with physiological concepts. And another is theoretical reduction, which means to formulate laws which would deduce mental processes from physiological processes. However, uh, there are no signs that these two criteria are fulfilled. Therefore, the methodology of neuropsychiatry is necessarily pluralistic or at least dualistic. I would like to conclude here with a notion that says a mind is without brain is nothing, but the brain is not everything for the mind. Thank you.
Thank you, Subroto, for being on time and introducing the concept that, okay, everything is all right, but in terms of how do you translate it and how it's kind of to establish certain conceptual, processes. It is important even now to think of it as separately. Maybe you were trying to highlight the other aspects of the treatment and the biopsychosocial model. It's not biological, so we were kind of alluding to the other models, perhaps. Okay, so let's go on to the to our next speaker for the motion. That is Subroto and our another Subroto, Dr. Subroto Noskar.
Thank you, sir. Thanks to the organizers for this opportunity. So I will be speaking for the motion. So we know that historical documents prove that since we have begun our quest for knowledge, the human body has always been an object of great mystery. Over the time, early anatomists through dissection of the body tried to identify the functions of various body parts. But the concept of mind and consciousness has always eluded the early scholars. Greek philosopher Plato, he first preached that human beings are made up of two independent constituents, the body, which is guided by mechanistic laws and can be measured by some scientific ways, and the mind, which is something incorporeal and it transcends all mechanistic laws. He believed in the concept of soul, which he believed to be identical with the mind and believed it to be indestructible and it can change bodies. Similar concepts existed in and also exist in current Hindu teachings also. The concept of Paramatma, according to Bhagavad Gita, is the very source of consciousness and is indestructible. Now, 16th century scholar René Descartes, he believed in this mind-body dualism, but he argued against the ancient concept of immortality of soul and its ability to migrate among bodies. He preached that soul and mind are not different, they are identical, and mind and body are different substances. He believed that the mind was non-physical and permeated into the entire body, and the mind and body, they interact among each other through the pineal gland. Now, in the 19th century, the father of psychoanalysis, Freud, He was a neurologist first. He pursued a structure-based approach, but later he concluded that neuroscience of his time is not sufficiently mature enough for the linking of neuronal mechanisms and psychodynamic concept. So a split between the neurology and psychiatry occurred when psychoanalysis took over in the Europe and USA during the early 20th century. Gradually, psychiatry became separated from the rest of the medical specialties. This isolation has seriously damaged psychiatry and has contributed in the increasing the stigma. Yet, recent advances in neuroscience, it makes it more difficult to draw a precise line between the neurological disorders, the so-called structural brain disorders, and the psychiatric disorders, the so-called functional brain disorders. Currently, neuroscientists with fMRI studies and PET scans have shown Freud's id related with neuronal activities in the brainstem. Ego-related neuronal activity centered on the anterior cingulate cortex. The localization of ego in this frontal midline is consistent with the notion that the ego is the true self, an aspect of personality that is displayed to the world. Finally, superego-related neuronal activity is usually localized to the lateral prefrontal and parietal cortex. These effects are consistent with the top-down aspects of the superego. The study of consciousness also had been long avoided by neuroscience because of this dualism, where it believed that consciousness is beyond the reach of an objective science, whereas current researchers have shown that consciousness emerged as a result of coordinated activity of brain networks spanning many scales over space and time. The thalamocortical system plays a critical role in the breakdown and reemergence of consciousness, as shown in studies using anesthesia. So from the case studies of Phineas Gage to the current era of fMRI and PET scans, we have gradually tried to understand the functions of different brain areas, the circuits involved. And as we see the screen of the various brain parts light up, showing increased metabolism in response to different stimuli that generates emotions as well as sensations, we understand that we have evolved past the dualism. Now, neuropsychiatry has generally been regarded as a hybrid discipline that lies in the borderline between discipline of psychiatry and neurology. The subject has not emerged because of the fact that body and mind are separate structures which interacts, but because as cognitive neuroscience progressed and we understood that a unification is necessary between the structural and functional brain disorders. The field of neurology and psychiatry has long been divided by this dualism, which has indeed resulted in a poor understanding of many psychiatric and neurological disorders. Neuropsychiatry is the product of the need to explain the gray areas of neurology and psychiatry which still eludes us. A unification of the discipline helps in proper understanding, or at least is a trial for proper understanding of certain disorders. For example, the chronic fatigue syndrome, like fibromyalgia, like Tourette disorder, where we understand how the structural and the so-called functional disorders meet. Not only that, we know that patients with pure neurological illnesses like Parkinson's disease, multiple sclerosis, Huntington's disease also show significant psychiatric symptoms. There we understand the need of an unified term that helps us to explain these symptoms, and then based on this understanding, use the different molecules that are available to us to manipulate certain areas of the brain to conclude the symptoms. Neuropsychiatry is not a product of Cartesian dualism. It is a product of the need to reduce the stigma about behavioral disorders in the society. We often find in our practice that patients mostly accept a biological model of the behavioral problems rather than accepting it simply as a mental disorder. Last, to conclude, I must also say, and this is a point that Subroto said I'd like to counter here. I must also say that in the quest of searching for neurological explanation of psychiatric symptoms, we must also remember that psychiatry also has brought on the table the importance of psychosocial factors in the pathogenesis of psychiatric disorders. Hence, a unified approach is necessary to address both the neurological and psychosocial issues for the holistic improvement of the person. And out of this necessity, neuropsychiatry has taken its birth. Thank you.
Thank you, Subroto. Thank you so much. So basically what you meant but that the divisive, it was not due to René Descartes, but it was more due to Freud's theory of psychodynamic, which kind of led to the separation of the two disciplines. And through the studies of consciousness, and even now you can explain the psychodynamic process through biological means. And finally, you made this point that, you know, like unification or sort of neuropsychiatry as a discipline will also cater to the psychosocial aspects of treatment. So it is not separate from it. So that's what I understood. Thank you very much. And so I move on to our last but not the least of speakers against the motion, Dr. Angshuman Das. Angshuman, are you ready?
I'm ready. Can I be heard?
Yes, you can be. Yeah.
Great. Okay. So good afternoon, everyone. Good afternoon, and thank you, Avirda, Rajashri, and to the organizers for inviting me for today's debate. So you have already been introduced to the topic. I'm not going into that. I'm just telling you something. Please pay attention. So you are listening to me, hearing me, observing me, rejections are there, and it's all coming in your laptops, desktops, your smartphones, all these devices. And these devices all have very sophisticated circuits. They have processors, they have monitors, drivers, etc. But are they enough to explain the experience you are having? Of course not. You need a basic software and you need a Wi-Fi signal and a 4G signal to go with it. That's exactly what happens inside us. We have a sophisticated brain system, and as my junior colleagues mentioned, with all its glory, the neurons, the chemicals, the nerve signals and everything, which is very important. But that's the hardware bit. You need the software and a Wi-Fi signal. And that's the importance of dualism, the other part. One part is your hardware, the brain and its parts, and the second part, the dual part, is the mind. So that's dualism, the essence of dualism. Now, word neuropsychiatry itself has dualism embedded in it. It is consisting of three parts, all Greek words, from neuron, that's related to nerve, psyche related to mind, and iatria means healing. So you are dealing with nerves, that is related to brain, nervous system, the body. Then you have psyche, that means the mind, and you are healing it. So we are basically mind healers as psychiatrists. We are really, whether Subrata Noshkar likes it or not, we are not neurologists. We are not behavioral neurologists. And tomorrow, Subrata Noshkar, in your nameplate, please make sure that you don't mention you are a psychiatrist. Mention you are a neurologist. You know, because to be a psychiatrist is different from being a neurologist. You are healing a person's mind, which is different from changing some brain structures, my friend. So Cartesian dualism, this guy, René Descartes, what he said, what he did, you all know, and there have been some proponents, some criticisms. I'm not going into the nitty-gritties. What I'm going to say to everyone is dualism, which I'm going to tell you, the modern neo-dualism is in sync with biological psychiatry, is in complete accordance with neuroscience. And that's the best bit of it. Okay. So let's come to the practical bits to clarify. So when we see a patient, when they come to us, we diagnose them. How do we diagnose them? We ask them questions about their mood, their thoughts, their behavior, feelings, all that. And these are the subjective thoughts they come up with, the subjective ideas. When ICD-11 and DSM-5 classify neuropsychiatric disorders, they don't do it on basis of fMRI scans or PET scans. They do it on basis of subjective symptomology. Please get this clear. So the subjective idea is the core of our specialty, is the mainstay of our specialty. What bioscience does, it does very well. It shows the mechanical way, the dopamines, the serotonins, the neurotransmitters, the nerve signals, the brain mapping, which is brilliant, absolutely necessary. That shows the mechanical process. But the core subjective quality of experience, that neuropsychiatry is different from neurology, from any other specific organic disorder, is its subjective quality. And that is explained by this intangible space called the mind. So to just clarify, any neuropsychiatric condition has basically dual component. One is the physiological component called the brain, and one is the phenomenological component, that's the mind. It's just like in research. We have all done research, and we have qualitative research and quantitative research. So quantitative research talks about data, the hard facts, RCTs, meta-analysis, and rest of it. But qualitative research, especially in psychiatry, is extremely important to get the whole feel of it, the richness of it, the embedded, grounded theory of it. So it's exactly like that. It's compatible, it's coexistent, and it goes hand in hand. Now, I touch upon perhaps the most important of our mental faculties, and that is consciousness. Subroto Noshkar highlighted about it, but I want to explain a little bit more, because he mentioned about the easy question, which is called the A consciousness or access consciousness. The thalamocortical system, it tells you about how aware, how conscious a person is. By the Glasgow Coma scale, you check the eye opening, the movements, the vocalization. That's easy bit, superficial bit. There is a hard question of consciousness, my friends. The hard question of consciousness is called P consciousness, or phenomenal consciousness. That goes beyond your touching and seeing and being aware. And that is the higher abstract function of intentionality, free will, desire, introspection, and to higher moral conscience. I'm not going into philosophy or spirituality over here, but you can't ignore this higher abstract thoughts that is beyond neuroscience, at least at this moment. And it is only explained by the dual element. And that dual element is the presence of an intangible space of our mental system called the mind. So dualism is there to stay, there to be conceptualized, there to be understood, and to be seen. So to conclude, I say that neuropsychiatry has to be explained properly by two dual components. One, of course, what we are all aware, all studying, all practicing, it's the biological component, physiological component, the seat of A consciousness, that is the brain and the nervous system, the neuro part. But there is an important second part, the dual part, and that is the phenomenological, qualitative, subjective experience, the seat of P consciousness. And that is the seat of a mental space, the intangible, imperceptible, but undeniable space called the mind. So I end by stating a brilliant remark by a very legendary neurosurgeon called Wilfred Penfield. He was the pioneer of neurosurgery for epilepsies. He was a staunch materialist and monoist in his early days, and he changed into a dualist. And what he says is very important. Please listen. That there is a difference between having an open mind and having a hole in your head from which the brain leaks out. So, my friends, please have the windows of your mind open, and please try to avoid head injuries. Okay, thank you very much.
Thank you, Angshuman. Thank you. As Rajashri said, that the mercury is rising. Eta Banglate bolle aro bhalo hoy, para chorche. So basically what Angshuman alluded to was you began with this whole concept of hardware and software, which we all often explain to our patients, and then very interestingly he went on to this whole debate about the physiological and structural versus the phenomenological, and I think that was the essence of his talk about mentioning this the phenomenological concept, the abstract concepts of mind, which cannot only be expressed through biology. Biology can explain bits of it, but not the whole of it. That makes me wonder that is there a phenomenological aspect of neurological diagnosis as well? Anyway, that's the question. So let's move on to the first rebuttal. I think with regards to time, as usual, we are just running a bit behind. So we'll keep 4 minutes, but if you can manage within 3 minutes, both the speakers who would do the rebuttal, it would be great. So I'll begin with who would speak for the motion as a rebuttal first? Tathagata. Okay. So
right.
You can please start.
Right. So as octogenarians I meet everywhere, including octogenarians in my family, they keep on saying that when I talk to them about psychiatry, they keep on saying, "Amader shomoy to erokom kichu chilo na." We didn't have this kind of disorders back in our time. Of course, I have to tell them and explain to them that it was there. Possibly the incidence was at the same level as it is now. It's just that the awareness was not there. And when I talk to them that people, there are suicidal people we have to deal with, people who have tried committing suicide 2 or 3 times. They say things like, "Duto tinta thappor marlei jibone ei obosthaye ascho na." So what I'm trying to say is the level of understanding for such people is a bit on the lower side. They have very poor understanding of psychiatry. And because these are the people who were born in the 20s and 30s, 1920s and 30s. So if we think about psychiatry from that point of view, we can of course say that the dualism exists. But now that things are coming up, we are getting newer technology. As all the panelists pointed out, things like fMRI, PET, all these scans, then the drugs that have come up, we cannot talk about psychiatry in the same manner that we spoke about it way back in 40s and 50s. And we had very limited options of treating patients. We had very limited options of understanding what the pathology behind their disorders were. So things have changed. Things have changed remarkably. Things have changed a lot in the last 10, 20 years, mainly, as I pointed out, with the advent of newer drugs, with the advent of technology. Now we are being able to pinpoint as to what the problems are, where the problem lies. Similarly, as Dr. Dash, Sir Angshuman sir pointed out about the hardware and software. Very true. Whenever, even now, when we are talking to our patients, when we're trying to differentiate us from the neurologists, we say that they are the hardware people, we're the software people. I do believe that statement to be completely true. But at the same time, when I say that that statement is true, what I mean about software is that there is nothing romantic about the mind and the consciousness. It is a part of our brain, which I'm sure with more advent of technology, we will be able to pinpoint properly to a greater detail, maybe in the next 10 or 20 years. I remember going to this conference in Mumbai 4-5 years back, and the president of the APA had come there. And he said that possibly by the next DSM, when we come up with the DSM-6, we will possibly be classifying all the psychiatric disorders according to the neuropathological part of it. As Dr. Dash was saying, that we generally diagnose our patients according to the questionnaire, according to the questions which have been listed by either the ICD or by DSM, the criteria, we match the criteria, and then we come to a diagnosis. Possibly that's not going to be there in the next 10 years. Possibly that's going to change. Of course, all of this has been there because it's still, psychiatry is still at an embryonic stage, I believe. And with more and more evolution of technology, I believe that the entire aspect of psychiatry, the possibly, if I'm so bold to point out, the romanticism regarding psychiatry would possibly be driven out. And we would be left like a core part of medical science rather than just romanticizing on topics that we are unclear about. That is what I would like to say, and thank you for the time.
Abir, please unmute yourself.
Sir, you are not audible.
Sorry. Okay, without much ado, I would move on to the against rebuttal. That would be by whom? Okay, Angshuman. Okay, Angshuman, please start.
Okay, so my junior colleague Tathagato, I think, got a bit disconnected. He started with the past and went to the future, and we are at present. So here is really not in here and now mode. So he talked about octogenarians, talking about what suicide is and what giving 2 thappors mean. And he is talking that in 10 years' time, he'll identify a psychiatric disorder by neuropathology in DSM-19. And that's absolutely That's romanticism, Tathagata. This, what we are doing is not romanticism. What you are suggesting is romanticism. We don't know what's going to happen tomorrow and neuropathology diagnosis by that. That's absolutely out of order. We are discussing whether neuropsychiatry is a product of dualism or not. So please stick to the topic. It has nothing to do with the topic, what you said in rebuttal, I'm afraid. So the couple of things that you mentioned is you said that you can't pinpoint something so it doesn't exist. You also mentioned in your lecture that reductionism and materialism, unless it's found, it's seen, it's not there. So that's not a great argument. You know, we all hear about this, the gravitational force. You can't really see it. You can just experience it. So you don't have to see something, or just don't have to feel it. It doesn't have to be a material object to be there. Okay. And then I think both Subroto and Tathagata wanted to bring stigma into the picture, and they think that biological psychiatry would just eliminate stigmatization. That is a completely false idea. That stigmatization I'm not going into details, but it has nothing to do with dualism. Dualism has nothing to do with stigmatization. Stigmatization has some other multiple social, economic, cultural, and other factors, and of course, biofactors. So these are completely different issues. And then there was a mention or try to alienate dualism from science. But I mentioned at the outset that modern dualism embraces science. I am a scientist. I have done many biological researches, and I am proud of it. That's not a problem. The problem is that the guys who are not willing to embrace the fact that there are two simultaneous processes. That is what I am saying. That's the essence. No one is discarding biological psychiatry. It's a huge part of it. It's a brain of our system. You can't take brain out of the body. But you need the other part as well, which is the phenomenological experience that I'm trying to discuss. And that's what dualism says. And in the consciousness bit, what Subroto said, I countered, I just want to repeat that please be aware that the consciousness we all are talking about is about the access consciousness, what the Glasgow Coma scale can find out. But we also have more than that, the phenomenal consciousness, the P consciousness, the hard question. And of course, what Tathagata says, that in years to come, there could be something that comes out, and we wait for the day. But at this minute, on today's time, as we are debating, please stick to the motion. Please stick to the facts available to you. And with the facts available to you, you have to accept there is another significant part of our mental space called the mind. So body and mind are two dual processes that helps our mental system, our mental process conceptualize our neuropsychiatric condition, and to help ourselves understand the condition and our patients better and to help them better. That's the best way ahead. Thank you very much.
Thank you so much, Angshuman. So we have come to the end. Yeah, basically the four speakers, they have kind of emphasized that if we give too much of importance to this dualism, then we might again walk along the path of stigma. And it has been countered by the against speakers by saying that there's a difference between what happened in the past and there's a difference between what is happening in the present. We are being over-inclusive, which includes biology and which includes beyond biology, the abstractions. There's also these systemic disorders which have neuropsychiatric manifestations. So, you know, neuropsychiatry is not only neurology and psychiatry. But anyway, that's for a different day and a different topic. So now, as a moderator, my solemn role would be again to ask for a poll to be conducted. And I would again request that, you know, in the initial stages before the debate started, it was whoppingly in favor of the against motion, whoppingly in favor of 6 yes. So has the things changed? So now let us go for a repeat poll and let's see what happens. So are we ready, the organizers? for the repeat poll? So if everyone has voted, we'll end the poll.
Shall I close the poll?
Yes, you please close the poll and declare the results, please.
Yes. With agree on the poll is 67% and disagree is 33%.
So agree means for the poll is 60. Well, how much?
67% agree with the motion and disagree is 33%.
Okay, so it has more or less remained the same with a 4% veering towards the agreement towards the polls. Anyway, so thank you very much, very much to Angshuman, Tathagata, Subrata Noshkar and Subrata Das for a very exciting debate which took place.
Thank you.
I thoroughly enjoyed it, and I'm sure the audience would have done the same. So we will end the session over here because we have been running late, and there is an external speaker who has to be accommodated at some stage. So I'd hand over to Rajoshri. Thank you so much.
Thank you very much. Thank you.
Thank you.
Thank you, Dr. Abir. Right now we have our session for our next session is brain changes in COVID-19 and update by Dr. Payal Talukdar as a speaker, and the chairpersons are Dr. Ranjan Bhattacharya, Dr. Susmita Chakraborty, and this session is sponsored by Linex. This is sponsored by Linex.
Hello.
Good
Am
evening.
I audible?
Yes, Shurmishari, please carry on.
Okay, brain changes in COVID-19 and update. I mean, I have to say, I think, 4 or 5 of you already know about a patient I admitted under me in a private hospital. And she was admitted with, very young patient, 34-year-old. And she was admitted with psychosis. And ultimately, there was a strange oral movement and there was encephalopathy and she had COVID-19 and I actually lost the patient. And with COVID-19, we are seeing as a sequela a lot of hallucination, aggression. I have 2 patients who are my own patients who have a sequela, dementia patient who had COVID-19 and suffering from severe aggression after that. And as a result, it is very difficult. So we really don't know how COVID-19 is going to affect. We know that it is affecting a lot of organs, but however, I think brain-wise, a lot of research is going on and a lot to come. So Dr. Payal Talukdar is going to enlighten us. Off to you, Ranjan.
Yeah, thank you very much. So it's a very interesting topic. since the first whistleblower Li Wenliang first described about the COVID cases in China, we have come across through a long way. So now it's very important to find out the brain changes. And during this session, Dr. Payal Talukdar, Associate Professor, presently attached with the inner Ashago Datta Medical College. She will deliver a lecture. As you know, there are functional changes and there are different diffusion tension imaging. The fractional anisotropy changes have been found and described in various literature. The differential volumes changes in the medial temporal lobes, the different superior parietal cortex, and the amygdala hippocampal region will be described by Dr. Payal Talukdar. Without much ado, we are running short of time. Over to you, Dr. Payal Talukdar.
Respected Chairperson, am I audible?
Yes.
Doctor, can you share your presentation? Dr. Talukdar? Yeah. Please. Yes, ma'am. Yes.
The screen is okay?
Absolutely okay. Please go on.
Respected Chairperson, my teachers, senior and junior colleagues, I am grateful to the organizers for giving me this opportunity. My topic is brain changes in COVID-19 and update. COVID-19 pandemic is the global health crisis of our time and the greatest challenge we have faced since World War II. Since its emergence in Asia last year, December, the virus has spread to every continent except Antarctica. India alone has crossed a total infection of more than 53 lakhs, total death of more than 85,000, and daily cases of 90,000 or more. It is a respiratory virus, but it has the potential to attack and infect the nerve cell. It is a neurotropic virus. Apart from mild olfactory and gustatory dysfunction, various neurological changes like encephalopathy, stroke, hemorrhage, embolism are also represented. Next slide.
Can you make it bigger? Full screen?
Yeah.
Yeah.
Now it is visible?
Yes, yes.
Structure of SARS-CoV-2. In the central part, we are seeing the genetic
full screen,
material.
please.
And press F5 or full screen it.
Full screen. At the bottom, you will be able to see a button to click full screen.
In the central, we have the generic material. It is an RNA virus, and there is a spike protein that is red color, spike glycoprotein. This spike is used to enter into the host cell. Next slide. The blue color is the ACE2 receptor, that is angiotensin converting enzyme 2 receptor, and the red color is the spike. The SARS-CoV-2 spike protein mediates the virus entry into the host cell. It binds to the ACE2 receptor. The ACE protein is cleaved by furin, allowing the fusion of the viral and the host membrane, resulting its entry into the cell. Now this is the SARS-CoV-2 replication, how it replicates in a host cell. First stage is the attachment. Binding to the target cell, that is attachment. Then there is fusion and endocytosis, followed by penetration of the virus into the host cell. And then uncoating. And the viral genetic material is released into the host cell, and there is replication, that is hijacking of the host's own enzymes and replicating of the multiple copies of the viral RNA. And then with the other protein of the cell, it produces many baby viruses. And
they will assemble, there is budding, and the last stage is the release of the virus from the host cell, and then they infect another virus. Evidence for CNS involvement. This is a post-mortem finding. Frontal lobe section shows the presence of 80 to 110 nanometer viral particles. Spherical viral-like particles were observed individually and in small vesicles of endothelial cells. Blebing of the viral particles in or out of the endothelial wall indicative of viral entry or transit across the brain microvascular endothelial cells into the neural system. Neural cell bodies exhibited distended cytoplasmic vacuoles containing enveloped viral particles with distinct stalk-like projections. Then postulated direct pathway. Number one, hematogenous route. Virus gain access by infecting the endothelial cells of the blood-brain barrier, epithelial cells of the blood CSF barrier in the choroid plexus. Observation of the virus-like particles in brain capillary endothelium and actively budding across the endothelial cells strongly suggest the hematogenous route. Neuronal transport. The virus can use retrograde axonal transport, that is travel from axon terminal across the axon to reach the neural cell bodies in the CNS. It occurs through olfactory, respiratory, and gut-brain axis or enteric nervous system. Olfactory network. Retrograde neuronal transport via the olfactory pathway, that is across the cribriform plate of the ethmoid bone to olfactory bulb situated in the forebrain, is the likely route given to the proximity to the brain, but also due to ACE2 receptors in the olfactory cilial cells. Then respiratory network. The virus may also enter via retrograde neuronal transport via axon from the peripheral nerve of the respiratory network to medulla oblongata, where the respiratory system is generated and regulated. Now coming to the enteric neuroinflammation. The enteric glial cells act as an antigen presenting cells, that is APC, to immune cells housed in the gut associated lymphoid tissue, that is GALT. Thus, infection of the gut may trigger a peripheral immune response such as cytokine storm and also facilitate enteric neuroinflammation, and that occurs through the vagus nerve. This is the immune response, normal immune response to any viral attack. If phagocyte eats the virus, the part of the virus, that is antigen, goes to the surface of the phagocyte. The phagocyte presents the antigen to the helper T cell. The helper T cell is then activated, and the helper T cell presents the antigen to the antigen presenting site, that is APC, antigen presenting cell, APC. Then activation of the inflammatory response and a complicated cascade of events occur with releasing of pro-inflammatory cytokines, that is TNF, interleukin 6, interleukin 1, and many others. Then T helper cell presents the antigen to the B cell also. B cell can be divided into plasma cell or memory cell. The plasma cell produces antibodies which attach to the current type of invader, and if the same invader invades again, the memory system of the immune system activity works further and fights with the virus. But in some individuals, there is some genetic predisposition to macrophage hyperresponsiveness. There is hyperinflammatory reaction that may be due to genetic predisposition, and there are some background inflammatory activity. The risk factor is diabetes, obesity, where already inflammatory cells are present in the body, such as from adipose tissue, adipokines are secreted, and these adipokines are pro-inflammatory cells. And the trigger is the COVID virus. And this results in increased macrophage activation and expansion, followed by increased T cell activation, expansion, and interferon gamma production. And this cycle goes on producing cytokine storm with the release of interleukin 6, interleukin 18, TNF alpha, and granulocyte macrophage colony stimulating factor, and many others. Now, postulated indirect mechanism of brain involvement post-infectious autoimmunity. First of all, molecular mimicry. The potential for T cell receptors specific for certain microbial epitopes to potentially cross-react with self-antigen that have similar molecular pattern or mimics. Bystander activation of immune cells. Overactive response to virus results in the release of self-antigen that trigger off the immune response by processing antigen by inflammatory monocyte-derived antigen-presenting cells to autoreactive T cells. And epitope spreading. In the context of antiviral immunity, activation of a broad set of viral-specific T cells is potentially a helpful event. However, destruction of the host tissue and autoimmunity may result should the spread happen to include epitopes expressed by the host tissue. Then, and AC2 receptor involvement. This is the most important part. As for example, virus enters through the olfactory pathway. The SARS-CoV virus binds to the AC2 receptor for entry, and AC2 receptors are present in many areas of the body like vascular endothelium, respiratory epithelium, alveolar monocytes, macrophages, oral and nasal mucosa, nasopharynx, stomach, small intestine, colon, skin, spleen, liver, kidney, bone marrow, and others. So they bind to the S2 receptors for entry. And second step, internalization of the S2 and destruction of the S2 producing tissues. And there is dysregulation of the renin-angiotensin system. In a normal cell, angiotensinogen is converted to angiotensin 1 by renin, and angiotensin 1 is converted to angiotensin 2 by S1 receptor. And S2 receptor converts angiotensin 1 to angiotensin 1 to 9 and angiotensin 2 to angiotensin 1 to 7. And this angiotensin 2 is harmful to the body. It produces acute lung injury, adverse myocardial remodeling, vasoconstriction, and increased vascular permeability. And when angiotensin 1 to 9 and angiotensin 1 to 7 is produced, that is beneficial to the body, they produce vasodilatation, anti-inflammatory, anti-fibrosis, and vascular protection. So the virus dysregulates the renin-angiotensin system, producing angiotensin 2, which is harmful to the body. So how the invasion occurs? Direct infection injury, that is hematogenous pathway, I have already told. Then comes the neural pathway, demyelination and neuroinflammation. The neuroinflammation, how it is produced. The cytokines released through the peripheral inflammation may increase the permeability of the blood-brain barrier, providing the pathway for the virus to enter the brain. And once in the central nervous system, it can infect the astrocytes and microglia, activating the cascade of neuroinflammation and neurodegeneration through the release of TNF, cytokine, and other inflammatory molecules. And the demyelination occurs usually post-inflammatory demyelination. Then comes the hypoxic injury. Hypoxic injury occurs via direct infection of the lung tissue, but may also occur due to neuroinvasive potential of the virus affecting the medullary cardiorespiratory center. And hypoxia causes increase in anaerobic metabolism in the mitochondria of the brain cell, resulting in increased lactic acid production that leads to cerebral edema, decreased blood flow, increased intracranial tension, which presents with variety of neuropsychiatric symptoms. S2 receptor involvement I have already described. Then comes the immune injury, SIRS, that is systemic inflammatory response syndrome. It is an exaggerated defense response of the body to a noxious stressor to localize and then eliminate the endogenous or exogenous source of insult. Even though the purpose is defensive, the dysregulated cytokine storm has the potential to cause massive inflammatory cascade leading to reversible or irreversible end organ dysfunction or even death. SARS, when combined with a definite confirmed infection, we called it sepsis. And sepsis with multi-organ damage, we call it severe sepsis. And when severe sepsis is combined with arterial hypotension, we called it septic shock. And next comes the coagulation factors. There is increased coagulation, that is certain cytokines can activate coagulation system like interleukin 6 and suppress the fibrinolytic system. And there is production of anti-cardiolipin and anti-beta 2 GP1 antibodies. And the endothelial cell injury also activates the coagulation system. And all this produces infectious toxic encephalopathy, viral encephalitis, and acute cerebrovascular disease. So this is the gross pathophysiology of COVID-2 brain involvement. Number 1, direct infection. Number 2, neuronal pathway, that is through olfactory bulb and enteric nervous system. Then comes the neuroinflammation and autoimmunity. Then S2 downregulation, blood circulation, hypoxic injury secondary to lung involvement, gut microbe translocation. Here, the inflammation causes gut leak, and this causes the bacteria to translocate into the circulation. And increased intestinal permeability also leads to influx of lipopolysaccharide, which causes release of interleukin and TNF alpha. There is cytokine dysregulation and cytokine storm with post-infectious autoimmunity. All these combine to make the brain involvement possible. So neuropsychiatric manifestation, we can divide it into 4 types. Number 1, encephalopathies, meningoencephalitis, neuromuscular disorders, psychiatric disorders like depression, anxiety, psychosis, sleep disorders, and query neurodegenerative disorders. So according to Brack's hypothesis, in Parkinsonism, the neurotropic virus can result in prion type of spread of the particular that synuclein protein, exacerbating neurodegenerative disorders. Second group is the anosmia and ageusia. Now they are so common that they are included in the screening tool of the COVID-19. Number 3 is the acute cerebrovascular disease. And number 4, infectious toxic encephalopathies due to hypoxia, metabolic disturbances, and systemic inflammation. Spectrum of neurological complications in COVID-19. Direct effect from viral invasion. Olfactory bulb anosmia, meningeal meningitis, cerebral encephalitis and encephalopathy, brain endothelium cerebral vasculitis, spinal cord myelitis, peripheral nerve, muscle myositis or myalgia. Indirect effects, hypoxia causes encephalopathy, cytokine storm causes encephalopathy, acute necrotizing encephalopathy, increased coagulation that causes stroke, metabolic abnormalities, then post-infectious autoimmune disorders causing Guillain-Barré syndrome, Miller-Fisher syndrome, and acute disseminated encephalomyelitis, that is ADEM. Now coming to the imaging. So indication of imaging in COVID-19, altered mental status or delirium. Number 2, stroke, mechanical fall or trauma, syncope, headache, dizziness, seizure, and ataxia. MRI sequences most commonly used: 3D T1 weighted spin echo MRI sequence with or without contrast enhancement, diffusion weighted imaging, gradient echo T2, susceptibility weighted imaging, 2D 3D FLAIR with contrast. Most frequent MRI brain changes. Actually, many changes occur in the brain, but these 3 are the most important features. involvement of the medial temporal lobe. Number 2, non-confluent multifocal white matter hyperintense lesion on flare with variable enhancement and hemorrhagic lesions. Number 3, extensive and isolated white matter microhemorrhages. These are some brain imaging in patients with neurological disease associated with COVID-19. I am not going to the minute details of the MRI changes, just going superficially. Number A picture shows hyperintensity along the wall of the inferior horn of the right lateral ventricle on diffusion weighted imaging indicating ventriculitis. Then number B.
Hello. I think the streaming has stopped. Am I audible?
Yes.
Yes, you are audible.
So let's please wait.
Ranjan sir, please go on.
Let me call the speaker. Please wait. Managed to contact with Dr. Payal Talukdar. She is joining us shortly. Please wait.
So am I
Ma'am,
audible?
continue. Yes, ma'am, continue quickly.
I am starting from the B picture. Hyperintense signal changes in the right mesial temporal lobe and hippocampus with slight hippocampal atrophy on FLAIR MRI consistent with encephalitis in a patient with COVID-19. Number C, hyperintensity within the bilateral medial temporal lobes and thalami on T2 FLAIR MRI. Then number D, evidence of hemorrhage as indicated by hypointense signal on the susceptibility weighted images consistent with acute necrotizing encephalopathy in a patient with confirmed COVID-19. Number E picture is a CT scan picture showing ischemic lesions involving the left occipital lobe. And number F is also a CT scan picture showing right frontal precentral gyrus of the brain in a man aged 64 years who deteriorated neurologically after admission to hospital with COVID-19 and was diagnosed with acute stroke. So it is the inflammation and the autoimmunity and the intracranial cytokine storm that causes the damage to the brain. And why some people are recovering with comorbidities while the young people without any comorbidities are succumbing, that is not clear till date. Whether it is genetics or something else we do not know yet. We have to wait for further research. Thank you.
Thank you, ma'am. Thanks a lot. I will ask Dr. Ranjan sir to comments, or Dr. Shushmita Chakraborty to conclude this session.
Very nice presentation.
Payal ma'am, can you close your screen? Payal ma'am, yeah.
A question will be asked by Dr. Kaustav Chakraborty from Live Forum here. Dr. Kaustav Chakraborty.
Finally, am I audible? Finally, Kaustav here.
Yes.
Finally, I have a question.
Carry on, go on, go on.
What are the data regarding long-term neuropsychiatry sequel of COVID? Is there any data regarding this?
Long-term research is yet to come out because the disease is already just 8 months old.
Yes.
And in one publication, I can mention that in Brain Behavior and Immunity, the spectrum of neuropsychiatric manifestation in COVID-19, that is TriNetX database in Global Health Collaborative Clinical Research Platform, January to June 2020, total 40,469 patients were diagnosed patients were observed, and among them 9,086 patients, that is 22.5% patient has neuropsychiatric manifestation. Among this, headache 3.7%, sleep disorders 3.4%, encephalopathy 2.3%, stroke and TIA 1%, seizures 0.6%, anxiety 4.6%, mood disorders 3.8%, and suicidal ideations of 0.2% were detected. Actually, neuropsychiatric manifestation will be dealt tomorrow by Dr. Kaveri Bhattacharya. That's why I am not going into the minute details of it. And MRI pictures, actually, the fMRI and detailed MRI picture is beyond our psychiatric purview. That's why I am not going into detail of that, only giving some basic pictures that are visible in MRI.
Thank you. Thank you very much. Over to Shormishta Di to conclude the session. Dr. Shormishta Chakraborty, over to you.
Thank you, Dr. Payal Talukdar. It was an excellent, very, very clear and concise description of the changes of COVID-19 in brain and its, very severe changes which happen, and maybe sometimes with encephalopathies, it can be quite irreversible as well. Thank you so much for the excellent presentation. I hand over to Rajashree. Thank you.
Thank you.
Thank you, ma'am. Thank you, speaker, Dr. Payal ma'am, and the moderator, Dr. Ranjan Bhattacharya and Dr. Shushmita Chakraborty. Now we are proceeding to the tea break, and I will request everybody to come again, since our IFEA President, Dr. Rangaram, will present his talk after the tea break. He's already here in the conference. He has attended from the US, and he is waiting to give her talk. So we have a 15 minutes tea break, and we will see you after the break. And I will also request all of you to kindly go to the virtual stalls. We have our sponsors who have sponsored this excellent program to go to the lobby and go to the exhibition hall and interact with the pharma companies. They might have some information for you. Thank you.
Thank you, Mr. Shushan. But from organizing committee, there's a request that since we are running behind the schedule, I would like to request to continue the session. The tea break session will be served here in the live forum during the session. Dr. Rangaram sir is waiting here for almost 1 hour. No point for further delay. Would like to request the moderator to start the session. It's a request from the organizing committee. We are right now, exactly the time is 17 hours.
Okay. Okay.
Please start the next
As
session.
you said, Rajeshri sir, we will now continue with Dr. Rangaram's presentation, and as this session is sponsored, this presidential talk is sponsored by Sun Pharma. So I will just like to acknowledge them. So after a half a minute video, I think Dr. Rangaraj can give his speech. Okay, over to Dr. Rangaraj. And with this talk, I have also Dr. Gautam Saha and Dr. Sri Kumar Mukherjee as chairperson. Welcome everybody. And over to Dr. Rangaraj Ram and Dr. Gautam Saha. Kindly introduce Dr. Rangaraj and Sri Kumar Mukherjee. Over to you, sir.
Good evening, everybody. I'm Ranga Ram from the United States. I'm the president-elect of the Indo-American Psychiatric Association. I'm so grateful to the organizers to have included me today in this presentation. I've been enjoying the presentation for some time now. As the previous speaker had mentioned, it is of very high quality. Do I just proceed or do I wait for?
Is Dr. Gautam Saha is present? Dr. Sri Kumar Mukherjee? I think they are in the venue. I think Dr. Ram, you proceed and post your session. I think they can give a conclude session. Please carry on.
Good evening, ladies and gentlemen.
Yes,
it is a great privilege to have Professor Rangaram with us today. As you know, that he is the president of Indo-American Psychiatric Association, and he is a good friend of all of us. He is a renowned psychiatrist, and I don't want to take much time before going to the Dr. Rangaram's lecture. Okay, Dr. Sri Kumar Mukherjee is with me as a co-chairperson, but now I request Dr. Rangaram, please go ahead and proceed with your presentation, sir.
In 1 second, as soon as I find my slide deck.
Okay.
Sorry for the delay. I should be. All right, here I am. I should have had this ready earlier. I apologize. Is my deck being seen?
Yes, doctor, we can see. Can you full screen it? Press F5 and full screen.
Yeah.
Yeah, thank you.
It's perfect now. It's perfect, sir.
All right. Are we ready to start?
Yes, sir. Please do.
Thank you very much. Once again, I really appreciate Gautam Da for inviting me. I will tell you briefly about the Indo-American Psychiatric Association. We are proudly 10% of the US psychiatric workforce, and our relationship with IPS is at 2 levels. We have always worked closely with the Indian Psychiatric Society since our inception, And many of us are very involved in learning from you, as well as bringing current knowledge from the United States to our colleagues in India. As for myself, I trained in India and I was a fellow of the Indian Psychiatric Society by the time I left India in order to pursue a research career at Johns Hopkins. And I have always been very interested in being involved with the Indian Psychiatric Society and attended many of your conferences. I really enjoyed my last visit to Calcutta, and I can tell you that is one of the highlights of my travel life. So with that, I just want to talk about some of the recent advances in psychopharmacology during the times of COVID-19. The possible hesitation that I might have in doing this talk is that many of the medications currently used in the United States, where psychiatrists like me are being called into the hospitals in order to discuss the care of psychiatric patients already in the hospital with COVID-19 or COVID-19 patients who have new psychiatric symptoms. The medications that we use here may or may not be widely used in the United States. And I hope to learn as we go along as to how many of the medications have penetrated the Indian treatment sites. And therefore, I would probably learn from you as we go along. To give you an update on the US story, it's a very sad and pessimistic presentation. It has really left 200,000, 2 lakh people dead at this point. We have shown that the greatest nation on the face of the earth, as Americans like to call themselves, has been an epic failure on several fronts. They ignored the epidemiology. The CDC leadership was ignored by the leadership of the country. The economy went into a tailspin. Unemployment rates are about the highest since the Great Depression. The equality or lack of equality between people has been shown in a very raw way, with Black and brown people being affected the most in terms of both morbidity and mortality. And I think at the core of it all is a lack of empathy among the leaders who are leading the country in order to address this pandemic. Having said that, this is not a political conversation. I just want to say that the neuropsychiatric symptoms and sequelae in the previous talk was covered so well. I just want to highlight a couple of points from this slide because I think it is redundant now with what you have learned already. So when the early reports came from Wuhan, issues around anosmia and ageusia was about 5%. And then it jumped to about 85% by the time the epidemic spread to Europe. And that brings me to one of the thoughts that I have always felt. And William Osler at Johns Hopkins had always taught us this quote from D.H. Lawrence: "What the eye does not see, the mind does not know, it doesn't exist." And therefore, it's very important that we have to know some of the symptoms, and then only our eyes would see it, and then only we would recognize it in our patients. So with that one comment, I'm not going to dwell on the symptoms, which I believe there's another brilliant speaker coming up who is going to tell you a little bit more about it. I had always been very interested in the Indian research, and I really thought that one very good summary came from Dr. Damodaran Dinakaran from NIMHANS. And all of the symptoms that he described have already been talked about, so I'm going to skip to the next slide. Psychiatric symptoms of several natures have been noticed within the United States. We have had patients with depression and anxiety, sleep deprivation, overwork. This is happening with doctors. Stigma is reported even in the United States for mental health workers and health workers in general. And I'm sure that there has been similar issues in India, even reports of violence early on. I haven't read anything lately. I hope that has come to an end. I pray for the well-being of healthcare workers who are putting themselves at risk and are at the forefront of this issue. The general understanding of COVID-19 has highlighted the need for good public health education. We have in the United States an ongoing debate about whether you should wear a mask or not. And that is so laughable because there is no really good reason not to wear a mask in order to not only protect yourself, but also show respect for other human beings and concern for them by not being a spreader. So this topic, I'm approaching it in two ways. One would be the first slide, which talks about the impact on patients who are already on psychotropic medications. Patients with psychiatric disorders are getting admitted with COVID-19 at a rate slightly higher than general population. And therefore, there is a great deal of concern about psychiatric medications, the bioavailability and distribution of these medications in the various patients is related and changed by the COVID-19 psychopathology as well. So the COVID-19 pathophysiology alters the psychiatric manifestations of existing patients who are getting admitted. COVID-19 impairs liver functions and therefore drug metabolism, and that is important to keep in mind. One thing that is very common in the United States, if you take the patients with severe mental illness, the rates of smoking is the highest among patients with severe mental illness, and abrupt smoking cessation as soon as they become ill and get admitted to the hospital has affected drug levels. And now we are seeing newly emergent side effects because they have stopped smoking and the blood levels of certain drugs that they have been taking previously are going up. So these are some of the things that we consider when we are having patients that we are called upon to attend in the hospital who have contracted COVID-19. So just following up on the previous presenter who did such a wonderful job, and I learned a lot from it, I just want to talk about the COVID-related risks. And I'm pretty much following a very similar order that she has followed. COVID is essentially known very prominently to be a disease of the respiratory system. That is how it was first discovered in Wuhan, and the first whistleblower was able to talk about that. So it was thought to be a viral pneumonia, and the respiratory risks remain the biggest problem even today, leading to ICU admissions and mortality. Psychiatric medications all have intrinsic sedative properties, and therefore one has to worry about both pharmacokinetic interactions and pharmacodynamic interactions. And if there are young residents in this group, for their recollection, I would talk about pharmacokinetic deals with the distribution and blood levels, whereas pharmacodynamic genes or interactions are related to the mode of action of the drugs. So having reminded folks on this, I will proceed to talk a little bit more about the respiratory risks. Antipsychotics with high sedative properties should be generally avoided. Clozapine, which is my specialty because I treat mostly patients with treatment-resistant schizophrenia, with its sialorrhea, constipation, and tendency to cause neutropenia, poses a major problem. And I have had to change my patients on clozapine when they are admitted to the hospital to other drugs just because they are not able to tolerate the side effects of clozapine, where the pulse is usually running around 100 because of the tachycardia induced by the drug. So one has to think about the consequence for their psychiatric issues when they are admitted to the hospital for essentially what is a COVID presentation. But we are forced to change the medicine so that the medical doctors are able to deal with their physical problem in a more safe and reasonable way. Benzodiazepines should be avoided or used in very low doses. Short-acting benzodiazepines are better tolerated and are metabolized faster, and they get out of the system sooner. So we prefer using those in order to control issues around agitation and in some other situations where the patient may have to be sedated, we have to do it very carefully and very thoughtfully. One example of an issue that comes up is, I don't know whether this combination is used in India of lopinavir and ritonavir, which is an off-label use for the treatment of COVID. It comes from the AIDS side of the medical side, and both that combination has problems with sedating drugs like quetiapine and with benzodiazepines. And this drug interaction has been reported more than one occasion in the literature as something that has been problematic. Moving on, routine EKGs and the QTC is measured for all our patients. Many psychiatric medications, ziprasidone comes to mind as the top example, but there are many psychiatric medications which cause QTC prolongation. QTC of less than 500 milliseconds is generally considered as a safe number, and a QTC prolongation of 10 points, as long as it is below 500, is considered as a reasonable expected concomitant feature of the use of psychotropic medications. But QTC prolongation larger than that, leading to numbers higher than 500 milliseconds, often predisposes the patient to cardiac arrhythmias. There are pharmacodynamic interactions occurring with many of the antivirals used for the treatment of COVID, and drugs like chloroquine, hydroxychloroquine, and opioid medications which are given for pain. All of these lead to increase in QTC, leading the patient vulnerable to cardiac arrhythmias and even a cardiac tamponade. It's a particular issue for patients with pre-existing cardiac disease, ischemic heart disease being the most important one to remember in this regard. So we have covered respiratory and cardiovascular risks. I want to go on to medications. Risk of medications in COVID patients who go into the hospital, recover and come out, and have been put on psychiatric medications, either before the illness or during the hospital stay. One has to remember that antipsychotics, benzodiazepines, mood stabilizers are all associated with the risk of secondary infections once these patients are discharged. The most important one to remember, and we see this often, is antidepressants in patients who've been treated with the various antibiotics and antivirals while they are in hospital. We put them at higher risk for C. diff infections. So that would be one of the things one has to bear in mind. Clozapine and carbamazepine are particularly problematic because even in COVID-19, without these medications, lymphopenia, which is less than 100 cells, occurs in 63%, 2/3 of the patients, and leukopenia occurs in 25%. So one has to bear that in mind, especially if we are going to be using medications that are known to cause neutropenia and agranulocytosis. So moving on, coagulation disorders. Both thromboembolism and bleeding disorders can occur with COVID-19. Both antipsychotics and antidepressants are known to increase the chances of thromboembolism. Risk of bleeding is higher with SSRIs and SNRIs, as you all know, and the concern is worse in older patients who are much more vulnerable to all of the effects. Strokes are the first thing that comes to mind, but even in younger children, there is a thromboembolic manifestation that has been a serious concern, and therefore if psychiatric meds have already been prescribed to these people because they were previously taking them, it's something to bear in mind as to whether we want to change them while they are in the hospital and we are called on as consultants in order to help manage these patients. So moving on to delirium. Delirium is being discussed by others, but I just want to say that it disrupts the care on the unit, especially the way the units are set up. in the United States, it has been a major issue to have a disruptive COVID patient who does not follow instructions and who is not doing the things that they're supposed to do in order to stay safe as well as not infect others. Delirium also is associated with poor prognosis. Delirium has multiple etiologies. Certainly multi-organ failure contributes to delirious picture, hypoxia, sepsis, medication also add to this. And since the focus of my talk is medications, I'm going to talk a little bit about that, but bear in mind electrolyte and metabolic abnormalities also play a role. The medicines that one should be careful in using are again, benzodiazepines, anticholinergics, and lithium. Also try and see what medications the patient has been given for the treatment of COVID. Antimalarials, antivirals, interferons, and corticosteroids all have a role in causing a delirium, and therefore one has to be relatively careful as to how we use this. Other drugs for delirium that is probably a little more interesting to us in psychiatry is that we use melatonin and melatonin receptor agonists, and these are helpful in delirium management because regulating sleep and the circadian rhythm appears to have a neuroprotective effect. Alpha-2 agonists, which we often use in ADHD and other situations like nightmares in PTSD, is another area where we are able to bring in our expertise in order to help patients with a delirious picture, and both clonidine and dexmedetomidine has been used. So that brings us to specific drugs that are widely used in the United States in terms of COVID therapeutics. So this is a different slant on it. If the patient is getting a specific COVID therapeutic, what are the implications for psychiatrists who are going on a consult service and looking at these patients and trying to help them with their psychiatric symptoms? So here are the common medications that are used. Despite all the controversy about chloroquine and hydroxychloroquine, it is still being used, and remdesivir has become the main intravenous drug that we use. And I would be very eager to know if there has been use in the in India, and people have some comments about how extensive it is. I'm trying to learn from you as I participate in this webinar. So remdesivir, as you all know, is an RNA polymerase drug. The treatment course is 5 to 10 days intravenously. It can cause hypotension, diaphoresis, shivering, and transaminase elevation. So if there is a drug that also causes transaminase elevation, one has to be careful about that. So that brings us to azithromycin. Azithromycin is widely used, and I have repeatedly seen patients who have been treated with azithromycin even before COVID show delirious picture. Azithromycin in COVID has also shown to cause depression with psychosis, case report, catatonia. Delirium is fairly common, an aggressive reaction which makes them very difficult to manage in an ICU setting. And then you have dizziness and somnolence. Having said that, chloroquine and hydroxychloroquine, the therapeutic benefit is relatively still questionable. But I believe, and correct me if I'm wrong, that ICMR encourages use of hydroxychloroquine to this day. It has not changed its recommendations. And I can understand why, because it has been widely used in India, and we have a certain level of comfort. In the United States, what we have found that different drugs in different disease states seem to have different effect on the patients. And we are seeing much more of the risk of QTC prolongation than I have seen ever in my career as a consult psychiatrist. It's metabolized through the CYP3A4 pathway, which means we'll have to think about drugs that are metabolized through the CYP3A4 pathway, such as fluoxamine, and also an inducer such as carbamazepine. So fluoxamine would increase blood levels and cause toxicities from that perspective. Carbamazepine may make it less effective because they are inducers of the CYP3A4 pathways. Risk of seizures need to be remembered, especially with antipsychotic meds, which as a rule lower seizure threshold, and bupropion comes to mind. One of the things that we need to think about is what is the half-life of the drugs. I kind of referred to this when I talked about benzodiazepines and the preference for short-acting drugs. We have to think about it the same way when we are doing any psychiatric medication prescription for patients on chloroquine and hydroxychloroquine. So that brings us to colchicine, which is an anti-inflammatory drug. It too has a problem of a narrow therapeutic index. In that sense, the toxicity of the drug can occur very easily. And once again, it's important to remember it is CYP3A4. Now, if you leave this with drug interactions and the cytochrome P450 system, with just one thing that you should remember is most of the drugs that are used for the treatment of COVID-19 go through the CYP3A4 pathway. So we should think about the use of drugs like fluoxamine, aripiprazole, brexpiprazole. I don't know whether that's available in India, carbamazepine, as well as some of the common medical drugs that are used, like the mycins, erythromycin, and so on. So that would be my thrust of talking about drug interaction. CYP450 system, the most important one appears to be CYP3A4. Convalescent plasma, the good news is that convalescent plasma has not so far caused any problems with psychiatric medications. I personally feel that there is a potential psychological benefit for the donors who have recovered from COVID themselves, and now they are able to help others by donating their blood and plasma for the recovery of patients. And this is probably the one area where there is a psychological benefit and personal growth and satisfaction of patients who have been so unlucky to have COVID, but lucky enough to have survived it. So that brings us to corticosteroids. The immune modulators lessen cytokine storm, and therefore steroids have a role. They mitigate the hyperinflammation syndrome as well. But remember, steroids can prolong QTC. So that is the second point I want to make around drug interaction. One is CYP3A4, and the second one is the QTC prolongation. Favipiravir is also used. It's an RNA polymerase drug, very similar to the other AIDS medications that are used. Again, QTC prolongation is a consideration. And that is really my short summary of the different drugs used. I once again want to thank the sponsors for including me. And my only regret is I'm not in that beautiful farm that Dr. Saha Gautamda had posted, where I would have really enjoyed this. I hope I have managed to keep you engaged in the time I was given. Thank you.
Thank you, Dr. Rangaram. It was a nice presentation. Over to Dr. Gautam Saha and Dr. Sri Kumar Mukherjee for their comments.
Thank you, sir. Thank you. This is Sri Kumar Mukherjee, co-chairperson of this session. Thank you, sir. Thank you so much for your erudite presentation of COVID-19 physical as well as neuropsychiatric manifestations, pharmacotherapy, side effects of drugs, as well as the outcome. Sir, it was a very illuminating lecture and we have all benefited from this. Now the session is open for question and answers.
Ranga, I am Dr. Prasad Rao. May I ask a question to you? How are you? Good.
Of course. Namaste, Prasad Rao. Go
Namaste.
ahead, please.
Thank you very much. I just want to ask, how much is the evidence for the remdesivir injections causing the improvement? Do you have that? And how much is the psychiatric morbidity following? Do you have any initial data coming from the United States? How much the people are getting depression? Here we are already seeing depression, panic attacks, OCD. We had psychosis as well. So it would be very useful from your side because you already do some work there.
Yeah. So remdesivir has been given what is called an emergency use authorization, or EUA, by the FDA. One of the downsides of EUA is that remdesivir can be used for patients along with other measures. And therefore, the outcomes that would emerge from that is contaminated by all the other medicines that are being given. So it's not a true drug trial. Now, effectiveness data is being collected, but not enough numbers have been there for them to publish anything. Having said that, the baseline rate of depression in the United States before COVID-19 was 1 in 6, or about 15%. Since COVID-19, their baseline rates have jumped to 1 in 4, or 25%. And so I'm seeing it in my practice. I hear it from my colleagues all the time that not only existing patients are having greater levels of distress, but new patients are coming into the system with depressive symptoms. If I may, I trained as an epidemiologist at Johns Hopkins, and I joined Hopkins in '88 when the first ECA studies were done. And I'm just going to tell you something that's going to come. It's not research that's completed. My professor, Bill Eaton, had actually put together a follow-up study of the original 1984 cohort. And they had divided them into 9 cells, and they were working on the cells, and they were halfway through when COVID came. So now half the patients from the original ECA studies were pre-COVID, and the other half are post-COVID. And the psychiatric symptomatology and disorders are being enumerated in this group. And I'm so excited to share this with you because that paper should be coming out, and we should have a very nice cohort of American representative sample, which will show the rates before COVID and after COVID. So.
Thank you very much. I think that's a good information. I think we are sharing our information. We are also almost, we don't have epidemiological figures, but we are sharing.
Hello.
Yes, sir.
One question. Excellent presentation, Dr. Rangaram.
Thank you, Gautam.
My question is, as recovery trial shows that the betamethasone is one of the most important medicines for treating the COVID-19. There are lots of patients have comorbid diabetes there. Is there any special guideline for that to using betamethasone or any steroid for them? Though it is a life-saving medicine.
Yeah. So diabetes is a major problem. The way the steroids have been prescribed in the hospital, they are able to control the caloric count as well as the sugars. And because these patients are being treated in the hospital, so far that has not been an issue. They just use insulin to control the sugars, short-acting insulin. And that is why I have not been called to see a patient, or I have not heard from my colleagues or any reports of diabetic DKA or other complications from the use of corticosteroids. But if they're going to be discharged on some dose of prednisone or other oral drugs, I would be very, very concerned about diabetic management. And that's a very excellent question. And I think there's a whole lot of sequelae that we are going to see. You know, this happened with Spanish flu. We had the Parkinsonian features beginning to be noticed early on. And then there was a virtual epidemic of von Economos disease, or whichever one disease that you remember from the various epidemics. I anticipate a neuropsychiatric sequelae to be the main concern as we go forward. But thank you very much for that question.
Can I ask a question?
Yeah, you may.
Thank you very. Sorry, am I audible? Yeah,
you are. Please introduce yourself.
Okay. I'm Dr. Abir Mukherjee. Thank you, Dr. Rangarao, for your excellent presentation. I was just wondering, are you using tocilizumab over there for for severe tocilizumab for for the cytokine storm, for the reduction of cytokine storm, because that is causing a lot of delirium over here. So have you been using it as a rescue medication as well? I mean, it's part of the rescue medication like dexamethasone and the rest. So like
we have used it, and it is causing a lot of delirium here as well. And I think I mentioned that in my talk. I may or may not have. I may have removed that slide. It has been a problem here as
well. One question. Yes.
Are there any more questions?
Yes.
Introduce yourself.
Thank you very much. Excellent presentation, Dr. Rangaram sir. I am Dr. Ranjan Bhattacharya. My question is that chloroquine prophylaxis, regarding chloroquine prophylaxis. So there had been debate and there had been paper published in the Lancet which has been withdrawn about the use of the hydroxychloroquine. So why there is difference of response of hydroxychloroquine in US setup and in Indian setup? Your final comment on that. How do you rank the hydroxychloroquine in the prophylaxis, especially on the healthcare workers?
Yeah, the truth is, if you think about what does hydroxychloroquine do, is that it mitigates the inflammatory response. So I would say that if someone is already ill with COVID and they are going into a cytokine storm, when people use hydroxychloroquine, which I have to tell you that despite the negative studies, we still prescribe them in the hospitals, and I see it being used in isolated cases. But the overall faith in hydroxychloroquine in the United States is very low. Having said that, it teaches us an important point that I think we often do not remember, is that the same drug in multiple disease states, even with patients without comorbidities, reacts completely differently. The one example that I talk about is the metabolic syndrome associated with, let's say, for example, aripiprazole or brexpiprazole in major depression is much higher than in schizophrenia. There is all these areas that we have to remember that the drug is a drug, but the disease state has some impact on how a person develops side effects because of a certain drug. And hydroxychloroquine is the same example. I myself use hydroxychloroquine every time I come to India in order to help me with my fears of malaria. I'm just a germaphobe by nature. I'm lived all my life prepared for this COVID epidemic because that's how I live my life. But having said that, I think I would be very worried about using it for a patient here.
Kumar sir, Gautam sir.
Good evening, sir. Myself, Dr. Jishnu Bhattacharya, very junior. Excellent presentation, sir. I just want to ask one thing. Sir, in severe acute psychosis case, he or she was treated with antipsychotic and found to be COVID positive. And you have said, and it is documented also, the drug seizure activity and other problems are increasing with the antipsychotic. Then what should we do in a acute psychosis case with COVID positive report?
Well, we have to be alert to the possibility of seizures. We should consider the use of anti-epileptic medications in addition if that is what you want to do, because there are usually some early signs that a person is beginning to show CNS decompensation. So I would encourage people to think about it. But if you have psychosis, there is not much you can do, except there is a new medicine in the United States. I don't think it has come out in India. It's called Capilleta. It works through the serotonin mechanism to produce some amelioration of psychotic symptoms. It does not have much of a dopamine activity. That is the drug that we would prefer to use because we think that the lowering of seizure threshold is somewhat related to dopaminergic activity, and therefore Capilleta, which is a brand new drug, it's been out in the market for 3 months, but in COVID patients, that has become the drug of choice.
Hello, it was really an excellent session. Thank you, Dr. Rangaram again. And all the participants, all the viewers, you have done a wonderful job. Sir, I think this is the time we can conclude the session. Before conclude, Rajeshri, I want to hand over the mic to Organizing Secretary, Dr. Rajeshri Goni.
Gautam, can I say one word? Gautam, can I say one word to Ranga?
It was a wonderful presentation, sir. Myself, Dr. Rajeshri Kothagutta, Organizing Secretary, of WBIPS and WBIITP. So may I now request Dr. Gautam Shah and Dr. Srikumar Mukherjee jointly to hand over the memento and felicitate Dr. Rangaram for his valuable presence.
Sir. Hello.
Hello.
Good evening, sir. It is virtually I'm given. I'll keep this with me. Whenever we meet next, I'll definitely hand over to you, sir.
You will bring it to my house when you come to the US next.
Yes, sir.
Thank you.
Thank you, sir.
Ranga, I was just saying that you sounded as an epidemiologist, internist, and psychiatrist together. A wonderful presentation on understanding and a thorough understanding of COVID. Thank you very much.
Thank you. Thank you very much, Dr. Rao.
Thank you, Dr. Rao. Dada.
Thank you, Dr. Rangarajam and Dr. Gautam Saha and Sri Kumar Mukherjee. Now we end this session and we will now do our official inauguration of Psycon 2020. And I will ask Rajarshi sir, our organizing secretary, to take over the podium mic and kindly follow the procedure for the opening.
Thank you, Shushanta. But we will have a tea break of 15 minutes. After that, we will start the inauguration ceremony, during which we will prepare the stage. Please give us this 15 minutes.
Okay. Okay.
And stay with us. We are all with you. And thank you for your valuable presence. Be on live.
Yes.
Thank you.
I will ask all the other people to kindly go to the exhibition area because we have postponed the tea break because we have Dr. Rangarajan Ram's presentation. So I will request everybody to kindly go to the exhibition hall and kindly meet the trade people where they are waiting for your valuable presence. So kindly go to the lobby and visit the exhibition hall. Thank you. I will be back again after 15 minutes for the inauguration when the stage will be ready. Thank you all.
এগুলো সব আছে এডিটর রিপোর্ট এডিটর দুটো কেন আছে সবই দুটো করে আছে একটা ওয়ার্ড ফাইল একটা ইয়ে ফাইল
हेलो हेलो
Hello.
One, two, three. Hello, 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 hello. You just tell 1, 2, 3.
1, 2, 3.
Yeah, thank you, thank you. I can hear you. Perfect, perfect. Okay. Hello, hello. Hello, 1, 2, 3. Hello, 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 hello. हाँ अभी मिल रहा है हेलो 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 क्लियर क्लियर ओके
হ্যালো হ্যালো তুমি যাও আমি দেখে নিচ্ছি হ্যালো হ্যালো এবার দেখো তুমি দেখো হ্যালো 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 আছে দাঁড়াও 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 কিচ্ছু অন করতে হবে না দাঁড়াও স্টোর দাঁড়াও হ্যাঁ এবার দেখো দেখি তুমি হ্যালো 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 যাচ্ছে না তো দাঁড়াও 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 অনেক উপায় আছে দাঁড়াও না 3-4টে আউট আছে কোন এক্সেলার আরে এক্সেলার ডিরেক্ট ঢুকবে না হ্যালো 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 নিচে না হ্যালো হ্যালো
ನಮಸ್ಕಾರ TSS ಏನ್ ಚೆನ್ನಾಗಿದ್ದೀರಾ? ಚೆನ್ನಾಗಿದೀಯಾ?
ಇದೆಯಪ್ಪ ರಾಜ್ಕುಮಾರ್.
వీళ్ళిద్దరు ఎక్కడికి వెళ్ళారు ఈ సినిమాలో? ఐస్ క్రీమ్ తింటూ అక్కడి నుంచి అమ్మ ఇంట్లో నుంచి పారిపోయి వచ్చి ఇంత మంచి బట్టలు వేసుకుంటాను.
Very good evening, sir. Am I audible to all of you? Yes, sir.
Sir, are you ready? Sir, are you ready? Rajoshi sir, are you ready from the venue?
Srinivas. Jamai Srinivas.
Yeah. Good evening, sir. We're going to start our program shortly. Our chief guest, the Honorable Superintendent of Police of North 24th Pargana District, is arriving shortly. Within next 10 minutes, I presume, we can start our inauguration ceremony. Kindly bear with us, please.
Hello. Hello.
SP Warrant, SP Warrant meeting. Black Tiva. మాట్లాడేందుకు అర్థమైందా?
Dr. Rao আছে। গৌতম দা, সবাই একটু ভিতরে বসে যাও, বাইরে যারা আছে ডেকে নাও। রাজশ্রী, বাইরে যারা আছে সবাইকে ডেকে নাও। একটু হলটা ভরা থাকে। এটা তো বলার দরকার আছে না, এটা গায়ে শুনতে হবে।
Rajoshi sir, start.
তো এটা আনমিউট করতে হবে তো। ঠিক আছে। গৌতম দা গ্রিন সিগন্যাল দিলে ভেতরটা একটু লোকজন বসে।
Rajoshi sir, you are live.
শুরু করব। শুরু।
Rajoshi sir, please start the inauguration
Good
program.
afternoon to all the delegates. We are now starting with the inaugural function of Psycon 2020. the joint annual conference of IPS West Bengal State Branch and IPP West Bengal State Branch. I'd like to request the following dignitaries to take the stage. I would like to call upon President of Indian Psychiatric Society, Dr. West Bengal State Branch, Dr. Jyotirindra Nag. Dr. Nag is not present here physically. I would like to invite President of Indian Association of Private Psychiatry, West Bengal State Branch, Dr. Shamol Chakraborty. We have our chief guest, Shri Abhijit Banerjee, Superintendent of Police, North 24 Parganas. He is on his way to the venue and will be reaching here within a short span of time. Vice President cum President-elect, Indian Psychiatric Society, West Bengal State Branch, Dr. Sri Kumar Mukherjee. Dr. Mukherjee is present here physically. Sir, please take your chair. I welcome President of Indian Psychiatric Society, Professor P.K. Dalal. I would also welcome Vice President cum President-elect, Indian Psychiatric Society, Dr. Gautam Saha. Dr. Saha is present here physically. I welcome President of Indian Association of Private Psychiatry, Dr. G. Prasad Rao. He is virtually present. Welcome, sir. Honorary General Secretary of Indian Psychiatric Society, Dr. T.S.S. Rao. Sir is also present virtually. I'd like to invite Honorary Secretary General of Indian Association of Private Psychiatry, Dr. Pramod Kumar. I welcome. Yeah, Dr. Pramod is also there virtually. I'd also like to invite Honorary Secretary of Indian Psychiatric Society, West Bengal State Branch, Dr. Ranjan Bhattacharya. Dr. Bhattacharya is here. Then I would like to invite Honorary Treasurer of Indian Psychiatric Society, West Bengal State Branch, Dr. Sanjay Garg. I think he is. Then Honorary Editor of Indian Psychiatric Society, West Bengal State Branch, Dr. Sujit Sarkhel. Honorary Secretary of Indian Association of Private Psychiatry, West Bengal State Branch, Dr. Hena Roy Borat. Then Honorary Treasurer, Indian Association of Private Secretary, West Bengal State Branch, Dr. Sanjay Saha. Sanjay Da is here. Sanjay Da, please take your chair. Honorary Editor of Indian Association of Private Secretary, West Bengal State Branch, Dr. Devashish Sannal. Organizing Chairperson of Psycon 2020, Dr. Alok Patro. Organizing Secretary of Psycon 2020, Dr. Rajarshi Guho Thakurda. Rajarshi is here. And I would also like to welcome our inaugurator of this program, Dr. Ranodip Ranjan Ghoshrai. So please come here. And last but not the least, Honorary Editor of Indian Journal of Psychiatry, Professor O.P. Singh. So we have the dignitaries on dais. Chief guest has yet not reached the venue. So we will start with the program, inauguration program. I would like to invite the organizing chairperson, Dr. Alok Patro, to deliver his welcome address. Is Dr. Patro here?
Yeah.
Yeah, Dr. Patro is there. Dr. Patro?
Yes. Yes.
Kindly deliver the welcome address.
Dear, good evening.
Dr. Patro to kindly deliver the welcome address. Hey, sound.
Good evening. Good evening, everybody.
Sir,
dear friends, am I audible?
Yes, sir. Yes, sir.
Dear friends, it fills my heart with pleasure to welcome you all to the inaugural ceremony of Psycon 2020. This time it was hosted by the Medinipur Tamralipto branch of IPS West Bengal. We had initial plans of holding the conference at Digha, but due to unprecedented situation arising out of COVID-19 pandemic, the venue had to be cancelled. As a result, we are holding it at Mon Nie Garden, Dattapukur, Barasat, with arrangement for virtual attendance and webinar simultaneously. Despite all the limitation, we have tried our best to put up a successful state conference, and I am immensely thankful to my organizing secretary, Dr. Rajashri Gothagudda, and I am also thankful to other members of the organizing body, particularly Dr. Ranjan Bhattacharya, Dr. Kaustav Chakraborty, Dr. Sujit Sarkel, Dr. Rajashri Rai, Dr. Sayandeep Ghosh, and especially Dr. Gautam Saha for having helped me with the venue of the conference. Also, I am thankful to the other members of the organizing body and IPS office bearers. I am also thankful to all the registered delegates and all pharma houses for their support. I hope all of you will enjoy the academic feast to the fullest. I sincerely urge everyone to stay safe in this trying day. Thank you.
Thank you, Dr. Patro, for your welcome address. Now I would like to invite Dr. R.R. Ghosroy to deliver his inaugural speech. Okay, Dr. Dalal is here. Yeah. We have amongst us President of Indian Psychiatric Society, Professor P.K. Dalal. I request Professor Dalal to say a few words. Professor Dalal.
Thank you.
Yes.
Am I audible?
Yes, sir.
Yes, yes.
Dignitaries on the dais and off the dais, especially I would like to name Dr. Gautam Saha, the President-elect of Indian Psychiatric Society, Dr. O.P. Singh, Editor of Indian Psychiatric Society, and Dr. G. Prasad Rao, the omnipresent President, our past President of Indian Psychiatric Society and current President of all the other organizations of Psychiatric Society of this country, and Dr. R.R. Ghosroy and all the other dignitaries on the dais and off the dais. It is really a great pleasure for me to be with you online. I actually wanted to be offline, that is in person present, and to have some Mach Bhat and Rashogolla, which I could not. One thing I really appreciate about the West Bengal State Branch is that you people do always this joint amalgamated program in which IPS as well as IAPP, you hold this program jointly. That is really very nice, and I expect and rather request all the other state branches to kindly emulate this kind of joint programs. And so with these words, I presume that all the scientific deliberations will be very fruitful, discussions will be very fruitful, and there will be definitely some take-home message as well. So with that, I hand over the mic to the organizer. Thank you.
Thank you, Professor Dalal, for your kind words. Thank you, Professor Dalal, for your kind words. I now request President, Indian Psychiatric Society, Indian Association of Private Psychiatry, Dr. G. Prasad Rao, to say a few words.
It is indeed a great pleasure to talk after our Indian Psychiatric Society President, Professor P.K. Dalal. Sir, thank you for your kind words. And it is my real pleasure being with such a luminaries. Bengal, as we can see, is the intellectual capital, and all the psychiatrists, most intelligent stroke is that you, for the last, not this year, for the last almost many years, you are combining this force, as Professor P.K. Dalal said. I would greatly appreciate. Yours is the award-winning team, both in the Indian Psychiatric Society, also in Indian Association of Private Psychiatry. We had and we have innumerable leaders. We had Hina Roy, we had Arvinda Brahma, Shamal Chakrabarti at this point of time, Sri Kumar, who is the incoming president of the IPS, our own young, lovely Ranjan, and a lot of others which I probably would not name because of the time. I'm very thankful for inviting me, and I wish all the best. I know this would be the best conference. I would have loved to be like P.K. Dalal in Calcutta, but I think sometime next year we are going to have, and I'll be there. Thank you very much.
Thank you, Dr. Rao. Thank you, Dr. Rao, for being with us. I now request Honorary General Secretary of IPS All India, Dr. T.S.S. Rao, to speak a few words. Dr. Rao, please.
Am I audible?
Yes, sir.
Okay. Good evening, everybody. And at the outset, I'm really grateful to Indian Psychiatric Society, West Bengal State Branch, and the IAPP Association for inviting me for this particular program. As I had sent the message, we were anxious about how to go about all through the year, but I think West Bengal and IAPP both have shown us actually that this can be organized in a great way, both physical and virtual, and the number of participants who can take part has actually increased enormously. The theme what you have chosen is actually extremely important one for a simple reason that whether mind, brain, same, different, and that particular conflict is actually continuing for such a length of time. And coming to each and everyone who is involved with this particular program, they are real stalwarts, and we have been the recipients of hospitality for a long time, many years. We are missing that particular physical presence, but all said and done, we are looking forward to the great program. Already a lot of things have gone on, and till tomorrow, it will be a real intellectual feast. So also something, a very personal learning experience for me. I wish this particular conference all the best, and looking forward to each of the deliberations that are going to happen. Personally, and on behalf of the IPS, we wish the conference all the success.
Thank you, Dr. Rao. We also miss you. Now I would like to request Honorary General Secretary of Indian Association of Private Psychiatry, Dr. Pramod Kumar, to say a few words. Is Dr. Kumar there? Sorry, Dr. Kumar has left for some emergency call from the hospital. So I now request President of Indian Psychiatric Society, West Bengal State Branch, Dr. Jyotirindra Nag, to deliver his speech. Dr. Nag is also not there because of some family emergency. So next, I would like to go to President of Indian Association of Private Psychiatry, West Bengal State Branch, Dr. Shamul Chakraborty. Dr. Chakraborty, please say a few words to the delegates.
Good evening. So this time, the Indian Psychiatric Society West Bengal Branch and Indian Association of Private Psychiatry West Bengal Branch jointly conduct the program both in physical as well as virtual form. I think that is a tremendous work. What our organizing secretary, Dr. Rajeshri, and chairperson, Dr. Alok Patra done. It is a really marvelous job, because from the morning I actually in my laptop, and I'm seeing that the technical support is fantastic. There is no problem to communicate or to see the programs, and the programs are all in time. So I think that will be the future instance in all other state branches to conduct such program in virtual as well as physical. So with these few words, and make thanks to the organizing committee as well as the office bearers of both Indian Psychiatric Society West Bengal State Branch as well as Indian Association of Private Psychiatric West Bengal State Branch. I congratulate all, and long live IPS, long live IIPP. Thank you. Thank you very much.
Thank you, Dr. Chakraborty. Now it's time for our dynamic Honorary Secretary of Indian Psychiatric Society, West Bengal State Branch, Dr. Ranjan Bhattacharya, to speak a few words.
Very good evening to everybody. Respected Professor P.K. Dalal Sir, President Indian Psychiatric Society. Respected Professor G. Prasad Rao Sir, President IIPP. Respected Professor P.S.S. Rao Sir, Honorary General Secretary of Indian Psychiatric Society. Respected Dr. Pramod Kumar, and all the other dignitaries of the dais and on the dais who were present in real and virtual mode. I welcome you all in the Psycon 2020, which is jointly organized by Indian Psychiatric Society, West Bengal State Branch, and Indian Association of Private Psychiatry, West Bengal State Branch. Since last 4 years, from 2016 to 2020, I had been holding this chair of Honorary Secretary, Indian Psychiatric Society, West Bengal State Branch, with your love, blessings, and affections, with the cooperation of the all past 4 presidents of our state branch, all my treasurers, all my editors, and the EC members, I have accomplished this. And as Professor Dalal has said, that we are very much popular in the national lobby for our warm hospitality, and you are missing the bhat, macher jhol, and doi. We too really, sir, are missing you not being present here in the real platform. The organizing committee led by Dr. Alok Kumar Patro and Dr. Rajeshri Guha Thakurta had left no stones unturned to make this program a grand success. It was literally virtually seeming impossible during this COVID pandemic to hold this program successfully. And you'll be amazed to know that perhaps we are the first professional body who are holding the state conference during COVID pandemic, maintaining all complete safety restrictions. And we have been awarded 8 credit hours by West Bengal Medical Council for holding this conference. Today, we have registered more than 100 participants in this program, and this will be streamed in the all social medias and virtual platforms, including the YouTube, and probably will be received by the audience of around in thousands. So whatever I have done in these 4 years as State Secretary is all because you. It makes my heart loaded with emotions. It could never have been possible without you. And all our IPS national leaders and my state colleagues have blessed me, and I think your blessings will be continued in future. Thank you very much for giving me this honor. Thank you.
Thank you, Dr. Bhattacharya, for a very emotional address. Now, I would like to request Honorary Secretary of Indian Association of Private Psychiatry, West Bengal State Branch, Dr. Hena Bharat Roy, to deliver a speech. Is Hena here? I think she is not here. So next, we have our beloved Rajarshri. Rajarshri will sing an inaugural song. So I would like to request Dr. Rajashri Rai Bandyopadhyay to sing the inaugural song. Rajashri, please.
Thank you.
Thank you and good evening to everyone. Am I audible, Costa?
Yes, absolutely.
Yes, ma'am.
This is an ancient Vedic song, Sangha Chadvam, fused with Anandaloke, and I will be singing a few lines from both of these stanzas. The English translation is, may you move in harmony, speak in one voice. Let your minds be in agreement, just as the ancient gods shared their portion of sacrifice. May our purpose be the same. May we all be of one mind. In order for such unity to form, I offer a common prayer. Sangachatvam, Sangvathatvam, Sangho Manasi Janata. Sangachatvam, Sangvaratvam, Sambho Manasi Janata. Samanu mantra samiti samani. Samanu mantra samiti samani. Samana mana Sahachitame Nandaloke Mongola Loke Iraju Shoto Shundaru Mohima Tabut Bhashito Moha Gogunu Mache Mohima Tabut Bhashito Moha Gogunu Mache বিশ্বজগৎ মণিভূ সনবেষ্টিত চরণে আনন্দলোকে মঙ্গলা লোকে বিরাজো সত্য সুন্দর বিরাজো সত্য সুন্দর. Thank you. Over to you, Costa.
Thank you, Rajashridi, for the beautiful rendition. Thank you very much. Now I would like to call Honorary Editor of Indian Journal of Psychiatry, Professor O.P. Singh, to say a few words. So please come to the dais.
It is a pleasure to be here, and of course it is my branch, and we are happy that all our leadership of all India level of both IPS and IAPP are present here to give their blessings. We in West Bengal, both IPS and IAPP work together, and we try to do innovative programs. And I'm really grateful to our organizing team, Rajarsi Thakurta and Dr. Alok Patro. They have taken a lot of, I said, really it was trouble of coordinating both the physical and as well as virtual presence. So technical team and physical team both has to be organized at this time, and they did not have a lot of support also because of the COVID. They have to do a lot of work on their own with support of some few people. So I must say that they have done wonderful work. And we, as a member of the state branch and also office bearer of All India IPS, I promise all the help and work for the West Bengal branch. Thank you.
Now I would like to call the President Vice President cum President-elect of Indian Psychiatric Society, our beloved Dr. Gautam Saha, to say a few words.
Good evening, my friends. It's a really great pleasure whenever you speak in front of your own people. In fact, all the members of Indian Psychiatric Society, Indian Association of Private Psychiatry is my own. Either it is they are present in person or virtual, it does not matter to us. It is always a great pleasure. My dear friends, when we start this joint program, it is long back. Still, I remember maybe the 8 to 10 years back, when I was the General Secretary of the both Indian Private Psychiatry and Indian Psychiatric Society West Bengal State Branch. We have started this joint program. After this, we are continuing all these things. Whenever we do program, we do jointly because we don't see any differentiation except the membership status among us. Whatever we do jointly. In fact, I am an active member and the office bearer of all India central body also, Indian Psychiatric Society and Indian Association of Private Psychiatry. Today, I must appreciate Dr. Rajesh Gowda, along with the chairperson, Dr. Olav Patro, for organizing such an excellent conference. Maybe we are the pioneer to organize this conference virtually as well as in person. Maybe the presence of in-person members are a bit less, but still we are really proud of the organizing committee led by both of them. At least they have taken lots of pain to organizing this. And I should appreciate not only these two people, along with the full team, young brigade, though some of them are not so young, as I mentioned. They have done a wonderful job. Whenever we are organizing like conference, whenever we organize state level conference, even when organizing a district level, any seminar, all of them are give their best. That is the thing we want every part, every corner of our country. And I am really proud of not only the young brigade of Bengal, the young brigade of the East Zone. I am really always proud of the young brigade of the All India. The All India Young Brigade now at present is there in my Indian Psychiatric Society. Lifetime, I have not seen so much brilliant and dedicated young members in the past. I am really, when we are young too. So, with saying so, I really congrats again the organizing team and the present senior members, Dr. R.R. Ghoshrai, Dr. Prabir Pal, Dr. Ashim Mullik, Dr. Srikumar Mukherjee, and my dear friend, editor of Indian Journal, Indian Psychiatric Society, Dr. O.P. Singh, and junior in-person present, Rajarshi, Dr. Kaustav, another Rajarshi, Pinaki, and all, Sanjay Saha, Abhay, Jishnu, all of them. They are brilliant and they are always helpful. They are our strength. Without them, we are nothing. Thank you very much. Thank you again to all of you. And Kaustubh, please.
I would like to request the dignitaries who are present over here to come to the dais for the inauguration of the souvenir of Psycon 2020. স্যার চলে আসুন সবাই চলে আসুন এই সবাই চলে আসুন না যারা বসে আছে সিনিয়ররা চলে আসুন এই কে সুবিনিটা দেবে কে সিরিয়াসটা কোথায় I request Dr. I'd like to request Dr. Ranodip Ranjan Ghosh Rai to inaugurate the souvenir of Psycon 2020. Dr. Ghosh Rai, please.
Assisted by past president.
He is being assisted by past president of Indian Psychiatric Society, WBSB, Dr. Ashim Molli. Others also please join. We have amongst us our chief guest, Mr. Abhijit Banerjee, Superintendent of Police, North 24 Parganas. He has just reached the venue. Welcome, Mr. Banerjee. So we need a big clap from the audience. We thank the editors of the souvenir, Dr. Shayandeep Ghosh and Dr. Obhiruchi Chatterjee. Dr. Obhiruchi has been instrumental for the designing the cover page of the souvenir, and Dr. Shayandeep Ghosh has been instrumental for past few years for editing the souvenirs. He has been collecting the articles, editing them. He has been a silent worker working behind the scene. So we thank both of them for their contribution to IPS West Bengal State Branch. Thank you them. Thank you both of them. So next we have the inauguration of Journal of Indian Association of So next we have the inauguration of Bengal Journal of Psychiatry, which is edited by Dr. Shujit Sarkhel. Shujita is not here amongst us. So I would request our chief guest, Mr. Abhijit Banerjee, to inaugurate the current issue of Bengal Journal of Psychiatry. I'd also like to call upon Professor O.P. Singh, editor of Indian Journal of Psychiatry, on stage for the inauguration of the journal. A big round of applause, please. Now I would request Dr. Rajarshi Guha-Thakurta to felicitate our chief guest, Mr. Abhijit Banerjee, SP of North 24 Parganas. Dr. Rajarshi Guha-Thakurta, please do the honor. Thank you. Side, thank you, sir. Next, the customary lamp lighting ceremony. I would like to request Dr. Ranodip Ranjan Ghosh Rai, our chief guest, Mr. Abhijit Banerjee, Dr. Gautam Saha, Dr. Sri Kumar Mukherjee, Dr. Ranjan Bhattacharya, all come together to light the lamp of the ceremony. Others also please join. Probita, Officer, Oshim Malik sir, please join. একটু ঘুরে দাঁড়ান, একটু ঘুরে দাঁড়ান। This is indeed a historic occasion for IPS West Bengal State Branch and IPP West Bengal State Branch that we are organizing such a beautiful conference, Psycon 2020, amidst this COVID pandemic. The pandemic is still at its height. So it is really commendable for the organizing committee who have put on all their hard works to organize such a great conference, both virtually and physically. Next, I would like to request our organizing secretary, Dr. Rajoshi Godhakurta, please felicitate Dr. Ranodip Ranjan Ghosh Rai. Ranodipda has been a great inspiration for all of us for many decades now. I would like to request Dr. Pinaki Sarkar to please felicitate Dr. Gautam Saha, Vice President cum President-elect of Indian Psychiatric Society National Body. Pinaki, please do the honor. Then I would like to request Dr. Rajoshi Godhakurta to felicitate our very own Dr. Sukumar Mukherjee. Sri Kumar Mukherjee, sir. I would like to request Dr. Jishnu Bhattacharya to felicitate our Honorary Secretary of Indian Psychiatric Society, West Bengal State Branch, Dr. Ranjan Bhattacharya. Dr. Ranjan Bhattacharya has served excellently for the last 4 years for Indian Psychiatric Society, West Bengal State Branch. Now we hope that he will be going to national platform and will serve the national society. Now I would like to invite our chief guest, Mr. Abhijit Banerjee, to say a few words. Acha. Acha, last. Okay. Okay. So, guest of honor. So as per the protocol, I would like to request Dr. Ranodip Ranjan Ghosh Rai, our inaugurator, to deliver a speech. So please come to the podium.
শুভ সন্ধ্যা।
Good evening.
আজ সাইকনের এই যে যৌথ সম্মেলন, যেখানে ইন্ডিয়ান সাইকিয়াট্রিক সোসাইটি পশ্চিমবঙ্গ শাখা এবং ইন্ডিয়ান অ্যাসোসিয়েশন অফ প্রাইভেট সাইকিয়াট্রি পশ্চিমবঙ্গ শাখা যৌথভাবে এই তাদের বার্ষিক সম্মেলন প্রতি বছরের মতো এবারও অনুষ্ঠিত করছে।
Today we are organizing the joint annual conference of IPS West Bengal State Branch and IPP West Bengal State Branch, like we have been doing for all the past years.
এবার প্রথম যেটা হলো, একই সাথে ভার্চুয়াল কনফারেন্স এবং ইন পার্সন কনফারেন্স একত্রে অনুষ্ঠিত হলো, যেটা এর আগে কোনোদিন হয়নি এই কোভিড 2019 অবস্থানের জন্য।
This is for the first time we are organizing this conference both in virtual platform as well as physically, which have never happened, but this took place only because of this COVID pandemic, because of which there is certain movement restrictions.
মাননীয় অতিথি হয়তো ভাবছেন যে এই কজন সদস্যকে নিয়ে বোধহয় অনুষ্ঠান, তা নয়। অনলাইনে প্রায় 100 থেকে 150 জন হাজির আছেন এই প্রোগ্রামে। আমি সবাইকে স্বাগত জানাই।
We are proud to have around 100 to 115 delegates, both present both physically as well as virtually. I welcome all the delegates.
একটু আগে সর্বভারতীয় উপসভাপতি এবং পরবর্তী সভাপতি আমাদের শ্রীমান গৌতম সাহা যে কথা বলে গেলেন, যে আজকে যুব প্রজন্ম সাইকিয়াট্রিতে যেভাবে কাজ করছে, যে উৎসাহ নিয়ে এসেছে, সেটা যখন শ্রী গৌতম সাহা শুরু করেছিলেন তখনও দেখেননি।
Like what Dr. Gautam Saha, Vice President cum President-elect of Indian Psychiatric Society National Body, just said that he has seen our talented and youngsters working so hard, and they are so much talented that he hasn't seen in his lifetime.
কারণটা হলো, আমি যখন সাইকিয়াট্রিতে এসেছিলাম, আমার মধ্যে এখানে প্রবীরদা আছে, আরো দু একজন আছেন, আমরা কিন্তু দেখেছিলাম সাইকিয়াট্রি তখন ডাস্ট সাবজেক্ট হিসেবে অন্ধকারে থাকা একটা সাবজেক্ট, যেখানে লোকজন আসতো খুব কম, সামাজিক সমস্যা অনেক বেশি ছিল। ক্রমশ দিনের পর দিন এগোতে এগোতে আজকে মনোচিকিৎসা এমন একটা জায়গা করে নিয়েছে যেখানে সবাই সাইকিয়াট্রি ডিসিপ্লিনকে মানতে বাধ্য হচ্ছে।
When I was a student, and seniors like Dr. Prabir Pal have always seen psychiatry as a dark subject, it was never into the mainstream. Very few people sought psychiatric consultation, but with the hard work of all the doctors, members of the Indian Psychiatric Society, Indian Psychiatric Society West Bengal State Branch, psychiatry has gradually placed itself into the mainstream of medical science.
দেখে ভালো লাগছে যে সাইকিয়াট্রি আজকে যেরকম জমজমাট অবস্থায় এসছে, হয়তো আরো কিছু বছর বাঁচবো, আরো জমজমাট হিসেবে একে দেখতে পাবো।
This has been a flourishing branch. People are seeking psychiatric consultation for various psychosocial issues, and the stigma attached to psychiatry are gradually dispelling. And I hope that this branch will flourish further.
সবাইকে শুভেচ্ছা জানিয়ে আজ এখানেই শেষ করলাম। ধন্যবাদ।
I thank all the delegates and I end my speech here. Thank you all. Now I would like to invite our chief guest, Mr. Abhijit Banerjee, SP of North 24 Parganas, on the podium. For knowledge of our chief guest, I'd like to inform him about the theme of our conference: neuropsychiatry, identity crisis or future identity.
Good evening. Good evening to all the honorable doctors and excellent human beings who are present physically here and who are also present in our virtual meeting. I must confess that I don't have that kind of expertise to deliver speech in this context. I don't have so much knowledge also. But we must appreciate that this is the most difficult section of medical science. You have to read the mind of the people. If we think of the medical science in health system, mental health, I think, is much more important than the physical health condition. In our service, in our domain, we used to see a major portion of the police force are suffering from the stress. They can't manage. We can't manage the stress, and that's why in paramilitary, in police, we experience that frequent case of suicide is happening. They are stout, they are physically fit, they don't have any physical problem, but due to the mental problem, due to the illness of mental, their mental health is not that such. That's why they are committing suicide. And I am welcoming all of you who have come here and honored us, honored our district. Our district is conducting such kind of conference which is related to a most important and pivotal issue of medical science. I must convey my sincere thanks and gratitude to Dr. Saha for providing me the opportunity and honored me to remain present here. And I am delivering speech before you. I don't have that kind of knowledge and that kind of credibility to do that, but it is an honor to me. I just want to say that police and doctors are the front liners during this period. Our society, our nation is facing a tough phase. We are going through a tough time. We know several doctors have made the supreme sacrifice. We must pay homage to them. We have also lost many police officials and many police force who have sacrificed their life on the line of duty. This phase has restricted us, has curtailed our liberty. Most of the people are suffering from the mental pain, agony. This time, the role of psychiatrist has become very, very prominent and important. So I wish all of you best of luck. I must congratulate your new president also. So it is a tough time. We must fight, and I wish you best of luck. I think we will be able to fight against this demon, and we'll come with the fine colors. Thank you all. আমি আবার সবাইকে আমার বেস্ট উইশেস জানিয়ে সকলকে আরো আমার তরফ থেকে ধন্যবাদ, আমাদের জেলা পুলিশের তরফ থেকে ধন্যবাদ এবং জেলার তরফ থেকে ধন্যবাদ জানিয়ে আমি আমার কথা শেষ করছি। থ্যাংক ইউ।
Thank you, Mr. Banerjee, for your wonderful speech and kind words. I'd like to invite the organizing secretary of Psycon 2020, Dr. Rajoshi Godhakurta, to deliver his vote of thanks. Dr. Godhakurta, please come to the podium.
कर्मण्ये बाधिकारस्ते मा फलेषु कदाचन मा कर्मफल हेतु कूर्मा संगहस्त कर्मणि. We have all heard this. We know the meaning. Today's program and this two-day program of Psycon 2020 organized by the joint amalgamated organization of West Bengal, IAPP and IPS, with the help of the local branch, Tamolipto Midnapur, which is still in its infancy stage, completing its 1 year tomorrow. I find myself opportunized, and with joy and pride, I would like to thank all the dignitaries on the stage and off the stage. And I would like to thank especially our chief guest, our guest of honor, Dr. Prabir Paul. Sir, if you please come on the stage. Okay, so hesitating, and all the virtual members who have joined. We have over 100 delegates. It is my first opportunity to organize Psycon 2020, which was supposed to be held in Digha, but due to certain restrictions, we had to move it to Monye Garden, Dr. Pukur. And by the endless efforts of Dr. Gautam Shah, Dr. Alok Patro, Dr. Ayon Maiti, and the entire organizing team, I would like a big round of applause for Tangadikya Midnapur branch. At the same time, I would like to thank the president of Tangadikya Midnapur branch, Professor Dr. Ashim Mollik, Professor Dr. O.P. Singh, both of whom are my teachers and my guides. And at the same time, I would also like to thank, because in the history of West Bengal for the first time, and maybe in this zone, under the aegis of such a local branch, which has been formed just in 1 year, with many youngsters coming tomorrow, both physically and virtually, it would not have been possible without the event management team under the leadership of Intelligent Communications, headed by Mr. Nityananda Datto, Mr. Shiraz De, Mr. Shushanto Shah, and all others who have been involved. I thank all of you, and we will now start our AGBM, and for that a separate link will be given to you. Thank you. We will now stand up for the national anthem.
I think people, or everybody in the home should also stand.
গঙ্গা জলধিত রঙ্গ শুভরা
Thank you, Rajoshi sir. And now the hall will be closed. So everybody please proceed to AGBM. Only the members are allowed. IPC members are allowed. So we have shared a special Zoom link already emailed. So kindly members, you check your emails and kindly proceed to the Zoom with the code. Thank you, everybody. We'll see you tomorrow at 8 o'clock. Thank you. Thank you all.